Okay. It's not expensive introduction.
Oh, is it? Yeah.
Good morning. So good morning, everybody, and a warm welcome to our 5th Paediatric Kidney Transplantation course. It's a delight to have you all here. Some of you have been before, some of you are new. It's great to see some old friends, some of whom have come a very long way across the Atlantic. We've got a fantastic day and a half, which we're really looking forward to. It's been a huge amount of effort put into this, very little by me, mostly by people like Peter, Hannah, George, Anna, and Nicos, and of course Jelena, whose course this really is. But every year she makes me stand up and take all the glory, so it's really her course, and we're very grateful to her. As usual, she's told me what I have to do, so I've got to tell you about where people are from. I don't know why it says get flags. What does that mean? So we've got delegates from 7 countries, from across the world, really. And we've got a combination of surgeons, nephrologists, nurses, dietitians, all sorts of people. And really one of the strengths of this course is the ability for people to have a chat with each other, interact with each other, and really act as a multidisciplinary team, which is essential in paediatric transplantation. This is being live streamed, so please don't swear, because people across the world will see it in real time. We can't edit it out. And be aware that you're going to be on YouTube, and you can go, I think, afterwards and have a look. And a big thank you to our sponsors, without whom, of course, this wouldn't have been possible. So we're really grateful for their support this year. Dinner tonight, 6 p.m. Coates Brasserie, which is just around the corner. If there are any of you who would like to come for dinner but haven't registered to come for dinner, then please see Jelena. It is officially full, but there may be some opportunities to get a few more people in. And I think that's all of my introduction. But I would like now to hand over to Emma, who's one of our patients. She was transplanted by John Taylor, who's sadly no longer with us, about 10 years ago. And she's now a medical student in Brighton. No? You're not a medical student in Brighton. Oh, well, you can tell us what you are, but she's going to tell you her story. Okay, Emma.
Complex conference PowerPoint.
Complex conference?
Yeah.
You've got the lapel. If you stand away from
Oh, there's nowhere to clip it, so
okay.
I can hold it.
Just leave it there, but don't wander too far.
No.
If you want to clip, that's backwards and that's
Okay, thank you. Hi, my name is Emma, and I was a patient at Gosh from 2005 until I transitioned to adult services at the Churchill Hospital in Oxford in January. I was born at 32 weeks, however, apart from the normal problems, it appeared that I was a healthy baby. Then at the age of 4, all this changed when my arms got pulled on holiday. I'd always known that I'd been short, but this was put down to me being born premature. However, this was now not the case, and this was when I first came to Gosh. I was referred to the orthopaedic department, and both me and my brother were diagnosed with a restricted growth condition, which was not achondroplasia, but they weren't sure what it was. From then on, I knew I was different, as I was shorter than my peers, but I lived a normal life, attending school and went to events for people with restricted growth conditions, such as the Dwarf Sport Athletics Games. This, however, changed when I started to become ill. I would be unable to eat food without throwing up, and I was constantly tired and just generally very ill. When I look back at old pictures, I looked ill for a while. The doctors at my local hospital diagnosed me with everything, from a bug I just picked up at school to Bell's palsy. Eventually, a doctor decided to try and take my blood pressure, but they couldn't, and this was when they discovered I had kidney failure. This is when I encountered my next department at Gosh, Nephrology and Victoria Ward. I was admitted to Victoria Ward for a number of weeks while doctors tried to get my levels stabilised and sort out medication. I don't really remember the period of time very well, however I do remember the nurses running out of ID tags to put on my teddy bears. It was soon clear that I would require a kidney transplant, so my family all got tested to see who could donate to me. Fortunately, my mum was a match and the date for my transplant was soon set. Unfortunately, I did not get to this point as a few months before my scheduled transplant I had to go on peritoneal dialysis in September 2009. I remember this admission to hospital very vividly. One day I was at a friend's house and the next day I was hooked up to a machine causing me a lot of pain. Luckily, my body became used to the dialysis and I was able to go home with my parents trained to use the machine. This, however, was not quite as straightforward as it seemed. When we got home, the machine wouldn't work. Luckily, one of the nurses from Gosh was visiting her parents, who only lived a couple of miles away. Finally, December 14th, 2009 came round and I was travelling down to Gosh to have my transplant the next day. The 15th of December is a day that will always stay in my mind, as it was the day that my life changed forever. As I had my transplant so close to Christmas, my transplant is extra special. It was lovely that everything was so festive, however the nurses did think it was funny that I was sat in my room with 2 fans on whilst it was snowing outside. My transplant changed my life medically, but also in so many ways. It has meant that I've been able to grow up, go to school and have some amazing experiences, such as going skiing with other transplant recipients and attending 9 British transplant games representing Gosh Renal. The British Transplant Games really are the highlight of my year. Not only do they help you to become active after transplant, they also enable you to make lots of friends. The games have also been amazing for my parents and siblings, allowing them to meet people in similar situations too. This December, Sunday, I am coming up to 10 years post-transplant, and touch wood, everything is going well, and in fact my transplant is the easiest part of my care to manage. I just remember to take my tablets every day and drink enough water. It is something a lot less medically complex that has caused me the most grief: psoriasis. I've always had problems with my skin. However, 5 years ago it began to get very bad and I was diagnosed with chronic psoriasis. My psoriasis has baffled doctors as it doesn't appear in the normal places and doesn't look like what you would call typical psoriasis. Unfortunately, because of my transplant, I am unable to take any medication that makes a real difference, as they would risk affecting my transplant. This is something that has caused me a lot of mental grief, as I have to try and use creams that don't help and accept that when I'm having a bad day I have to write that off. My psoriasis follows no pattern, which is one of the many reasons it's caused me so much mental and physical pain. I would like to take this opportunity to say that just because something may not be life-threatening doesn't mean it's any less painful or distressing for the patient. Luckily, my renal team at Gosh were able to coordinate with dermatology so that everyone knew what was going on. As someone with multiple complex conditions, you become the expert. I know what medications I have tried and whether something does or doesn't work. I'm also very sure of my pain levels and what to do if something isn't working. For example, having blood tests. If blood doesn't come out straight away, there is no point wandering a needle around and you're better off starting again. Having multiple conditions also means you have to transition to adult services multiple times. I have spoken a lot about transition, but I cannot fault my transition from Gosh. This was due to a number of things, including having a key person to speak to, a specialist nurse, everyone including my new team knowing how daunted I was about the thought of transitioning and taking things slowly and only moving forward when I was ready. This meant my new team coming to Gosh and going to young adult clinics just to see how it was run without having any tests done. It was also made a lot easier as I was allowed to stay with all my departments until I was 18, as the idea of leaving departments at different ages caused me even more stress. I really cannot stress how important it is when transitioning your own patients to take into account how they want to be transitioned and the feelings they may have around it. Although I am no longer a patient at Gosh, I haven't left. I've been a member of the YPF for the past 3 years, and I am one of the YPF representatives on the Council of Governors, and I regularly give talks to new nurses at the hospital. This really has helped to reduce some of my anxiety around transition, as I knew I'd be coming back to do lots of exciting things. I am incredibly passionate about getting youth voice into the NHS. I am a member of the NHS Youth Forum and have had some amazing opportunities to improve services for young people, such as being heavily involved in the long-term plan and also getting the opportunity to speak at this year's NHS Expo about diversity in the NHS and particularly how to get more people with lived experience into the workforce. Alongside my work in the NHS Youth Forum, I am also a lay member on NICE Guideline Committee looking at babies, children and young people's experience of healthcare. It is a real honour to have been selected for this role, as I know it's really going to help the treatment of children and young people in the future. I'm not a medical student, and in fact I'm studying childhood and youth studies at the University of Sussex with the hope of becoming a youth worker in the future so I can help other children and young people in hospitals who have complex health needs. So, why does all this matter? As I've described, I have had extensive use of Gosh over the past 12 years, and everyone at the hospital really did become like my family. I wanted to end my speech by highlighting what I think one of the most important things to help children and young people who've had a transplant. Talk about actual life. I knew that when I went into appointment at Gosh, I wouldn't just be talking about how I'd been medically since my last appointment. I would also be talking about school, my family, and if I've been on holiday. So I just wanted to finish by mentioning some of the things that I've done since I left Gosh that I wouldn't have been able to do without my transplant and the life-saving care they've given me. I passed my driving test, won a Diana Award for my contribution to young people, named after the Princess Diana, and is the highest award a young person can win. I went on holiday with my friends, attended my first transplant games at Oxford, but of course I still saw the Gosh renal team. Went on an outward bound weekend with a group of people I'd never met with climbing out, and I'm now studying at university after passing my exams. Thank you all so much for listening, and I hope I've given you at least a little bit of an insight into what it's like being a transplant patient.
Thank you so much, Emma, for sharing your trip over the last 12 years with us and inspiring us to continue doing our work. So that introduces us to the first talk, which is working up patients just like you for transplantation. So Maria Skynes, she is a clinical specialist nurse at Great Street, and she's going to tell us how she prepares patients for us. Sometimes it might take months or years, whereas the transplant may only take 4 hours or 3. Thank you, Maria.
Thank you, Nicos. Thank you, everyone, for asking me to speak today. So I've been asked to speak on paediatric recipient renal transplantation, the workup, how, when, and where. So as we all know, preemptive living donor renal transplantation improves the morbidity and mortality of children with end-stage kidney disease and is widely accepted as the gold standard for renal replacement therapy. So I've just pinched some slides from NHSBT just to look at paediatric kidney-only transplants in the UK since 2009, particularly looking at the differences between deceased donor and living donor, and how I think all of us are striving for a living donor transplantation. And then just another slide to look at the different units around the country and their activity. So just to talk about the GOS programme, the first living donor transplant was in 1990. Since April 2015, we've carried out 127 transplants, and that's till November 2019, 84 of those being living donor and 43 deceased donor. And these numbers include children from other centres, children in the sharing scheme, HLA incompatible and ABO incompatible transplants. We approximately have 100 recipients for workup at any time through varying degrees of CKD, and talked about 80 donors annually. As I said, we treat children from the NHS, from other centres. It says E112, but I believe that's now NHS2, and international private patients who are essential for our funding for the hospital. We deem that patients should be about 10 kilos for transplant, and it takes about 15 months, 16 months of age to get them to 10 kilos and to have received all their vaccinations. So just to look at our transplant activity since 2006, again recognising that we have more living donor transplants than deceased donor. So to look at the transplant workup for the recipient, we start with doing their blood group. Then we do their HLA typing, which we send to the clinical transplantation laboratory at Guy's, and we test their HLA antibodies. For living donor, we only do an initial cross-match with the donor if the recipient has the presence of HLA antibodies, they've had a previous transplant, or as advised by the transplantation laboratory at Guy's. And if it's going to be a donor blood group incompatible transplant, then we'll do ABO titers. All children should have received all their immunisations prior to transplant, so they'll have their routine vaccines, and then we ask them to have hepatitis B and varicella if they need it. Just to state, a recent change is that the hepatitis B vaccine is now included in the UK in the routine baby vaccines, but we're having to play catch up with those children who haven't received this, and GPs are now refusing to give their Hep B in the surgeries. So I think it's something the units are going to have to start taking on. As I said, if the children are varicella negative, we'll give them 2 varicella vaccines. And if they're measles negative following 2 MMRs, we'll give a measles booster. They should have a course of hepatitis B vaccines plus a booster, and they have antibodies greater than 100 mils per unit per mil. We check their CMV and EBV IgG, and if they're negative, we continue to check that every 3 months. And we check the Hep B and C antigen and HIV antigen, ensure they're negative. Other bloods, we do coagulation. If the coagulation is abnormal or they have a family history of bleeding or clotting disorders, we'll do a full thrombophilia screen and take advice from our haematology team. We do regular liver function tests, and if we deem there to be high risk of diabetes, we'll do a fasting glucose and an HbA1c. Looking at the imaging, we ultrasound the abdominal vessels, looking particularly at the IVC and the iliacs to ensure they're patent. It's our policy that all children under 20 kilos have an MRV, but they also have an MRV if they've had previous femoral lines, previous transplant, and if we deem there to be any occlusion or complex anatomy. We do a neck ultrasound if they've had previous neck lines. We do a yearly echo, or more frequently if they've got cardiac dysfunction. We do bladder ultrasounds to ensure the bladder is safe and empties to completion, and will it cope with the increased urine output post-transplant. And then think about, does the patient need nephrectomies prior to transplant, such as with FSGS. A lot of our children come to us from urology, so we work closely with the urology team to get a bladder plan prior to transplant. They may have a bladder fill assessment or go on to formal video urodynamics. We have an MDM. All the children are brought to MDM prior to listing for transplant, be it deceased donor or living donor. And if there's any urology problems, we invite the urologist to come along and agree a plan with us. We like to document the bladder plan, and annually the bladder plan is reviewed, or more frequently if need be. So other things, we encourage all patients to visit the dentist, to have healthy oral hygiene. An anaesthetist will review them at the MDM, but if we feel the anaesthetist needs an individual review, she will see them separately. We involve other specialities as needed, such as hepatology, cardiac or metabolic, particularly with the MMA children. Does a PICU or CICU bed need to be booked post-operatively? We book a PICU bed for any child under 20 kilos or complex problems, otherwise they come back to the ward. If it's a particularly complex child, we might ask for an extended theatre list, whereby we start the recipient before the donor. All patients must have MDT before proceeding to listing, and then the protocol signed off by the transplant consultant. We also insist that all families have psychological preparation and input prior to transplant. The psychosocial team will discuss practical aspects of transplantation, such as if one parent is a donor, that's taking one carer out of the family. If we have a single parent who's donating, does the other adult staying with the child have parental responsibility for consent post-operatively should something go wrong? They look at the care of the siblings, loss of earnings of the donor, and the impact on the whole family. And we also heavily involve our play specialist, who isn't Lindsay, Charlotte. We've got a new play specialist to help prepare the children. So nearer to the time of transplant, the family meet with the consultant transplant nephrologist in the pre-transplant clinic, and they meet with the transplant surgeon. They normally meet with the transplant surgeon more than once, and we have a weekly surgical clinic. The nurse specialists have ongoing discussions with the family, trying to prepare them for this time, and talk about the preparation and the process post-operatively, such as the follow-up, the medicines, plan for return to school, and just how difficult a time it can be initially. We then will confirm the transplant date with the lead surgeon, the family, and the ward. Once we have that date, we'll book a PICU bed if needed, email the team, book the patient hotel. If the donor's on site with us, we'll book a taxi so they can go over to Guy's early in the morning and do the final cross-match. And the patients can visit the patient hotel, the ward, and PICU if they want to. The week prior to transplant, they'll meet with the surgeon again and do the surgical consent. We'll do the final cross-match with the recipient and donor, a chest x-ray, finalise the admission plans, and then the consultant will sign off the protocol. And then all the results go to the ward. If we're activating a child on call, we just send HLA antibodies over to CTL, ensure the protocol's up to date, very similar to the living donor preparation. So we're met with many potential donors, normally in clinic. Jen and I will be the first port of call for them. So we'll take a basic medical history, ask if there's a history of diabetes, hypertension, talk about BMI, and then we'll register the donor with us. We'll do the blood group and the tissue type. And particularly when we do the HLA typing, we always explain what the test is, so we don't receive any nasty surprises, which you then may have to explain. We give them their transplant information pack, and we'll then refer them over to Anita, our counterpart at Guy's. If it's an overseas donor, we'll get the blood group done locally and either get the HLA typing done locally, but in some countries it's very expensive and the families can't afford this. So we get them to bleed them locally and send the bloods over. And they often do get lost in the post, but we usually get there in the end. Once we refer the donors over to Guy's, we make it very clear the donor must make contact themselves and book their appointment, so there can be no coercion on our part at all. And then all the donor work up thereafter is done at Guy's. We keep that very separate, so that, again, there's no coercion. We liaise very closely with Anita at Guy's. We hand over, I would say, weekly, sometimes daily. And then the donor will have thorough medical and psychological assessment, comprising initial discussion, the medical tests, bloods, ultrasound, GFR, CT, echo, ECG, and sometimes have to proceed to flexible cystoscopy and biopsy, meet with the nephrologist and the transplant surgeon. Once all this is okay and they've gone through MDM, the independent assessment we booked, where both donor and recipient and a representative of the recipient attends. So we always look at our service, we always try to make improvements, we continually audit our practice. We'll do a morbidity and mortality meeting for a death or an unexpected patient outcome. We constantly look at our preemptive rates because we aim for living donor preemptive transplant, and we look at whether any patients on dialysis who could have received a preemptive transplant and didn't, or are there any delays or barriers to listing on deceased donor transplant list. And also, are there any barriers to living donation, for example, fear, financial issues, or psychosocial issues that we can help the families with? As I've mentioned, we get referred complex out-of-centre and overseas recipients, regularly referred to us mainly from Scotland, Wales, Ireland, Europe, and the Middle East. The complexities of these children can include surgical challenges, comorbidities, complex urology, and particularly MMA. And just to mention, we've started an MMA collaborative network incorporating Great Ormond Street, King's, Guy's and St Thomas's, and Evelina. And each case brings its own challenges, both surgical, medical, and geographical. And there's an added dimension of another team in there that can sometimes lead to some communication difficulties and some delays. So I just thought I'd talk about the way forward. So firstly, to mention the National Living Donor Sharing Scheme, which I'm sure you've all heard of and all aware of. It was quarterly national runs, managed by NHSPT. And the scheme includes paired and pooled donation, where donor and recipient pairs are either HLA or ABO incompatible. 2 pairs is paired donation, more than 2 pairs is pooled donation, and an algorithm is used to match and maximise the pairs. Some families are very reluctant to consider the sharing scheme, so we have to spend some time sitting with them, explaining to them, and letting them know the very, very positive outcomes from this scheme. Also, in the paediatric population, we put limits on with the sharing scheme, such as age and mismatch. and we have to be aware that this can reduce the chances of being matched. So I think it's very important to assess each child individually, weighing up the risk. We get many calls from altruistic donors. So it's an anonymous, non-directed altruistic donor to a recipient on the waiting list. They can be registered into the sharing scheme and can start an altruistic chain. As I said, we get quite a few phone calls from people phoning up saying we would like to be a non-directed altruistic donor, and we direct them to the NHSBT website explaining how they should register for this. We've been doing some blood group incompatible transplants, which is transplantation across the blood group barrier. Before we proceed with this, we would advise a minimum of 3 runs in the sharing scheme first, and then we'll consider ABOI if the ABO titers are low. If we proceed, we draw up an individualised plan with the team regarding immunosuppression and is there a need for plasma exchange, double filtration, plasmapheresis, or immunoabsorption. We've also done some HLA incompatible transplants, and this is transplantation when the recipient antibodies are present against donor HLA. We could take advice from the clinical transplantation scientist, the nephrologist, and the adult surgical team, read the tailor-made immunosuppression protocol. And again, it's risk versus benefit. Is it riskier to leave a child on long-term dialysis with no chance of transplantation, or to proceed with a HLA-I with increased immunosuppression? So just very quickly, HLA matching. Historically, we've always accepted a 1-1-1 mismatch for living donor and a 1-1-0 for deceased donor. With the children on call for deceased donation, after a year, we reduce their criteria to **1 = 3. So that means we'll accept a 1 or 2 antigen mismatch on the A or B, but only 1 on the DR, but it still equates to a 3 antigen match. With living donation, we're looking more at accepting 2 antigen matches from a fit, healthy donor after discussion with the team and the family. And with deceased donation, if the child proves difficult to match or has very limited dialysis access, which we're seeing more and more with people returning from transplant, we're enlisting initially for a **1 = 3. And social media campaigns, I think, is the biggest change that we're seeing. It's becoming increasingly popular. The HTA state it is not illegal to advertise for an organ as long as there is no offer of reward, payment, or material advantage, and this can incorporate directed altruistic donation. We've had 1 child who's successfully transplanted from a social media campaign, and we have another donor who's just been referred to Guy's for one of our children, again through a social media campaign. It's a lot of work because you get a lot of donors that come to you initially, maybe 10, 20 for 1 child. And lastly, our best initiative is we've started a theatre open day with the cardiac team. And every 3 months we invite children and their families to come to theatre where they can dress up as a surgeon, they can scrub, they can pretend to stitch, cannulate, play with the surgical instruments. And the feedback from this day has been fantastic. 1 child went down for a transplant a week after her open day, and she said it just relieved her anxiety hugely. Thank you.
Thank you very much, Maria, for a very thorough and clear talk. I would like to ask you if you have any questions or comments. We also want to hear what you do in your units. It's a great opportunity in this meeting to do that.
Thanks so much. Great talk. What proportion of your patients, or how many HLA-I incompatible transplants have you done, and what type of patients are you doing the HLA incompatibles in?
I might direct that to 3, thank you. Yes, we've done 3 HLA-I. Sorry, what was the second part of your question?
Why are you doing them? What's the reason? Are they overseas patients?
No, they're in-centre patients. We take advice from CTL as to whether it's high risk or historically positive. Do you want to answer, Nizam? Do you want to speak?
Yeah, one of them was from Ireland and had been in the sharing scheme unsuccessfully. I think it's, as Maria said, it's a balance of risk versus benefit. If they're running out of access, if we think an HLA incompatible transplant is relatively straightforward, and we'll risk assess them in a number of ways. and if the alternatives are limited, so if they're very highly sensitized and therefore their chance either in the sharing scheme or on the deceased donor list is limited, then we will consider it. But it's not that common, and on the adult side, we've seen the number of HLA incompatible transplants falling quite dramatically.
What do you call an HLA incompatible?
We would define that as someone whose baseline cross-match is positive. So a DSA positive, cross-match negative, we're not too concerned about. We think that's okay. Give them some slightly stronger immunosuppression, normally Campath. But an HLA incompatible is someone who has a positive cross-match.
Is this a historical or a present?
Current.
Current. Okay. Now, do you use complement fixation to see if this cross-match positive has complement fixation?
So we don't typically test for C1q antibodies, if that's what you're driving at. C4.
Yes, C1q, sorry.
C1q. My understanding is that the evidence about whether or not C1q is a risk factor is variable. There have been some studies suggesting that if you have C1q positive antibodies, you're at increased risk, but equally some saying that that's not true. So we have looked in our paediatric population. I don't think Livy is here because she did the work, but I don't think she found any correlation.
Thank you. And I'll show you some slides later on about the number of incompatible transplants that we have done. Thanks.
I just wanted to ask from Leeds how you deal with those social media campaigns. We've just had one recently and had 500 inquiries in the first couple of days.
Well, luckily we haven't had 500, but we have quite a lot. And what we do is ask them to provide their blood group. And if they're blood group compatible, then we'll do HLA. And then if they're
So
HLA...
how do you choose which ones? Because
the ones who are, well, out of the 20 that we've had, only one was blood group compatible
Right,
with a
okay.
3 antigen match. So that sort of weeded it out. And then we put a stop on it. So after about 20 or 30, if we've got 1 or 2 potential donors, we just take their details and say, we have enough, we'll deal with what we've got, and then we'll contact you later. Because it's so time consuming.
Just eliminated the waiting list. Well done.
We try.
It's a very interesting question and point. I'm on the council for the British Association for Paediatric Nephrology, and it's something that we're discussing because it actually varies hugely. Even though there's only 13 paediatric nephrology centres, of which 10 do transplantation, some centres have a policy where basically they give out the number for the ward. And there was one centre, which I won't mention any names, but as you said, basically the phone lines just didn't stop. So there's a feeling that we'll say that we'll probably only look at the first 10 that come forward and then do it in runs of 10. But obviously we direct people to NHSBT because if MD wants to be an altruistic donor, then they're still able to, whether it's directed or non-directed. So we would want to encourage people coming forward to not use it as a negativity. So we had one patient who was on ITN News, and literally there was 100 phone calls to ITN, which happened after that.
Yeah, so we developed an appeal website. We've learned from a previous case, so we've devised an appeal website, which this family that recently went on the news locally and stuff, they gave out this appeal website, so all the potential donors were emailing that, so it didn't take our phone calls out of the way. But yeah, there was 500 inquiries. Out of that, 50 have returned a health questionnaire.
That's good.
So yeah, it's just then how do you move forward with, and hopefully we'll have a lot of altruistic donors from it who aren't compatible. But
Thank you. Thank you very much, Maria. Oh, one more question, sorry.
What do you do with family that don't want vaccination for their children? Will you transplant
We don't
them?
proceed to transplant.
Thank you. So I would like to invite Imran Mustak to give us a talk on blood augmentation as well as nephrectomies. He's a urologist and a professor from Great Ormond Street. Thank you very much, Imran.
Do I need this? You need a mic. Okay. Backwards, forwards. Backwards, forwards. Thanks. Good morning, everyone. And firstly, I just want to thank Jelena, Nicos, Nizam, who's left. Very good timing. He's gone. So thank you very much for asking me to. Oh, there you are. I just thanked you for inviting me to come and join this symposium. Invite me. There you are. So thanks very much. And my intention was to make this quite an interactive session. And I've just realised you've already got a copy of my lectures, so there's going to be no big surprises, certainly. But I think it'd be really, really helpful to make it interactive, because what we're going to be discussing is not just the timing of bladder augmentation, but actually how to assess and how to render a bladder safe to receive a transplant. And the reason why I think it's important to be an interactive discussion is because it's very complicated, it's not easy, and very much individualized to each patient. And what I hope that you'll be able to understand and experience from my talk is the complexities and the nuances of how to render a bladder safe to receive a transplant. The first couple of lectures are just really about native nephrectomy. It's very, very straightforward. And then we'll move on to talking about bladder augmentation and other techniques to make a bladder safe. And the way I've done it is I've got illustrative cases, because that makes it much more interesting and more representative of what we see day to day. So just a few slides just about native nephrectomy, because it's not something we do very, very often. The typical groups of patients we do that on is obviously the majority of patients are the nephrotics, the congenital nephrotics. So this is a group of patients who often have got quite severe proteinuria, who would benefit from a preemptive bilateral nephrectomy prior to receiving their transplant. The other group of patients are those who may have quite significant reflux, who are having recurrent urinary tract infections, where they're getting refilling of their bladder from the refluxing urine, and that's causing recurrent UTIs. And the final group are those very rare group of patients who may have predisposition syndromes. Some of these patients will have an underlying nephropathy as well, so they often will have a double reason for needing native nephrectomy. So this is a typical example of a patient, a 4-year-old girl who's on dialysis already, and got very, very severe proteinuria, got nephrotic syndrome, and is ready for transplant. So this is your typical patient that often gets referred to us prior to having their transplant for preemptive nephrectomies. Now, I'm sure everyone does it slightly differently, but this is the way we do it. So we've developed a way of doing it laparoscopically. Now, if the patient's on peritoneal dialysis, then obviously you cannot do it transperitoneal. You can't go through the abdomen. You can do an open operation. You can do bilateral flank incisions, stay outside the peritoneum to keep the peritoneum intact for their dialysis. But we tend to do it laparoscopically, so we go from the back of the patient. So the patient is lying, as you can see, the patient's lying prone, and then we go from the back. We using a balloon, we make a space around the kidney, drop the kidney forward, and then take the kidney out. So it's all done very straightforward laparoscopically, and it means the patient can then resume peritoneal dialysis within a day or two. We tend to rest the peritoneum for about 2 days and then resume peritoneal dialysis. So it's a very nice and elegant way to do the nephrectomy. It can be difficult in certain cases. So when you've got a very, very small child, the kidneys can be quite large and bulky, so taking the kidney out can be quite difficult. And these nephrotic kidneys tend to be quite hard and gritty. So it's not an easy thing to do, and it does require good laparoscopic experience to do it. But that's typically how we do our nephrectomies in most of the nephrotics. This is another example of a patient who's 16, who's a typical valve, a sort of teenage valve patient, who's got ongoing high-grade reflux on the right side. He's had his transplantation done, the transplant's working fine, and he's also had augmentation and stuff. But this patient is now getting recurrent urinary tract infections. Not a common scenario, but we do see it, and we're often faced with a dilemma here. Are the recurring infections due to the reflux into this native kidney, or are the recurrent infections due to poor compliance? Because we know that sometimes these teenagers, their compliance can be quite an issue. So this is a case where we may need to consider doing a native nephrectomy. And again, this is something we probably would think about doing laparoscopically. This is another example of a patient who, again, we'd consider. So this is a patient who's got very early onset hypertension and renal failure. The key thing here is the child's also got very ambiguous genitalia and severe proteinuria, and the child is 46XY. So what condition is this child likely to have? First bit of interaction. What's the underlying condition this child most probably ambiguous? Sorry? Dennis-Strash, yes. So Dennis-Strash, Frazier syndrome, spectrum. So early onset of renal failure with ambiguous genitalia, and a female-looking genitalia, but a male karyotype. So this is a very rare case, but yeah, Dennis-Strash is what you consider. So these patients obviously have a very high risk of developing Wilms tumours, and my understanding is that if you do a transplantation and you immunosuppress the patient, then you may increase the risk of them getting Wilms tumours even further. But certainly this patient would need to have the gonads removed because they're often dysgenetic and they can develop gonadoblastoma quite early on. So this patient would need the gonads removed and the kidneys to be removed. And the dilemma here is a patient's often on PD, and then how do you get the gonads out if they're intraperitoneal, if they're intra-abdominal? So 2 reasons to take out the kidneys: the tumour risk as well as the proteinuria risk. So moving on now to the interesting bit of the talk, which is all about how to assess or how to render the bladder safe. Now, it's not an easy thing to do, as I've already mentioned, and of course all of these patients who are heading to transplant will have a detailed bladder assessment. Now, there are 2 types of assessments, as we know. There is the non-invasive, where our nurses will do flow rates, they'll assess residuals, the voided volumes, etc. So that's your non-invasive, and then you've got your more invasive urodynamics. Now, we do not routinely do urodynamics, invasive urodynamics, on every transplant patient. Obviously, we do non-invasive assessments, and often it's not just one assessment. These patients will have had probably many assessments leading up to the transplant, so you'll get a fair idea of how their bladder's been behaving, and then obviously you'll decide selectively which patients need invasive urodynamics. So I'm not going to go on to that too much, but just to illustrate that we do obviously assess bladders very, very, very carefully, but not every patient would necessarily need an invasive study. And then when you're deciding on what sort of operations these patients need to do, these are the sort of factors that you have to put into your mind of, what you need to be thinking about. So the age of the patient is obviously very important. So if the patient is 2 years of age, that's very, very early to be doing an augmentation. So you need to consider other things to make the bladder safe. You need to look at their underlying condition. How severe is their degree of renal failure? Have they got plenty of renal reserve, or actually have they got very minimal renal reserve? Because of course, if you do a major bladder reconstructive operation, they may go from being stable to going into end-stage renal failure and needing to go on to urgent hemodialysis. So it's really important to look at how severe is their level of CKD, and obviously discuss that with your nephrologist. Urine output. You've got to know what is their urine output in terms of, are they oliguric or are they polyuric? In order for a patient to have a bladder augmentation, they must have a good urine output. I know that there are studies saying that you can do an augment in a dry system, you can cycle the bladder, but that's something we've never done, and I would not encourage anybody to do that, because I'm not convinced that that's the right way to do it. If you do an augmentation and there's not good urine flow, there's not good cycling of that bladder, the bladder will never achieve the capacity it needs to achieve. So you will not achieve what you've set out to achieve. It will not necessarily be a safe bladder. So it's very, very important that if your patient is likely to need augmentation, you must do that whilst they've still got a good urine output. It's absolutely essential. You need to look at history of UTIs, if they've got reflux or not, and how severe is the reflux. Are they on dialysis or not? Are they on PD? Because obviously if a patient is on peritoneal dialysis, you cannot do a bladder augmentation and then resume peritoneal dialysis. You cannot do that. They're going to have to be on a period of hemodialysis and then probably go on to transplantation. So these are all the subtleties. And you must not ignore the family and social issues, because of course these patients have really been through the mill, some more than others. And with that comes a lot of stress, anxieties, and the ability of families to cope. Despite all the hard work that our teams do, and their specialists, our psychologists, some of these sort of issues that arise are just insurmountable. So you must not put the family into a situation where they're actually going to be more stressed and not be able to comply with what's required from some of these surgeries. So I've got a sequence of cases. I'll try and go through these quickly. So this is a typical example. 6-year-old prune belly syndrome who's got severe reflux, fairly severe renal failure, who's having recurrent urinary tract infections. He's got a low GFR, but the urodynamic assessments show he's got a large capacity, poorly contractile bladder with big residuals. So he's 6 years old, he's got a big capacity bladder. What are the options here? Because he can't catheterize, he won't catheterize, he's got large residuals, so you need to give this child a safe system to receive a transplant. So what would you do? You have the answers, I guess. So this is a patient we'd probably consider for a Mitrofanov, right? So this patient probably does not need an augmentation at this stage in time. He's got a good capacity bladder. It's not contracting effectively enough to give him complete emptying, and that's why he's got bigger residuals. So this is a really typical case where we do a Mitrofanov. It gives you complete control. Often these patients are quite polyuric as well. So it's not just the daytime emptying, but it's also the nighttime. They tend to be very, very polyuric at night as well. So they're producing very large volumes overnight. So Mitrofanov here will allow that bladder to be emptied regularly, and if you wish, you can put the patient onto overnight drainage. So Mitrofanov alone is an elegant solution for this particular patient. Here's another example. So this is an 11-year-old child with VACTERL, and often with VACTERL syndrome, you will see children have got renal problems as well. This child's got a solitary kidney, severely hydronephrotic. The bladder assessment here shows something different. It's a small capacity bladder. It's poorly compliant. There's no reflux. Advanced renal failure. He's fecally incontinent because he's got an anorectal anomaly. So you need to factor that in. He's got an anorectal anomaly. There's poor compliance with the bowel management issues, and there's a lot of social issues. So this patient needs a transplant. So what are we going to do for this 11-year-old boy who's got a solitary kidney, he's got a hostile bladder, and is fecally incontinent? So what are the options? Silence. No interaction. An ACE. Yep, absolutely. So an ACE would help him in terms of his bowel management, absolutely. That can be considered, definitely. I mean, you can try an ACE, you could do peristeen washouts, whatever you like, but yes. But in terms of the bladder, this child's going to need transplanting within 6 months or so, let's say. But could you transplant into that small capacity, poorly compliant bladder? Not really. So what is the most likely thing you want to do for this individual? Augment, yeah. So absolutely. So this patient, he's 11, he's a good age, he hopefully should have good compliance, so a bladder augmentation would be the most logical thing to do here. The things that are difficult here is there's a lot of social issues. The child is fecally incontinent. He might become better continent if you do an ACE or peristeen washouts, but there is a background of a child in a family where there's lots of other children, there's a lot of compliance issues. So your ideal, of course, would be a bladder augmentation. But these are real patients, by the way. No name, but these are real patients. So this patient, we wanted to do a bladder augmentation, but actually there was no way this family would cope with it. The child's got some learning difficulties as well. So what we've ended up doing is a cutaneous left end ureterostomy. And what that's given you is some stability of that kidney, because the child's got very advanced renal failure and hydronephrosis. So he's not ready as a patient and as a family for augmentation. So that's the option for this patient here. And then once the child is more able to cope with bladder augmentation, then you can consider augmentation later on. 15-month-old child with bowels, high-grade reflux on the right. This patient's on peritoneal dialysis already. Again, he's got a relatively safe bladder, but he's having recurring UTIs because he's got reflux, so he's refilling his bladder, and he's getting recurring urinary tract infections. The family have tried CIC, but have not been able to sustain it. And every time the child gets a urinary tract infection, the creatinine goes up, as we commonly see. So he's got a good bladder, but his problem is recurring infections and unable to do CIC. So what can we do here? He's 15 months old. Would we do a bladder augmentation? Too young. So what can we do? What are the two options for this 15-month-old? Remember, he's only very little. He's still in nappies.
Refluxing ureterostomy.
Yeah, exactly. So your options would be a vesicostomy or a refluxing right ureterostomy, exactly. So vesicostomy is what people traditionally comes to mind. The problem with a vesicostomy then is that you lose the ability to some extent to be able to assess the bladder later on. So if you do a vesicostomy, then at some point in time you're probably going to have to close that vesicostomy and then reassess it. What we would do probably here is exactly that. You do a refluxing right ureterostomy. So that allows the bladder to cycle. Urine comes into the bladder. Some urine typically may come per urethra, but any excess should hopefully come back via the refluxing right ureterostomy. So that will render the system somewhat safe. It should reduce the infections, and then you can transplant into that system, into that bladder. The child will continue to reflux from that ureterostomy. And then at a later date, if you wish, you can close your ureterostomy and reassess the bladder. At least the bladder is intact, and you can assess it in some way. You may be able to occlude the ureterostomy and then reassess the bladder again. So at this young age, a refluxing ureterostomy is a nice way to render the system safe as an alternative to a vesicostomy. But you need to have good going, pretty high-grade reflux for it to actually work. 2-year-old girl, bilateral renal dysplasia. The key thing here is the early onset anuria. So she's almost anuric from the very beginning. She went on to PD very early on and then has received a transplant. So we assessed the bladder relatively, literally on the table. Nicos, you remember these patients. These are real patients, which is why they're so interesting. So we decided in this patient that we'd transplant into the native bladder. We assessed it on the table. It seemed reasonable. And what we would do is we would transplant into the bladder, but we leave a suprapubic tube as well, just as a sort of as a way of having some control over the bladder, should it demonstrate itself to be hostile. So she got transplanted into her bladder. Her bladder continued to function reasonably well. The graft function remained good, but she remained incontinent day and night. And then about 8 years following the transplant, we then noticed her creatinine starting to go up with some new onset hydronephrosis into that transplant kidney. So she's had a good 8 years of good renal function with the transplant. So what do we do now? She's been okay, but now we're starting to see some concerns in terms of her creatinine and her transplant kidney. So what do we do here? So her bladder is still small. It's still small. She's voiding very, very frequently, and so her capacity is probably about 150 to 180. So relatively small for a sort of a 10-year-old girl. The compliance, the compliance is reasonably good, but it's small capacity. So it's not high. It's not a necessarily high pressure system. But what we did here was we actually put a catheter in and drained the bladder for about 2 weeks, and we noticed that the hydronephrosis, because she had no hydronephrosis for many, many years, and then developed progressive hydronephrosis. So what we do in these situations, we put a catheter in, urethral catheter, drain the bladder for 2 weeks, reassess the creatinine level. The creatinine improved a little bit, but what was striking was the hydronephrosis completely went away. So that tells you that if you take the bladder out of the equation and the hydronephrosis goes away, then the bladder is hostile. So it's a small capacity bladder. The compliance is not too bad because she leaks, you see. So in this patient now, she needs an augmentation. So this illustrates that actually she was actually very, very good for many, many years. But then ultimately, as she got a bit older, the bladder then became, the system at least became hostile. Now why after 8 years that happens, who knows? So she didn't need augmentation or any options initially, but then subsequently now she needs augmentation. Another patient, 18 months old, bilateral renal dysplasia, bilateral ectopic ureters. And that's not an uncommon thing, that patients often can have renal dysplasia with ectopic ureters. The whole system's abnormal. Advanced renal failure on dialysis, minimal urine output, and a tiny, tiny, tiny bladder on cystogram. So when you have ectopic ureters, you'll often see that the bladder is also very small. It's never ever cycled properly, and it's really, really small bladder. So this patient here, this is what we'll do here. So when she needs her transplant, she's only 18 months old. You can't transplant her into the bladder because the bladder's too small. So she is one of those rare cases where we're doing end transplant ureterostomy, and that will give time for the transplant to bed in, for it to function well. And then much later on, we would do what's called a neobladder, because her bladder is probably so small you probably couldn't augment it. So you can't transplant into that bladder, it's too small. You probably can't use it for augmentation. And then later on, when she's older, maybe when she's 8 or 10, you'd reconstruct her a new bladder, and then you take down your transplant ureterostomy and then implant it into the new bladder. We try and avoid that as much as possible, but these are one of those occasions where I think there's no other option.
What would you make it?
Sorry?
How would you reconstruct it? What would you...
Oh, how do we do a neobladder? So a neobladder, because obviously in a typical augmentation, you have your native bladder and you join intestine onto it, normally small bowel. When you don't have any bladder, you use you take a piece of colon. So you take a piece of colon, so you do a colo-ileo neobladder. So you take a piece of colon, and that you use as your backplate to implant your transplant ureter. Colon is slightly thicker than ileum, so it's very difficult to do like an anti-reflux tunnel in ileum. So you take a piece of colon. People used to use stomach, like 25 years ago. They used to take a piece of stomach. Now we use colon. So you use colon for the backplate to join your ureters and to join your Mitrofanov, and then your capacity you create using ileum. So you take a piece of small bowel, piece of large bowel, and that's how you do a neobladder. And they tend to function very, very well. Here's another example. A 10-year-old boy with valves who's got end-stage renal failure, been on PD for 4 years. He's polyuric, as typical valve patients are, which is very good. He's got a good capacity bladder, but he's got poor compliance. So it's a very sort of poorly compliant, stiff bladder. It's good in capacity, and he's ready for transplantation. So what we would do here. Now, because remember, this patient's on PD already, so you can't do a bladder augmentation, okay? So this patient needs to be switched to hemo. You then do your bladder augmentation, and then ideally we would want to wait 6 months, okay? But that's not so easy. So, you know, in terms of you don't want to keep them on hemodialysis for too long. So you do your bladder augmentation, and then maybe at about 3 months you'll be able to augment into that. Okay. So they often, even though they're on hemodialysis, they're still often producing good volumes of urine, is what our experience is. So you need to put them onto hemodialysis, you do your bladder augmentation, you continue with hemodialysis, he'll hopefully have a urine output from his native kidneys which will give you good capacity of your bladder augmentation. Ideally, you want to wait 6 months, but in some cases, you may be able to do your transplantation at 3 months. Okay, so this just illustrates it's not easy. It's very complicated, the decision-making process and the sequence in which you do things. You can't do an augment without putting him onto hemodialysis because he's already on PD. A 9-year-old girl, recurrent urinary tract infections, bilateral reflux, scarred kidneys. Again, a common scenario that we'll see, you know, in our MDMs. She's on CIC. She's got a good urine output. but she's still having intermittent urinary tract infections, and every time she gets her creatinine goes up. Her assessment shows she's got a trabeculated, thick-walled, poorly compliant bladder. So that's, again, not an uncommon situation. So that's a hostile, nasty bladder. Now, because her GFR is really quite low, what you need to do is you need to do a planned bladder augmentation with hemodialysis backup. And why I'm saying that is because certainly, you know, hemodialysis beds are not available at the drop of a hat. So you need to make sure that you've got everything set up, that should she go into end-stage renal failure in the week or so following her bladder augmentation, that you've got the hemodialysis backup ready. Okay, so it's not just a matter of doing it. This requires a lot of planning between urology and nephrology and dialysis. So just for those who have not seen what a bladder augmentation looks like, this just gives you an idea. So, sorry, the pointer's not working. So the top left, that small thing is, is that working now? Don't work. I think it's the screen. So the top left is the native kidney being taken out, and then the middle picture shows what we firstly do is we harvest the appendix. So the appendix, and that's the appendix on its pedicle, just there. And then in this picture, what we're doing is, so this is the bladder that's been opened up. So you bivalve the bladder, and then you implant this is your mitrophonos. The appendix, you create a submucosal tunnel to create a sort of an anti-reflux mechanism. And then you implant your appendix into that. And then in the top picture there, you're harvesting your piece of small bowel. And once you've harvested that, then you open it all up. So you're looking at the inside of the small bowel. And then it's a matter of then joining on. So this is the front plate of the bladder. That's the ileum joined on. There's the appendix going to come out in the right iliac fossa. So that's what we call a clam. It's like a clam. You clam the bladder and then join the small bowel onto it to create your additional capacity. And then this is the finished product, basically. So that's the mitrophonos where the patient will do the catheterizing through. And then that's an additional catheter, obviously, to drain the bladder. So that's basically what we do when we do a bladder augmentation. And that's what it basically looks like for those who have not seen one. So, my last slide. So what I've been able to illustrate that actually, you know, it's very, very difficult in these patients to decide what to do. And it requires a lot of careful thought and interaction and discussion between urology, urodynamics, nephrology. You know, you don't just do something without discussing it with the rest of the team. And, you know, it's very, very individualized in each patient. But the key message is that you must take away from this is in order for the patient to get a bladder augmentation, they must have a good urine output. They must be an appropriate age where the child is going to be complying with the intermittent catheterizing and the family are able to do it. And there must be enough reserve in terms of kidney function that your surgery itself does not push them into end stage. And if you think that might happen, then of course you need prior discussion and arrangements for a hemodialysis backup should you need it. Thank you.
Thank you very much, Imran. That was an excellent talk on a difficult topic.
Very difficult.
Thank you. Any questions?
Thank you very much for all these interesting cases. I don't know if you have contact with other countries, but I have the feeling that urologists are much more conservative in treating children with bladder complications. The last years we almost never perform augmentation anymore. It's always catheterization, medication, even nightly bladder catheter, and just try to not augment the bladder. It's that.
No, contacts with people, a lot of people in Europe and around the world, and that there are some countries where I visit and I go to, or we have fellows coming to us where they say years. So I think that our patient groups are probably very, very similar. But you are correct that many centres in Europe have very, very high thresholds for going to bladder augmentation surgery. That is the case, whether it's just a population thing that don't like bladder augmentation, whether it's the institutions. There are some countries where a lot of bladder augmentations are performed, little pockets, but you're right. I think in Holland, people are very, very conservative, but seem to be successfully conservative. I don't know. I mean, I don't know what happens to those patients who then go into the teenage years and into adult life. Do they then, or do they stay conservative? Don't know.
Thank you very much for your talk. I just wanted to ask you, what are the options for the sites for Mitrofanov? Because they seem to always be perfectly sited in the middle of the transplant sky.
Yeah. So you're right. Some of us do try and have a discussion well in advance with the transplant surgeons. You know, we work very closely with our transplant surgeons. So, so we will always try and discuss it with them. The preference is always right iliac fossa, and having it in, the other option is putting it in the umbilicus, which I don't think is not an ideal place to have it. Most children seem to prefer it in the right iliac fossa. But our experience has been that I don't think our transplant team have ever had a problem where they've accidentally caused damage or inadvertently transected the Mitrofanov. I mean, Nizam and Nicos, you can say, but one of us, whoever's done the augmentation, generally knows the patient's coming in for the transplant. So that's patients who have transplant, obviously post-augmentation. But I mean, what do you want to say? Do you have any problems? Rarely. Do you think the right iliac fossa is a better place? Because that's typically where you'd put your transplant as well.
We prefer it on the left, but right is okay. We could go on the left.
And what do? You just catheterize it, you just move it out the way, don't you?
So if it was on the right, if we were doing a retroperitoneal approach, we'd probably go on the other side. If we had to go on the same side, which happened recently, I think you were on standby.
Yeah.
Then you just dissect carefully around it and get down to it. But you're right. I can't recall us ever having damage to Mitrofanov.
Yeah, but I think the right is probably best. I think it's better than umbilicus. I'm not sure having umbilicus makes your life any much easier. Not necessarily. Sorry.
Great presentation.
Thank you.
Two things. Can you describe your post-augmentation care?
Yep.
Because as you know, all these patients have a lot of mucus.
Yep.
And a lot of these bladders don't contract. So we're not friendly with augmentations, but we'd like to know your experience in the post-op care and your incidence of urinary. Can you comment on ureteral bladder augmentation?
Ureteric, yeah. So yeah, I mean, the aftercare of these bladders is obviously very, very important. These patients do produce a fair amount. In the first sort of 3 weeks after the augmentation, they produce a lot of mucus. So these catheters, the nurses teach the families to flush the catheters and do a very gentle lavage. You can't obviously put 100, 200 mils into a newly reconstructed bladder. You do very gentle lavages. And then I think once they get, let's say it's been a month or 2 months and they're catheterizing regularly, then most of them would be doing a washout.
What is regularly?
Once a day, but with about 50 mils of saline. I mean, it's very individualized to each patient. So some patients produce, so I think in the first 6 months, most patients would do a once a day 50 mil lavage with saline. That's what I think most patients would do.
Do you use mucomist?
No. I mean, they typically, the majority just use normal saline, basically. Some patients produce, obviously, more mucus than others. Our nurses find that patients who have a lot of dairy, a lot of milk, a lot of yogurt, they can produce more mucus than others. But, and some patients may need to do washouts twice a day, but I think the majority of patients would do it once a day or only do it twice a week.
How many times you catheterize throughout the day?
So they typically, initially, would be doing every 3 hours during the daytime, let's say for the first 6 months, because the bladder takes time to increase its capacity and to grow. So in the first 6 months, they'd be doing it every 3, maximum every 4 hours. And for the first 6 months, we keep them on overnight drainage. So that's a period of time while the bladder is increasing its capacity. So overnight drainage for the first 6 months, CIC every 3 to 4 hours. And then at 6 months, if your assessment shows that the capacity is then big enough, usually it should be about 300-400 mils, then they maybe have to come off overnight drainage, so they don't have any overnight drainage. Some of the valve boys, not all of them, some of the valve boys still remain very polyuric overnight, so you couldn't take them off overnight drainage. So some of them, even after augmentation, even though their bladder capacity is maybe 500 mils, they may be producing more than a litre overnight. So you have to bear that into factor. But the typical management would be, in terms of minimising recurrent infections, not all our patients are on prophylactic antibiotics. If they've got good regime for doing catheterizing, for doing washouts, but if they do get recurring UTIs, then of course you need to assess their compliance, make sure they're doing mucus wash. You may put them onto prophylactic antibiotics. And some patients, not many, despite everything you do, still get recurring infections. Everything is perfect. And then you might go to doing gentamicin. You could do a gentamicin washout with gentamicin. That's very rare. Divyesh, do you want to say anything? Because Divyesh is out.
No, I agree. I think, there are the odd patients every once in a while who, despite all possible measures and instituting all correctable measures, continue to get recurrent UTIs. And it's very frustrating. It's very frustrating for us. It's very frustrating, obviously, for the patients and most importantly for our nephrology colleagues.
That was excellent,
Thank
Imran. I was going to ask you, well, one statement, which is the fact that be careful when you're doing a bladder augmentation before transplantation, that you have good anemia management, because you don't want to give a blood transfusion and then sensitize against the living donors we've had historically. So just everybody beware. I was going to ask you because it varies a lot in London and nationally and internationally, what is the minimum investigations for somebody who doesn't have a bladder issue? Should they have non-invasive urodynamics if there's been no instances, but if they've got congenital anomalies of the kidney and urinary tract? And what is your view about those that are anuric? Because many people do inject dye and do micturating cystourethrogram in dry bladders.
Yeah. So, I mean, Divyesh can add, but I think the patients must have at least one, but ideally a sequence of bladder assessments to see what's been the change or if the situation's stable. I hope I'm correct. I said I don't think we do invasive in every patient. We do it very, very selectively. I think the small bladders are really difficult. The patients who have been oliguric or anuric from a very early age, within a few weeks, some produce a bit of urine and then they stop. Some have never produced urine. Yeah, then the assessment's difficult. You've got to do a cystogram to get a visual picture of what the bladder's like. You can't really do urodynamics because they're anuric. So the only investigation you can do is a cystogram to look at the size of the bladder. And then from that, you have to make a decision. Like one of our patients, we said, we would see what the bladder looked like literally on the table. It's not a very academic way of assessing a bladder, but it's an assessment. And then you can implant into that bladder. You leave a suprapubic, so if the child gets, hydronephrosis of the transplant kidney or it's a hostile bladder, you've got a way of releasing it. And then you're going to have to move on to the next step. So the next step may be a vesicostomy, So you don't want to take down a transplant ureter that's gone into the bladder and then take it down and make an endometriostomy. That's not a good strategy. So you've got to have a plan B before you institute your plan A. So you'd have a very detailed plan of if that bladder really doesn't work, what are we going to be doing as the next option? It can't be an open-ended thing.
Thank you very much.
Yeah.
We have to move, because there's so many questions.
Yeah, we don't do very many. Ureterocystoplasty, I have never done one.
Thank you all for the questions. You can ask more questions later on at the break. Before we move to Divyesh, I wanted to acknowledge our bladder dysfunction and recurrent UTIs post-transplantation. He is also a urologist from Great Ormond Street. Thank you, Divyesh.
Thank you very much for this kind invitation and allowing us to share our experience regarding what is a very challenging and difficult topic. And before I start, I just want to convey some of the challenges that we see and face, and that is that in pediatrics, the bladder is continuing to evolve. It hasn't matured, and depending on the age at which you're considering a renal transplantation, I think we have to sometimes not just do one assessment, but a series of assessments. And a common scenario for us is that a child's renal function is fairly fragile. We are told he's being worked up for a transplant or she's being worked up for a transplant, and if appropriate, they'll have invasive urodynamics, and then the renal function stabilizes for a long period of time, a year, sometimes 2 years, and then 3 years down the road again, it's being revisited, and obviously the child's bladder function has evolved during that period. So therefore, from our side, we would always keep our minds open and not make a firm plan based on a single assessment. Okay, so the principle of management, at least from our perspective, is that we should take all necessary steps to ensure that you have a safe urinary tract prior to renal transplantation. Now, we should just keep in mind the urological conditions that are associated with significant renal as well as bladder dysfunction. And certainly when I started training, augmentation was very commonly being carried out for 3 conditions. The first was posterior urethral valves, the second was bladder exstrophy, and the third was the neuropathic bladder. Over time, I think that there have been improvements in the management of some of these conditions, and therefore our incidence of offering and carrying out augmentations has reduced considerably. So these are the conditions that are associated with quite significant degree of bladder dysfunction, which can have an impact on the transplant. And the one thing that we are looking for, obviously, is to identify and then appropriately treat, as Imran illustrated through some of his case studies, the hostile bladder. What do we mean by a hostile bladder? A hostile bladder is one in which the compliance or the pressure under which the urine is being stored is significantly high, and greater than 30 centimeters for expected bladder capacity would be considered a poorly compliant bladder. A leak point pressure, which is more than 40 centimeters of water, is also associated with a high risk of renal damage. Detrusor sphincter dyssynergia can be associated with significant back pressure changes and cause renal damage. Secondary vesicoureteric reflux, incomplete bladder emptying, which is associated with the risk for urinary tract infections, and these are all the factors that we would be looking out for. So the assessment starts, as in most cases, with a good history. Antenatal history will give you a clue as to what may have been the underlying problem. Subsequently, going back to some of the questions in the earlier talk, it's quite important to know whether the children attained continence, had normal toilet training, and if they were reliably dry, both during the day as well as at night, and subsequently ended up in renal failure. History of urinary tract infections, and of course, most importantly, any previous surgical interventions. We would, along with the bladder assessment, also look at the results of radiological investigations where appropriate. And in pediatrics, whether you're doing a non-invasive or an invasive assessment, it is a combination of art as well as science. Okay, so children, when they come for these assessments, it's an alien environment, and they may not necessarily replicate what happens in a normal day-to-day situation, which is why usually we would carry out certainly more than one non-invasive assessment, but also take into consideration other random incidents where they come in, for example, for an ultrasound of the urinary tract, an MCUG, and take all the findings into consideration. If you've got consistent evidence, for example, of incomplete bladder emptying, across all your investigations, then that's very likely to be a significant problem. Assessment of bladder function. Going back to Steve's question, I think I would agree that it's important to distinguish between urological and nephrological causes of end-stage renal disease. But also it is very important to consider the age at which you're considering transplantation. Particularly with urological conditions, as I alluded to earlier, there is an ongoing evolution, not just in normal bladder function, but also with the specific conditions. And therefore, assessment and planning would be based on these factors. For the nephrological causes, generally these are not associated with a significant degree of bladder dysfunction, and certainly to have hostile bladder dynamics would be uncommon. Urinary tract infections and urinary incontinence tend to be the main problems if bladder function is abnormal. Usually a history, physical examination, imaging, and non-invasive bladder function assessments are sufficient to make a plan. And the need for invasive urodynamics in this group of children is uncommon. So moving on to the urological conditions, I think we'll just consider them individually and see what the risk is in terms of the bladder dysfunction. So looking at children with posterior urethral valves, which is quite a common problem, we still get anything between 25 to 30 new cases each year. And what is recognized about the evolution of bladder function following successful valve ablation in these children is that very early on, these children, the bladders tend to have a reduced functional capacity. They have detrusor overactivity, but the compliance is usually unimpaired. They tend to void with elevated voiding pressures, which are typically in the region of 120 to 150 centimeters, and bladder emptying isn't always to completion. As they get older, between the ages of 4 and 7, their bladder capacity tends to increase, the detrusor overactivity tends to resolve, and voiding pressures start to normalize. They empty quite efficiently, but some degree of post-void residual is not uncommon. And late, so once they are into their late teenage and early adult life, it is recognized that a proportion of these children will develop a large bladder capacity, their voiding pressures will reduce over time and will be associated with significant post-void residuals, what is described as a decompensated bladder. In addition, there may or may not be associated ongoing reflux. Looking at the natural history and evolution of bladder function in children with primary vesicoureteric reflux, generally early on they tend to have a good, if anything, large functional capacity. They may have some detrusor overactivity, but the bladder compliance is unimpaired. Their voiding dynamics tend to be immature with poor coordination between detrusor contraction and sphincter relaxation and incomplete bladder emptying, either primary or due to the ongoing reflux. In older children with primary vesicoureteric reflux, they tend to have large capacity bladders, which are generally stable and compliant. They have decompensated voiding dynamics with reduced voiding detrusor pressures and tend to leave significant post-void residuals. Moving on to the third group, and that is the open spinal dysraphism, which is the myelomeningocele typically. It is well recognized that this condition is associated with a significant degree of renal damage. And it can be quite dramatic. One single urinary tract infection can sometimes completely destroy a kidney. And approximately a quarter of these children end up with significant renal damage and may subsequently require renal replacement. So looking at the bladder dysfunction in this population, essentially there are four classic patterns that are recognized. The first one on the top left, which is the DSD, and that's seen in approximately a third of this population, is the most dangerous, because this is one where you've got a reduced functional capacity, detrusor overactivity, compliance is impaired, and then during voiding they have a detrusor sphincter discoordination, which usually is associated with secondary reflux and renal damage. The one on the right, the overactive detrusor with the underactive sphincter, is a problem for continence, and that can be addressed at a later stage, but is unlikely to be associated with significant renal damage. The underactive detrusor with the overactive sphincter, here the problem is going to be of bladder emptying, because they tend to have a large capacity but not enough contractility and an overactive sphincter, and typically these children would end up with intermittent catheterization. And then the underactive sphincter with the underactive detrusor is an issue of continence, which will need to be addressed once the child is older. So the hostile bladder is the one that we are constantly on the lookout for and needs to be appropriately treated, whether that is with anticholinergics and clean intermittent catheterization, whether that is with urinary diversion, or in selected cases, bladder reconstruction. Anorectal malformations, again, typically the bladder dynamics following corrective surgery essentially stay unchanged. And the higher the lesion, the greater the risk that it is going to be associated with associated spinal anomalies, and that can lead to potentially hostile bladder. The cloacal anomalies are again a very rare group of children, and typically the historical studies have shown that in the long term these bladders tend to have decompensated dynamics post-surgical intervention. There have been some recent changes recently in the approach to the initial surgical reconstruction, and we are continuing to monitor these bladders to see whether there is any change in their long-term outcome. Rhabdomyosarcomas, again, depending on the type of treatment, whether that's brachytherapy, whether that's conventional radical surgery, end up with some degree of bladder dysfunction, and they typically tend to have a reduced functional capacity with detrusor overactivity, can have impaired bladder compliance with elevated voiding pressures and incomplete emptying. So potentially, again, this group of children are associated with hostile bladder dynamics. Other rare conditions like tuberculosis, etc., have the potential, and it is important to recognize that this is something that can have an impact on the bladder, and therefore carry out appropriate bladder assessments to address this. So, as we've talked about several times already, the most important question that the nephrologist wants to know, that the transplant surgeon wants to know, is from the urologist, is the bladder safe? Can you give me in writing that it is okay for me to go ahead and transplant this child with reimplantation into the bladder? So we typically would tend to start out with non-invasive bladder function assessments, and that not only serves as a baseline, but can also serve in ongoing follow-up depending on what interventions or medications have been suggested. It helps us to direct treatment or modify treatment, and more importantly, it will identify the patients who would benefit from more invasive studies where appropriate. You probably are very familiar with these different types of flow curves. That's your normal bell-shaped flow curve. That's a tower-shaped flow curve which suggests some degree, possibly, of detrusor overactivity and urgency, and typically this would be associated with urinary incontinence. The interrupted flow is suggestive that the bladder may be decompensated and they are using abdominal straining in order to try and efficiently empty the bladder, which can be fairly successful when they are young, but would tend to become a problem, particularly once they are post-pubertal. The staccato flow, that's telling you that you've got a significant degree of detrusor sphincter discoordination or dyssynergia, depending on whether there's an underlying neurological lesion or not. And then the plateau flow, which is typically associated with some degree of fixed resistance or obstruction, whether that's a meatal stenosis, whether that's a urethral stricture, and basically would prompt you to look for any correctable obstructive lesion. Moving on to the invasive urodynamics, I think it would be fair to say, and I'm happy to be corrected, but I think for most urological conditions, at Great Ormond Street, we tend to ensure that these children have had an invasive urodynamic study prior to renal transplant. I think for the for the nephrological causes, I think it would be uncommon, but for almost all urological conditions, we would ensure they have invasive urodynamics. And depending on their age and depending on the underlying condition, we have different types of studies that we carry out. For the babies, so the really young children, we carry out what is called as natural filling urodynamics. For the older child, it's either a standard filling artificial cystometrogram, or where we are also interested in looking at anatomy, presence of diverticuli, presence of reflux, we would carry that out using radiocontrast in a video urodynamic study. So, as the name suggests, it requires the presence of catheters, a rectal catheter for abdominal pressure recording, and a vesical catheter for intravesical pressure recording. Again, typically, which is probably a little bit different to a lot of other centers, we tend to do the vast majority of our invasive urodynamics through suprapubic catheters, which requires an anesthetic a day before we are doing the study, and I have faced quite significant questions over this approach, but there are sound reasons why we think that this is a better technique. The first is depending on the age of the child. So typically, barring the natural fill that we do in babies, most of them would be around 4 to 5 years of age before we would consider invasive urodynamics. The lumen of the urethra at that age is quite narrow. If you then put a urethral catheter through it, a 7 French or an 8 French double lumen, I think you're further compromising the outlet. In addition, we've burnt our fingers in the past, particularly with the neuropathic population, where we've done a study through the urethral catheter, because typically a lot of these children tend to be catheterizing anyway, and so it doesn't make sense to subject them to an anesthetic. However, what we found on occasion was that the outlet resistance is sometimes more difficult and is in fact artificially elevated by the presence of a urethral catheter. So the children then went on to have their augmentation, Mitrofanov, ACE, and they came back 3 months later for follow-up and they said, still wet, constantly leaking. So we, as I said, generally tend to do it through suprapubic catheters. And obviously, in the filling phase, the things that you're looking out for is presence or absence of detrusor overactivity, what is the compliance of the bladder or the system, bladder capacity, presence or absence of sensations, any associated urgency, any leakage, and if it's a video study, whether there is any vesicoureteric reflux. In the voiding phase, you're looking for hesitancy, pattern, so more or less that would correlate with your flow rates. What's the maximum detrusor pressure? What's the maximum detrusor pressure at maximum flow? Is the flow continuous? Is it interrupted? Is there any reflux? What's the bladder neck function doing? Is the urethra looking normal? And is bladder emptying good, or is it incomplete? And if there is reflux, is there secondary refilling? So natural filling urodynamics, just very briefly, as I said, the applications for this type of study is generally in babies in a clinical situation. It's very time consuming, typically takes about 4 hours, and you need to record at least 2 filling and voiding cycles. So therefore you can imagine in a young adult who's got a capacity of 600 or 700 mils, this is not a good approach. And typically it involves a single catheter in the bladder. The bladder will fill naturally from the kidneys, and obviously you need a rectal catheter for abdominal pressure measurement. Advantage is you can carry it out in babies who are in a cot, toddlers who are ambulatory, you just strap the thing to their waist and off they go and come back. At least one of the cycles, it's important to observe what their voiding is like. The standard artificial filling cystometrograms, advantage is that it can be done in privacy. You don't, unlike in the video setting where you've got 3-4 people in the room, this can be done behind a curtain, and so therefore you're much more likely to get good cooperation from the children. Disadvantages are you obviously don't get any fluoroscopic imaging, and so if you are concerned about reflux, outflow obstruction, you would need other imaging modalities to answer that question for you. And then situations where you want information on both anatomy as well as function, you would prefer to go for a video urodynamic study. So coming to bladder management options, and I think through Imran's talk, and we've discussed various possible advice that may be offered from the urological side. So the ideal scenario is you've done your thorough assessments and you've deemed the bladder to be safe, and so you say, this bladder is safe to receive a transplant. Fantastic, no problem. The second situation is that your bladder capacity is reasonably good, compliance is not an issue, the bladder is stable, but the bladder emptying is ineffective or they're leaving behind significant residuals. At a young age, children can compensate for this by practicing what is called double voiding, which means basically you ask them to go and empty their bladder, and then after a gap of around 10 minutes, you ask them to go back and try and empty again. And sometimes that's more efficient if they do it sitting down. The third situation, which Imran alluded to, I think in one of his cases, is overall the bladder seems to be reasonably good, but either because the child is a bit oliguric, you can't be 100% certain about how that bladder will cope once the transplant is in, once they are on a fluid target, and there's a lot of urine going through the system. So we recommend in those situations to put in a suprapubic catheter when they're doing the transplant, and then once the transplant has settled, we would then, typically about 2 weeks after the transplant, start clamping and releasing and assess the bladder function, see how the bladder is coping, and see how well the bladder is emptying. There is, of course, a role for offering and advising that the children start clean independent catheterization with or without anticholinergics, depending on what the bladder assessment has shown. Now, urinary diversion is, I think it would be fair to say, is not very uncommon in our practice, but in selected situations. If possible, refluxing ureterostomy, typically because it tends to allow the bladder to continue to cycle and the bladder function to continue to evolve. And so that I continue to look after at the moment, one of them is about 7 plant, had a hostile bladder that was identified underlying condition was posterior urethral valves. He was too young at that time for an augment, and so he had a refluxing ureterostomy. He is now so comfortable with that. There are some psychological issues because he's had problems with his hips, has had bilateral hip surgery, etc. That 8 years down, it is now, every visit is about trying to convince. He's still wearing nappies. He's 12, 13 years of age, and that needs to obviously change. The dynamics to see if there's been any change over this period of time, and unfortunately there hasn't. And I think he's on the path now and is being prepared, that obviously refluxing ureterostomy, an augmentation, and a mitrophanol. And then the definitive solution in a proportion of children, certainly in our practice, remains bladder reconstruction with or without an associated mitrophanol or an ACE. So it certainly still has a place in practice, and we continue to offer it in selected cases. Coming to urinary tract infections, again, a lot has been said, a lot of surgical, and we've also accepted that every once in a while we are in this frustration, despite trying everything, we are unable to overcome that. But there are some correctable risk factors for urinary tract infections that we must look at and address aggressively if necessary. Children with an abnormal urinary tract, it has been documented and demonstrated in them, certainly reduces the risk of recurrent urinary tract infections. Vesicoureteric reflux is well recognized as a factor that increases the risk, be either into the native or into the transplant kidney. Incomplete bladder emptying, again associated with significant risk of urinary tract infection. Constipation, urinary stasis, for example, poor drainage in a non-functioning kidney with hydroureteronephrosis. And finally, look for foreign bodies, things like calculi, of stents, indwelling catheters, buttons, etc., and see if these are the precipitating factors, if there can be any alternatives. Adjuvant measures, good fluids, good fluid intake, probiotics, cranberry, managing the bowel as best as you can, and ensuring that you have regular and complete bladder emptying. And certainly it was reassuring for us to see that, auditing the outcome of the renal transplants in those with urological and non-urological underlying causes, I would be brave enough to say that I think our assessment and management seems to be reasonably good, because I don't think there is any significant difference long-term in graft survival. Thank you very much.
Thank you very much. Question. I know at Jelena they do bladder assessments for everybody, including the...
Carry out an assessment if there is either urinary incontinence, mild or occasional, or if they have urinary tract infections. In a child who is completely well, successfully toilet trained, reliably dry, day and night, ultrasound scan showing normal kidneys and complete or near complete bladder emptying, the possibility of finding underlying bladder dysfunction is very low. So, and that's why I alluded to the fact that you don't just rely on one test, which is the bladder function assessment, but you look at, a lot of other things and then add that to because certainly the younger the child, in our experience, more often than not, a single bladder function assessment is not going to show you what typically this child does. So to rely on that is fraught with error.
Thank you so much. I've been asked by the course director to give you some coffee now for 10 minutes, if you can come back, and I'm sure we'll catch up with the questions later on. Thank you.
Sorry, I think you ran over quite a bit. So
No, no, we
No question. You've just heard from the urologist who're trying to tell you it's the bladder. And now you've got a nephrologist who might try and tell you that maybe the heart is also a little bit important. So let's have a look. So I thought I would cover a little bit about cardiovascular disease, but also look at cardiac function and consider before and after transplantation. And we'll touch on a little bit about what's happening in America and the UK and elsewhere. So I'm going to touch on a little bit of end-stage kidney disease management. We're going to talk a little bit about it because obviously there's a lot more data, and Leslie Rees, who's speaking after me, has done a lot of work on cardiovascular disease in children, but a lot of it we gain from adults and then try and do our own thing, but look at what chronic kidney disease management and also considering both renal and cardiac transplantation. So, everybody thinks that when they're about to look at something that they've just discovered a new subject. But actually, if you go back, we can go nearly 200 years ago to 1836, when it was discovered that left ventricular hypertrophy was present in the autopsies of patients with albuminuria. So I think that's probably one of the first isolated that we realised that the heart was important. And then you can see in this timeline from the 70s and 90s, Scribner and Foley, who basically started some of the long-term work in understanding atherosclerosis, and of course arteriosclerosis came subsequently, and also that there were changes in echocardiograms in adults who were starting hemodialysis. And what we've learned is more trials and more research, but the children are not just small adults. There's different pathology, and although we learn from adult practice, there are inherent differences. So I thought I'd actually share a case with you to start at the beginning. This is an 11-year-old boy. He's got end-stage kidney disease, secondary to steroid-resistant focal and segmental glomerulosclerosis, has nephrotic syndrome presentation with hyperlipidemia, hypertension, and renal dysfunction. And he was initially managed in another centre before being referred to us. He had bilateral native nephrectomies. His kidney function prior to that had been deteriorating. He had a trial of LDL pheresis as well. He also had inflammatory bowel disease, and he had a monoclonal antibody called vedolizumab, and he started having a reaction to that, and it was stopped. By this time, his genetics for nephrotic syndrome had come back being negative, and he was running into problems with recurrent episodes of fluid overload, cardiac decompensation, and then had a severe dilated cardiomyopathy. This was the year before we saw him. And he had an intercurrent infection when his function went off. So he was started on milrinone because of his poor left ventricular function. His ejection fraction and fraction shortening were remarkably reduced. And on hemodialysis, he had intradialytic hypertension, so he was having times of hypertension and hypotension, and he ended up having an increase in his prescription for hemodialysis, and he went up to 5 sessions of 6 hours a week, so 30 hours a week. But due to the intermittent hypertension, he also had posterior reversible encephalopathy syndrome, and he required medications for having seizure activity now with topiramate, and he also had generalized tonic-clonic seizures as well. So what would you like to do to this young man? He's got poor cardiac function, he's got end-stage kidney disease, his kidneys are out. Hands up if you're going to continue with in-center hemodialysis. Who wants to commence him on peritoneal dialysis? Okay, 1 or 2. Who wants to convert him to home hemodialysis? Yep, there's a few here. Who thinks, well, we should do the kidney first and then a heart transplant? Okay, and who thinks a heart then a kidney transplant? Yep, there's a few there. And who wants to do both together? Okay, so there's a few. So I think there's a selection of different ideas. What we did, and when the referral came through to us at Gosh, we had a trial and a treatment of home hemodialysis, which we'll talk a little bit about. So we all know that renal transplantation is the best form of renal replacement therapy, but obviously you've got home and hospital, PD, hemo, and different forms of transplantation. But what we do know is that we have improved outcomes with home hemodialysis, and some of the earlier studies showing already an increase in the patient survival in adults on home hemodialysis. So this is nearly 30 years old now, coming 20 years old, I should say. And what this shows is that although we don't see children die from cardiovascular events, we have had some of our patients aged 19, 20, and early 20s die in adult practice with fluid overload and hypertension. And what this shows you is that if you have end-stage kidney disease as a child, then actually your risk of having a cardiovascular event is similar to the normal population of by age 80. So hugely increased incidence. And what we know is that the worse your renal function is, so the degree of chronic kidney disease that you have also affects your cardiovascular disease outcome. But what is it that is the interplay? And this is where it's very much debated, because chronic kidney disease is a risk factor for cardiovascular disease, but also that cardiovascular disease may be a risk factor for the progression of chronic kidney disease as well. So that's why we really feel that we need to look at both the traditional cardiovascular risk factors and the non-traditional. And these are very much stated here, so obviously there's things you can change, but as an adult, obviously you can stop smoking, you can have a better lifestyle, less sedentary, so you can have more exercise, improve your blood pressure control, improve your diet, improve your lipids, improve your salt intake as well. But there are other aspects which you can't improve, which happen over time. What about if you say, well, let's give you a kidney transplant anyway? Well, we know that cardiovascular disease is much more prevalent in both adults and children after renal transplantation. The 4C collaborative network, initially from the ESCAPE, is looking at the cardiovascular risk factors, and we're seeing changes which are ongoing in children after renal transplantation as well as before. And some people try and say, well, it's not just the traditional risk factors, there's added risk factors that we see, and part of it may be infectious complications. So for example, cytomegalovirus has been implicated in perhaps having a role, but also the immunosuppressive drugs themselves may have a role in increasing the cardiovascular risk. What I wanted to take home here was that although we do our best and we aim to have both adults and children transplanted, is that actually in a lot of the series, the biggest cause of graft failure is actually dying from another cause. So dying with a functioning graft, and actually most adults will die from a cardiovascular event as a cause of their death. So in other words, we're getting the renal transplantation for the end-stage kidney disease, but we're not actually improving their long-term cardiovascular morbidity and mortalities. And why can that be? Well, obviously, if you are a smoker, as being an older diabetic patient, then your risk for ischemic heart disease is hugely increased, that you can see here. What I find interesting is actually that if you're a younger non-diabetic, it didn't actually make much of a difference whether you were a smoker or not, but I think it depends on the number of cigarettes that you smoke and your cumulative amount as well. So why might be in the situation of children potentially requiring a kidney transplant and a heart transplant? Well, part of it can be because of an ischemic insult, which can be perinatal and hypoxic ischemic encephalopathy. We've had some really difficult neonates to try and manage who've got severe cardiac dysfunction. But it primarily is because of either a cardiac event, so we've seen some children have a significant arrhythmia and then have a cardiac arrest, and that's causing an ischemic insult both to the kidney and the heart as well. Obviously, you've got children with congenital heart disease and some of them having operations, and around the time of reparative surgery or having an arrest or having ECMO for severe dysfunction, ending up having acute tubular necrosis as a cause of acute kidney injury, and then those babies going on to have bilateral cortical necrosis. Historically, and I don't think any pediatric or adult cardiologist who was involved in transplantation would disagree that there were a huge number of patients who had cyclosporine-induced nephrotoxicity. It was the management of immunosuppression after a heart transplant. The feeling was, this is your only transplant that you're going to have. We need to stop you having an acute rejection. And there were very, very high levels which were used historically. And that caused the nephrotoxicity from the calcineurin inhibition. But we do see secondary conditions, and they may be microangiopathy, hemolytic uremic syndrome, post-transplantation is seen, and we've also seen some children with a C3 glomerulopathy-like illness, so a membranoproliferative glomerulonephritis, post-cardiac transplantation as well. So what can we do? Well, what I was trying to get on with the home hemodialysis is that you might be able to make some of these changes. But there are a lot of work going on to looking at reverse modelling and improvement in cardiac function after transplantation. So this was a group who looked at baseline systolic dysfunction, and it was a group of patients, and as you can see there was over 1,000 who had pre-transplant echocardiograms. There wasn't much of a difference between the two, and then they looked at what their outcome measures were by looking at both the morphology of the cardiac, so what the dimensions were, but also the overall cardiac function. And what they showed is that there was an impact of impaired pre-transplant left ventricular and diastolic function on the post-transplant survival that you can see here. So if you compared the groups that had normal baseline left ventricular morphology and function, their survival was actually significantly improved. However, if you were able to improve that function post-transplantation, then some of these patients actually, their overall cardiovascular mortality and morbidity hugely improved. Now, Professor Rees is sitting in the front row, so I couldn't but state that one of the obvious things is actually, and I mentioned it earlier, was your management of anemia, because actually improving your hemoglobin, which of course happens post-transplantation, generally, although maybe reduced by using immunosuppression such as mycophenolate mofetil, even by just improving your anemia management actually will improve your left ventricular ejection fraction as well. This was a group in Egypt who looked at 150 patients. There was 30 adults and 30 children who had renal transplant recipients, as well as those on hemodialysis in normal population. And what they showed is basically in adults, they had an improvement in the left ventricular end diastolic volume and improvement in ejection fraction and fraction shortening, and that was seen as well in their pediatric population as well. So the changes weren't as significant in the children as they were in the adults, but there was definitely an improvement as well. So one thing to consider, of course, is you could do a combined kidney and heart transplant if you really have a patient who's in intensive care. Now that's not something we would all jump at with joy, because of course what do we want after a transplant, for a kidney transplant? We want to give fluids. What do they restrict when you do a heart transplant? It's fluids. So there is a real debate about what is the best modality. And of course part of the reason is that you're wanting to do transplants. So this was data which was published in 13 adults from a single donor. And what I wanted to show you that if you look at this, where it was about a third of the patients survived the whole time, and that is up to a median of 15 months it's supposed to be. So if we look at 30 consecutive adults who had a combined heart and lung transplant, and we compare it to 440 just adults who have a cardiac transplant, you can see that immunologically they do very well with reduced rejection episodes. So what about in the UK? Well, there's been 8 paediatric transplants over the last 10 years. We haven't had any case at Gosh, but there's one case of a simultaneous heart and kidney transplant in the UK. In the United States, there's been 38 cases reported by UNOS over 30 years, and these are a single center from UCLA, where they actually, if you look at what the ejection fraction was, some of them you would actually question whether they need a heart transplant, and then if you look at their estimated GFR, you would question whether some of them actually needed a kidney transplant, because their take was that they would do a combined if the eGFR was less than 50 mils per minute per 1.73 meters squared. So to end, what are you going to consider to do to your patient? Well, we put him on home hemodialysis. He had a trial of nocturnal. He went forward and had a living donor transplant, but unfortunately had a recurrence of his nephrotic syndrome. He ended up having SVC obstruction, a real difficult case, both psychologically and medical. His kidney function and his fractional shortening deteriorated, and he started becoming hyperkalemic. And we ended up putting him on peritoneal dialysis with improved heart function, but he's going to require another kidney transplant if we know what the treatment is for recurrence of FSGS. So I'd just like to thank everybody in the team, not just the nephrologists, but the surgeons, the interventional radiologists, but the multidisciplinary team with anaesthetists, cardiologists, gastroenterologists, the doctors, and the whole nursing and MDT team. Thank you very much.
Steve, thank you. And thanks for sticking to time. I think we've got time for just a couple of questions.
Or can you think about the other way around it? When you have a heart failure, when do you determine to do a kidney?
So when to do a kidney transplant?
Kind of go to the same place, but looking from a different point of view.
Yeah, so what I guess my take home is before we would do the kidney, you would want to try and improve the heart function as much as you can. So obviously medical treatment. Professor Rees will tell you that the most important thing with hypertension is fluid and salt. And we constantly find that when you reduce that, you actually will improve the fluid overload and actually the long-term outcome from the heart point of view, and that heart function will improve, thereby making it easier to do a kidney transplant without hopefully needing to do combined.
Okay, thanks, Steve.
Thank you.
So now it gives me great pleasure to introduce Leslie Rees. Again, I'm sure most of you know her. She's been a consultant at Great Ormond Street for a long time. She's one of the editors of Paediatric Nephrology, so talk to her if you want to get your paper in. And she's going to talk to us about transplantation in children with learning difficulties. Thank you.
Okay, I need my slides. So I have what is usually the good fortune of sharing an office with Jelena, but one day she kind of looked over at me with that "I'm going to ask you something" look on her face, and she asked me, would I give a talk on... You loaded it?
Yeah, I don't know.
It's... God, I have to get my glasses. Can't see that. Leslie Rees. Bottom. Yeah, so don't need them after all. So she gave me this topic, which I thought, oh no, I'm going to have to start waxing philosophical here. And then I thought, well, actually, ethics is about deciding what's right and what's wrong. And therefore, if I see if there's any facts at all that can help me, then that's probably the best way forward. So I've taken a rather pragmatic approach to this, and I'm sure Joe, who's going to follow up, will have a very different view. But we shall see. So just to remind you, first of all, that kidney replacement therapy is not available to everyone in the world. In fact, it's quite special still. And if you look at the data, then about 80% of all the patients who have a transplant are in Europe, North America, or Japan. And then there, most children with CKD have access to kidney replacement therapy. Actually, this isn't my latest, but never mind. So there are still places, even within Europe, where kidney replacement therapy is scarce or even unavailable. And that's principally the low and middle income countries. And there they have still limited financial resources and a lack of trained personnel. So even in the developed world, there is variable access to kidney replacement therapy. Many infants are not accepted onto end-stage programs. Those with comorbidities may have life-threatening conditions, so kidney replacement therapy may not be appropriate. We are treating more and more children with end-stage kidney disease. And in fact, when it comes down to it, most of the controversy about transplanting these children is about their IQ. And few people would reject a child with severe physical handicaps but a normal IQ. So how do different centres approach transplantation for children with learning disability? So there's a survey from America, and they looked at 88 transplant centres, and of those, 85% considered neurodevelopmental assessment should be evaluated as part of a transplant assessment. And 71% of those considered subnormal IQ a relative contraindication, but in fact none had a system to evaluate IQ. And interesting thing to come out of this survey was that living related donor was the preferred option for families with learning difficulties over than putting him into the deceased donor pool. So what are the factors? Can we learn anything from the factors that influence the decision about offering transplantation to children with LD? The R shouldn't be there, apologise. So I think one of the things is uncertainty about their outcome, very reasonable. Does it affect patient survival, transplant survival, quality of life? And then another factor that you read a lot about is, are we depriving a more deserving candidate of a transplant, which is, of course, a big ethical issue. So, to answer the first question, do children with severe learning difficulties have poorer outcomes? Well, there is a bit of literature on that, and we'll go through that. First of all, dialysis is not what we're concentrating on today, and that does have very variable outcome measures. But most of the data on transplantation actually shows no difference in patient survival, transplant survival, or quality of life, which in fact is often improved in these patients. So if we look at the outcome papers that I could find, first of all, this is quite old, but it's probably the biggest study. They looked at 25 multiply handicapped children in Japan, and 13 of those had a very severe learning difficulty with an IQ less than 35. And when they looked at the group of patients who had these very low IQs, the patient and transplant survival was very comparable to the rest of their transplanted peers. And perhaps importantly, there was a significant improvement in the quality of life of the carers that were looking after these patients. There's another more recent study in the US using their big registry data, and they found that up to 24% of the children there had learning difficulties, and again, no difference in patient or transplant outcome. And then the most recent paper looking at UNOS data, which is again American data, of just over 2,000 children transplanted. There's quite a significant number, 117 definite, 215 probable learning difficulties. And actually in their study, most of these children, or the majority, had actually had a deceased donor rather than a living donor. And again, no difference in patient or graft survival over 3 years. So we cannot use outcome data to guide us as being a contraindication. So what are the circumstances that might lead to poorer outcomes in children with learning difficulties? Well, first of all, many have threatening comorbidities. We know that we are transplanting or looking after more and more children with multiply complex syndromes. Is this going to have an adverse effect on the quality of life of the children and the families? Of course, you have a very high burden of care in these children, and is that going to exceed the benefit, which of course is survival, in the families, and that the difficulties which they might encounter with kidney replacement therapy mean that the benefit to continued life is not worthwhile. And that's of course all discussable. So is there any difference in the long-term outcome of these patients with learning difficulties? So does the patient have a shortened lifespan? So we're very prejudiced by historical data about outcomes of our patients because there was, of course, until, well, certainly when I first qualified, quite a lot of children who were not treated who had syndrome. For example, patients with Down syndrome who had cardiac disease were not operated on when I first qualified. So all these things will have influenced the expected lifespan for our patients that we read currently. Another question that is we see is who will care for the child when they reach adult? You know, what if their parents die or, you know, they, whatever. But of course that isn't a medical problem, that's societal failure for care of the vulnerable. And then doubts about quality of life, and this is a very difficult issue, I find. does the individual with a learning disability have a higher quality of, without a learning difficulty, have a higher quality of life, and therefore is of higher value than one with learning disabilities? Another question that we see is, does inclusion of those with learning difficulties result in the intellectually intact dying on the waiting list? There were, in the US data in 2017, 125 children died on the list. So the question that is raised is, would these children have been more likely to contribute to society than children with learning disabilities? A difficult problem. So, whether the outcomes of these children is worth it relies on perceptions of the quality of life or value of an individual's life, which is very difficult. I think Joe will have something to say about that. And many of the judgments we make are social. They're not medical value judgments at all. And one does wonder sometimes whether the medical community values IQ more than other groups in society. And social value is often in conflict with human dignity. So are there any guidelines out there? Well, there are. They're started back in 1995 and go all the way through to 2016. And many of them factor around compliance with essential medications. And of course, the group with learning disabilities are not the only ones who have compliance with medications. So exclusion on those grounds is quite a tricky issue. Relative contraindication in the absence of a caregiver, but again, that's a societal issue, not a medical one. The last one that I could find was 2016, and that's Boston Children's. And they state that you cannot exclude on the basis of learning difficulty. The only criteria for excluding a patient should be organ and patient survival. So another question that comes up quite often is, should dialysis be started when transplantation is not possible? Because dialysis is seen as bridging to transplant, a temporary thing rather than a permanent one. And the arguments against that, against starting a patient, are what you're doing is prolonging the dying process. On the other hand, you do give continued life, albeit with reduced quality. I don't think anybody would ever say that dialysis has anything other than a negative effect on your quality of life. But if you take that to a logical conclusion, then that would mean that you should not you should not dialyse a child with recurrent FSGS, because again, you're not going to transplant them. So the other thing is, of course, transplantation is temporary. Unfortunately, it's not a permanent treatment, as we know. Then we need to think about allocation of organs, principles of utility and justice. So one thing is that it would be, in terms of fairness, unjustified to use a scarce resource without any expected benefit. So, of course, transplants are a limited resource. We can't give them to everybody who wants them. We don't have enough. On the other hand, dialysis is not subject to those limitations. But in terms of justice, there shouldn't be any discrimination against individuals on morally irrelevant grounds. And people should be treated equally, and the criteria should be applied in an equal manner and be transparent. And when we looked at the guidelines from around the world, I think we probably agree that there's a very liberal definition in those guidelines. So what are the arguments for inclusion of children with learning difficulties? Well, firstly, they do actually contribute to the organ pool. So we have to remember that when we think that they are not entitled to deceased donor. They often have value through their relationships with others, and who are we to judge that? Other people within the family are more likely to be able to answer that question. And of course, if you're going to exclude children, that means they may lead to families resorting to the court, the press, the social media, and again that introduces an element of unfairness, because the persuasive families will obviously do much better, i.e. you're making the system unfair. So I just wanted to discuss or bring up this patient, because this child has caused disagreement within the team, and disagreement between the team and the family, and the sort of multiple disagreements. So I'm presenting the patient to you. I'm not going to do anything other than present her, and then I think it will probably lead into the discussion after this. So this is a girl who's 9 now. Normal antenatal scans other than polyhydramnios, and a normal birth but very low birth weight, 1.8 kilos. She was noted right from the start to have a very small head, to have developmental delay. She had anorectal malformation, an unsafe swallow, a scoliosis, coloboma, registered blind, bladder neck excision, and then the reason why we're discussing her now, chronic kidney disease. Her current state, at the age of 9, she's wheelchair bound, she's incontinent of urine and feces, she has no speech or vision, no genetic diagnosis, a creatinine in the 600s. The family absolutely adore her. She's just had a new little sister, which they tell me she interacts with. She's a valued member of the family, and both parents want to donate a kidney. So we'll come back to her later, if you can just remember. Many of our team here will remember. So, so here we have a disagreement between the carers and the providers. And what are the factors that we might take into consideration? Can the child form relationships? Are there positive benefits for the family from these relationships? Many reports focus on the burden to the family for these children and the time taken up by dialysis and the effect on the family finances. But of course, again, this is unfair. This is biasing against families with limited, by that I mean financial resources. So can ethics help us? And this is where I can't even see Joe, I hope he's here. Ethics is a set of principles that help us distinguish between right and wrong. But the thing is, there's really very rarely a right or a wrong answer to whatever question we pose. So ethics is a means of evaluating and choosing between different and often competing options. And it's about analysing values rather than facts. Now, the Royal College has published a booklet on withholding and withdrawing life-sustaining treatment. And all treatments now in the future must be in the child's best interests, a phrase that is used a lot and can be manipulated or used however you want it, in lots of different ways. They do stay acceptable to limit treatment that's not in a child's best interests. So what are the best interests? So an action or an intervention is in the child's best interests. I think we would all agree on these concepts. The benefits outweigh the burdens. There's acceptable minimisation of harm. There's respect for as much autonomy as possible, but of course that's not the case in children with learning disabilities. And an individual must be treated fairly and justly. So what are sources of ethical conflicts? Well, application of clinical facts alone cannot determine what should be done. And Steve's last talk illustrated a patient very clearly with those sort of ethical issues, with no right or wrong answer, and could easily have resulted in quite a lot of disagreement between the parents and the carers, and indeed between the carers. There's disagreement about the right course of action. Again, that case is the same. Application of moral principles conflict. Here is where you can go to your ethical committee, but of course an ethical committee is there only to advise. It's not there to tell you what to do. It's not going to give you any answers. And just remember that the law may be very unhelpful. In other words, there's only really one situation where it helps, which is deliberate intention to cause or hasten a patient's death is illegal. But decisions about withdrawing or withholding treatment do not have any black and white answer to them. So ethical conflicts require professionals to make value judgments to resolve them. Scott, to guide us on this, most of the work has actually been done in neonates, and this is quite an old 1995 in the States. Maybe our visitor can comment on that, but it's divided into 3. Treatment that is clearly beneficial when treatment should be provided even if the parents do not consent. Clearly futile when treatment should not be provided even if the parents want it, or ambiguous or uncertain when the parents should be the final determinants of the course of action. The French have a very different definition about neonates, that any crucial decision affecting the parent's life calls for individual medical responsibility. So this is again a British paper to withdrawing treatment, and it says it may well be ethical to withdraw or withhold or limit treatment on the grounds that greater benefit could be achieved by using the resources in other ways. 1998, I think many people now would feel quite uneasy about using that criterion. I think this statement from the French Neonatal Society is a very good one. I think the French work is very good on all this, that withholding or withdrawing a life-sustaining justified when the intention is to cease opposing in an unreasonable manner the natural course of a disease. So, in conclusion, transplant, unlike dialysis, is limited by the fact that we have a shortage of resources. We don't have enough for everyone. So I believe, and this is for discussion, that the criteria for transplantation allocation must be fair and of expected benefit. Clearly your patient must show a benefit, show no discrimination, be equally applied to all, transparent, and rationing should not alter our concept of just allocation. Thank you.
Leslie, thank you very much for a very thoughtful talk. Do we have questions and comments from the audience? Yes. Do we have a roving mic? Anyone at the back? No, we don't have a roving mic. I'll rove myself.
Thank you very much for this different. And I think it would be much better when we make an separation in learning disabilities with behavior problems, for example, because now, for example, a child with a Smith-Magenis syndrome last couple of years ago, she had a lower IQ, but she really quality of life because she was very difficult to treat by the parents because of her aggressive moments, and it was the aggression where we finally decided to even not transplant her, and also the dialysis was impossible because she removes everything when she was in such an, I think, and that's what when you read the literature, it's so difficult to have a statement, yes or no, on learning disabilities. So I think it would be better when we make separate, different kind of children with learning disabilities.
Yes, I think that's right. We have actually we had a child with very bad autism, catch him to do his blood pressure even, and the family opted for palliative care for that child. But in that patient or in that situation, the harms outweigh the benefits. And so you ought to fit into one of those categories of doing more harm than you, well. So that's one of the criteria for rejecting treatment in a patient. I quite agree with you.
What did you do to your 9-year-old patient?
Oh, well, that's for discussion. What would you do? There was a lot of disagreement. There still is. You have to tell me what you think, unless you want to bring that into the next talk.
Unless people want to say something now about what they think.
I was going to ask you, Leslie, what people is the word conflict. So obviously there can be conflict within the team, and there can be conflict between you and the parent. When I say you, I mean the multidisciplinary team. And I think my personal views is you also need to think if it's in the best interest of them to have a transplant, and is it going to improve their quality of life. But if you, Professor Rees, believe is in the child's best interest, but the parents tell you it's not, how far would you go legally, and vice versa? So say, you know, I'm willing to give my kidney, so who are you to question whether it's right? Because I'm with the child 24/7. So when should we go to court? And Joe might have some views with the Charlie Gard effect that we're beginning to see in modern medicine.
From my point of view, I would find that very hard to contend if a parent wants to give their kidney to their child because they're a valued member of the family. I would find that very difficult to refuse, as you know. As you know.
Okay, thank you. Thank you. I think we're going to move on now. So, thanks, Leslie. So we thought we'd have a debate now, and the title of the debate is Children with Limited Life Expectancy Should Be Offered Transplantation. And we've got two fantastic speakers. So we're going to kick off with Mike Boss, who, hi Mike, who I've known for probably nearly a decade now through LPAT, which is a European organisation interested in ethics and psychosocial aspects of transplantation. Would you describe yourself as an ethicist or a philosopher, or both?
No, by training I'm a medical sociologist, but
there you are.
For the last 25 years I've been working with the Dutch Health Council, which is an advisory body to the government and parliament, and I more or less by chance specialized in bioethics. So in this case I think you should say I'm the ethicist.
You're the ethicist. Okay. So what we're going to do is we're going to have 15 minutes from Mike, and then we're going to have 15 minutes from Joe, and then we're going to throw it open to all of you to have a discussion, and then we'll have a 5 minute summing up from each of the speakers at the end.
Okay, so good afternoon all of you. And let me start out by thanking the organizers, Nizam and Jelena, to invite me here let's say, on an intriguing subject, which I called hard choices in pediatric transplantation, not only limited to kidneys, but all organs. And so after some debate this morning with Joe, because we were teamed up as a sort of pro and con session, my position is that I will look especially at the non-medical situation, assuming that unless there is a very compelling medical contraindication to transplantation, it should always be considered for a child transplantation, but you will run into all kinds of psychosocial, ethical, and even legal hurdles. Professor Rees summed it up very nicely, I think, and I'll refer to that same sort of situation in my talk. And you should always try to find solutions for that. So I'm pro-transplantation in these difficult cases. So I think let's start out with a very simple ethical framework for pediatric transplantation that I think is familiar to all of you and you will agree. So as already said, what is in the child's best interest? Is the child sick enough to need a transplant? So is there a proper indication for transplantation? But also, is the child well enough to survive the procedure? Are the child and parents able to follow the medical instructions? So can you deal with non-adherence? And also, is there proper valid consent for the procedure? Is there no conflict between the different parties? So I think you could say that non-adherence or non-compliance, as it used to be called, is a very key issue that we have to look at. And of course you can say, well, if there is non-adherence, it will lead to rejection and graft loss, and you could say that is a waste of a scarce organ. And how to find out about that? So in those cases you will need a psychological evaluation to assess the risk factors for non-adherent behavior. And of course, in pediatric patients, especially the younger ones, it mainly comes on the shoulders of the parents to see to the adherence. It's different for, let's say, adolescents. And in adolescents, in some cases, you even have a role for the psychiatrist. So non-adherence, you could say, you can tick a list of these. You should know the general situation and the motivation for the transplant. Why do we want to transplant? Is there a history in the patient or in the family of non-adherence with medication and appointments? Is there parental psychiatric events or even in the patient himself? The whole situation in the family, parental supervision, family conflict, poor communication within the family, the social, financial situation of the family, and even between the parents and the medical team there can be strained relations that become a very different hurdle. Now I want to provoke you a little bit by presenting some cases. Originally I wanted to discuss it with the whole audience, but now I'll discuss it with Joe because we had not, let's say, decided before. So these are the cases that I want to present to you, and I'll tell you what the solutions are, and then you can even tell me in the discussion if you agree with that. So this one is about a dysfunctional family. A boy of 5 years is diagnosed with progressive cardiac condition, needing ultimately a heart transplant. And of course the social worker discusses this with the parents and makes a home visit. And her conclusion was, this is a severely dysfunctional family, lack of social support all around, suspected parental drug abuse, and there is a serious risk of non-adherence for this child once having a transplant. So what can you do? And here a number of considerations that you have to look at. The social worker and the psychologist say, well, there is a high risk of non-adherence, and finally graft loss because the whole family situation because of the drug addiction is so chaotic. There is very little hope of timely improvement through counseling of the parents, and also the parents will not cooperate in any way with taking away the parental authority through the courts and seeking a foster home for the child. So what is the outcome of this? The team really wanted to go ahead with the transplant, but they had to find a solution for this high risk of non-adherence. And what came up in the end, that was the sister of the mother of the boy. She had a family of about the same age children, and she volunteered to take the child as a sort of a foster child, and we made an agreement, even a financial and a legal agreement, that she would look after the child after the transplantation for 5 years, and all the social care and the financial aspects of that were transferred to that sister. So the boy would grow up in a normal family situation, and the non-adherence risk was absolutely reduced because the sister was able to take it over. And this prevented, let's say, the awkward situation where there should have been a foster home for that child in a situation that was absolutely not, let's say, positive for adherence. Okay, a second case. This involved a teenage mother with 16 years old who was in a hopeless conflict with her parents, and she lived in a shelter. The baby was diagnosed with biliary atresia, needing a quite urgent liver transplant. There was no suitable donor liver available at short notice, and the parents of that girl absolutely refused to become living liver donors. So the mother, the 16-year-old, said, I will become the living donor for this baby of mine. And should she be accepted as a living donor because she is a minor? And the considerations here was that there is especially in the country where this happened, the legal criterion for allowing living donation of 18 years, exceptions only in the case of regenerative organs or tissues, and also on minors, the decision on medical treatment, it must be in accordance with the patient. So you have a legal problem there as well. And the parents, as I said, were in hopeless conflict. So in the end, what was the solution here is that we took the case to the court, to the family court, and said, well, two things. The girl is absolutely competent, mentally competent to oversee the consequences of becoming a living donor. And also, you could say that the liver is a more or less regenerative organ, and so will not create, let's say, a lot of harm to both the donor. So the court decided that the transplant could go through, and she was the girl became the living donor just before she became 17 years old. This is a very tough case, a sad case, I must say. A teen with suicidal history, a boy of 14 years old. He was admitted to the clinic with a drug overdose, leading to acute liver failure. And there were already suspicions of suicidal intentions of this situation. And he has a history of psychiatric disorder, schizophrenia perhaps, and already a history of repeated suicidal attempts. So should he get an urgent liver transplant? Again, some facts. There are no uniform guidelines for transplanting patients with pre-existing psychotic disorders. Some treated as relative, others as an absolute contraindication. But the general opinion I found out was that to exclude a patient on the basis of psychiatric diagnosis alone is unjust, just like the cognitive impairment. But on the other hand, there is experience that active psychiatric disorder is associated with a high risk of medical non-compliance, makes sense, and also that previous suicide attempts is a strong factor for predicting future suicidal attempts. And this is in fact what happened. The boy was transplanted as soon as possible, and they started an intensive counseling, psychiatric treatment. But after 6 months after the transplant, he attempted suicide again, and this time fatally, and with an functioning graft. So you could say it was a very sad outcome for the team. Well, this looks very much like the presentation of Professor Rees, and I'll go quickly through it. Again, a girl with a complex congenital defect causing severe cognitive impairment and progressive renal failure. And the parents wanted her listed for a preemptive, if possible, kidney transplant. But the transplant center in the country where they lived refused because of the severeness of the mental impairment. It was a European center, not an American center. In this case, it looks like American center. But they feared that the transplant itself would harm the girl in her, let's say, life, because it was clear that the life expectancy of this girl was quite short. So the parents came to a center in the Netherlands for a second opinion what to do. And as Professor Riesel said, he said there are no uniform guidelines for cases of cognitive impairment. Indeed, in 1995, the American Society of Transplant Physicians said cognitive impairment can be considered a contraindication, but only if it's so severe that there is no possibility of having a good compliance and no one can, let's say, compensate for that. But I think today most centers will conform to what it was said in the Harvard Boston Ethics Committee, that pediatric patients with cognitive impairment should not be categorically excluded from transplantation because there is no evidence that the outcome is different. Oh, sorry. So what happened here is quite extraordinary. That the Dutch center where the parents came to for a second opinion said, okay, we can do the transplant, but how shall we do this? So the mother volunteered to be a living kidney donor, but it came out that she was not suitable, also because of size match. And then, very interestingly, an altruistic donor stepped forward, and she became the donor for this child. And the mother of that child with cognitive impairment then donated her kidney to the list. So, as a sort of compensation for that, because they could not be involved in a paired kidney donation, there was no situation, but she went to the list. Okay, the final case that I want to present to you is a family that was caught up in a political debate. There was a mother and 2 children from Armenia, and they applied for asylum. And after a lengthy procedure, their status as refugees was denied, and all their legal options were exhausted. The boy of 7 years had already end-stage renal disease and had already started dialysis in the country where they were temporarily staying. Because of the strict rules, the mother is deported back to Armenia, but the children were allowed to stay temporarily, awaiting a final decision, because in that country we have a child pardon under certain conditions. But it was a very precarious situation. The children could be deported also, and they were seeking shelter in a church. The dialysis treatment was severely compromised in that situation, and an early kidney transplant is to be preferred. So the center where the child was under dialysis said, well, what can we do in this situation? So they're opposing, let's say, arguments. On the one hand, Armenia is a safe country, so they have no right to asylum under the normal rules. A child pardon is only granted to children who have stayed in the new country for more than 10 years, or are born there, and are totally rooted in that new culture. And this was not the case for these children. On the other hand, there is a universal right to family, as it's called, so there should be no separation between the parents and the child. And the center also said, well, if we transplant the child, it could be considered as a final solution, and he can be sent back to Armenia, so what to do? On the other hand, the availability of dialysis and transplant care, also from a financial point of view, in Armenia was very bleak for this family. So in the end, the center decided to transplant the child, and very soon after, both the children got a pardon. They got a refugee status in the country, and even the mother was brought back to the country because of the right of family. So a happy outcome, you could say, but there is by no means a real solution, because it depended totally on the Minister of Foreign Affairs to exercise his discretion in these cases. So I think I've given you some thoughts to, and Joe, to reflect on this, and so thank you for your attention, and we'll see what Joe comes up with. So okay.
Thank you much.
My simple statement is look at all the possibilities and get transplant done if you can solve the problems. Okay.
Okay, thanks. Mike. Things in Armenia are improving, so hello to the people in Yerevan who are watching. We have a program with them through the Transplantation Society to try and get their transplant programs going. It gives me great pleasure to introduce Joe, who's an intensivist at Great Ormond Street, but also has not just a national but an international role in the ethics of transplantation and organ donation. And now we're going to hear his take on this.
Great, thanks. Thanks to the organisers again. I have to say, coming and following Mike and Leslie, who are two of the nicest people in medicine, I'm amazed I wasn't booed to the stage, but I'll see if I can be booed off the stage. The topic we were given, children with limited life expectancy should be offered transplantation. Well, obviously, I don't know why you would do a transplant otherwise. But, you know, we have to think about whether we're doing the right thing for the child. And I'm going to push you very hard. Meet Boris. Too soon? Election? Perda? Not sure. Boris has been born with no brain. He has a condition called anencephaly. His parents do not want him to be discriminated against and have fought to manage to get him to a unit in Italy who've commenced long-term ventilation via tracheostomy. It is a fictitious case for those of you starting to twitch. Boris is now 1 year old, being kept alive on a ventilator. He hasn't met any developmental milestones, how can he? And he started to develop renal failure due to free reflux. Living donation is against parents' religious beliefs. They want Boris to go on the deceased donor list. I did say I'd go hard, Leslie. I think the debate we're talking about is about the old-fashioned ethical idea that sanctity of life and quality of life are somehow opposed to each other. Sanctity of quid, argued mainly by pro-life side in political and moral controversies, you know the controversies. It's very anthropocentric, the idea that the human form is much superior and we do lots of things to keep human beings alive. Some Eastern philosophies actually argue that other species should be included as well. What about androids or aliens? You can see I'm going outside my remit. But when does this apply? Is it at the beginning of life, conception, the quickening, fetal life, and the other argument at the end of life? When does it stop applying to you in terms of when someone has severe dementia or is brain dead on a ventilator? The point about that is, though, the sanctity of life, no organisation, no religious group thinks this is absolutely the standard law for everybody. Otherwise, everyone would be on a ventilator when they died. You would never stop things. So it's not a right to life. There's no right to keep someone alive. So a right to life, but not a right to be alive. So let's pull back to the patients we're talking about here. If we're doing a renal transplant here because the alternative is somebody dies, then you have to think about the bare stuff that's going on. So if you're alive, you exist. You have a benefit as an individual in continuing existence. Then concepts of the quality of life, how good someone's life is. Leslie's talked about some of the stuff there about how you may think about that. But most of the objective scores people talk about are terrible. It's really hard to stand here and say what someone else's quality of life is. This is a subjective measure. You are the best judge of your quality of life. But if you're a children with complex learning problems or disability, it's very hard for you to express what you think about things. The opposite is if you're dead, depending on your views, you're either in oblivion, you fail to exist as an entity, or you're in paradise with God. You may argue that children don't tend to go to the other place. So 5 points and a free coffee for where this is from. William Blake from Dante's Inferno. Satan there in the middle of his life. So quality of life, I think it's really hard. It's very subjective. The scores we have when medical teams look at them and go and talk with adults with learning difficulties, you can have a conversation. Adults with disabilities and learning difficulties score their quality of life much higher than clinicians, physicians, doctors, nurses. And for kids, it just is a horrendous idea to have that idea. Our current European overlords measure quality of life this way. Again, I don't think this is particularly helpful. Really hard. Too much politics. We've got an election on next week, guys. In adults, we'd be having this discussion talking about euthanasia, assisted suicide, assisted dying, law, ethics and religion. In children, in most countries, although Mike, of course, from Holland, where you have euthanasia for children, just to highlight that, we don't have that here. But our concepts of what we do here are much more about when we might withdraw or withhold life-sustaining treatment. And the argument I'll make is that a renal transplant, in this sort of concept, is a life-sustaining measure. We're much more focused on plans around end-of-life care, thinking about the individual and the families, and not limits of care, but withholding, withdrawing life-sustaining treatment. For us, with an international audience, where do our standards come from, our moral norms? Well, I'm going to appeal first to law. The overarching law most countries, all but one really, would have is the UN Convention on the Rights of the Child. No time to go through it in length, but this should be on every wall of every children's hospital. A child version of the UN Convention. And from that, in the UK, our own law comes from the UN Convention into the Children Act in the UK, and the term Leslie used, and again, this is the judge in the case, the Guard case recently, children's best interests are paramount. Paramount meaning the most important thing, not just a consideration, but the number one consideration when you're making decisions for children. Paramount. How do you work out best interest, though? It's kind of tough. The idea comes from the welfare standards from US law originally, where you're working out almost a table of burdens and benefits. This is really important. So not just burdens, but the child's ability to benefit from your intervention. Wishes, feelings, physical, emotional, educational requirements, a lot of this stuff, and again, Leslie's argument might be, it's really hard to work this out for a child with the most severe end of learning difficulties. But how can we work that out for Boris with his situation? Not easy. So we default to the parents' viewpoint, don't we? And this is an idea from Lynn Gillam in Melbourne, the idea that we normally work with a zone of parental discretion. Every day in your hospitals, you sit around with the parents of children and you talk about the right thing to do. And as the child gets older, that's expressed more and more by the child. There'll be different laws in different countries about when the child can make decisions, but the child's best interest is determined in this zone of parental discretion. And on either side of this, there are things that parents either are not allowed to refuse for their child. So if a child came in now with a massive subdural hematoma and was dying, and the parents said, do not do an operation, we would do it. Parents do not have control over us trying to save their child's life. We don't have time to go to court, you save the child's life. The other end, there are things that parents cannot demand for their children. So has anyone got a teenage daughter here? Do you know what age you're allowed to have a tattoo? Or she's allowed to get a tattoo? 16? Never. Never is the right answer, because you're the father going, not happening. Never. A child cannot have a tattoo. It's against the law in this country. Maybe different in different countries. So you can't have a parent going, oh, for your 14th birthday, you can have a tattoo of a butterfly. No, not allowed. Being a bit silly. But the problem with this is, when you talk about the debates and some of the issues and the controversial cases here, here's one of the first ones. Some parents in Southampton didn't want to have the recommended international radiotherapy for their child. They wanted something different. This was really controversial at the time. Some of the voices from here, between the ICU nurses looking after very sick children, thinking, well, parents just dictate and tell us what to do. It's a real feeling for that at the moment in the current ICU world. But the other side is when you have parents of a child with complex problems, including learning difficulties, they're more and more feeling that people are having to listen to them. And that balance has shifted, almost certainly for the better recently. So here's my number one rule as a UK doctor. The General Medical Council, rule number one, make the care of your patient your first concern. When I was doing adult medicine, it was really obvious to me who my patient was. It's the bloke in the bed. I don't know if I got a light on this, probably not. On the right, who's my patient? Is it the child in the bed? Is it the parents and the child? I think in paediatrics, we often talk about the family with family-centered care. There's a couple of references papers there for you. I've even published on it. It's the idea that most paediatric treatment is much better when we look after the family as the unit. But I will argue just occasionally that compromises the child. Just occasionally. So withholding, withdrawing life-saving treatments or decisions to limit therapy, two different acronyms for it there, comes on this basis that actually children aren't supposed to die. In society, in culture, this seems the way the world is now. The death of a child is just abnormal. When it does happen, most deaths, I don't want to worry you, you're all going to die, hopefully not this morning, but most of your deaths, most people's deaths, have some medical decision-making involved with them, whether that's a DNR, a decision not to go into hospital at the end of life, a decision not to go to the ICU, a decision not to do something, or to stop something. So even on the ICU, most deaths, around 2/3, have a decision about either withholding or withdrawing life-sustaining treatment. So the idea from many religious backgrounds that death is only for God to determine, I may be right, but there are medical decisions being made about most deaths. We fool ourselves if we don't believe that. So the allowed natural death stuff comes from that sort of background. Into this, our UK Royal College, as part of the group, have a document that is very, I think, up to date, been looked at recently and decided still fit for purpose, where we work with children and their families, normally to work out when it's right to stop life-sustaining treatment or to not start it. The last version, there's an awful lot more palliative care, child-centred, even in the ICU, thinking about how to care for the holistic part of children's lives going forward. Organ donation, now routine and end-of-life care in childhood, which I'm sure you're very keen on. The 5 categories when life might be limited in quantity or quality in children who are old enough and able to competently decide things are there. But I want to highlight the axioms here. This is based on timely, open communication with mutual respect in there between clinicians and family. And I think we've not got that right over many years. That's our side. Mutual respect for children and their families in a really tough space making the hardest decisions. So Leslie highlighted some disputes occasionally happen, might be between parents, between, who would say this, renal transplant surgeons and nephrologists. Apparently it happens. I'm amazed. Is that right? Never happened. Not where you work. Simply resolving disputes is a listening exercise. Multiple MDTs, but particularly with the families, whether they have a faith-based issue, community-based, whatever it is, bring people in. Mediation, ethics committee, community teams, second opinions. If we get questions afterwards, we can talk about this. But 99% of initial disputes are resolved. So most times, sitting with families, whatever the problem is, however the difficult the situation is, this is resolvable. Some thoughts about what's happening here. When I were a lad, we do have more cases going to the courts as a nation. Still tiny numbers, but 20 in 2018 versus 6 in 2008, and the processes are taking longer. And I think this is not based necessarily on our side of this, but the differences in society, populism, pluralism, contempt for experts, and the social media aspects are very important. We might come back to that when we look at how that happens with transplant. But one of the issues is that death, I mentioned before, is hidden away in society. So those of us old enough to remember the 1900s, 1 in 7 children died in infancy. By 72, that's 1 in 600. That's even less now. Even in our ICU world, death is really rare now. We have a mortality of 3% in the sickest children in the ICU population. But that's not necessarily because we're much better at our jobs, which of course we are. Can I go with that? It's because we're making different decisions on the same stuff. We are keeping children alive who would not have been kept alive in 2005 and 6, 2011 and 12, because stopping the ventilator is now not allowed. That's really important. Many more children are coming out of the ICUs with complex health care, ongoing needs. Prematurity, you know that's a massive success. Congenital heart disease, massive success. The proportion of children with ongoing health needs who either have a serious brain issue, serious lung issues, has not changed. So with many more survivors, we have many more children with complex health needs. Here's the number of kids in England and Wales, 2012, it's pretty unchanged, with life-limiting conditions in our community. It's going up for all the possible diagnosis, and I hope the urologists note that genitourinary is on there as well. The problem with this is not spread across our society. There is a huge preponderance in people who are poorer, from cultural groups who cannot access healthcare. Again, that's on us. We have not interfaced well enough with demographic changes with people who are not used to interfacing with modern healthcare. The other thing we're doing, we have death deferment devices on every street now. Every street's got a kid on a ventilator. Community PICU, home ventilation, home PA, and home renal replacement therapy for children who will never get a transplant. Home ventricular assist devices. We're doing more and more stuff. Last year we referred a child for palliative home LTV and parental nutrition. Same as Mike's case, didn't have a home. The social stuff, you can't ignore that and say that's someone else's problem. That's part of the factors here. Long-term ventilation is going up exponentially. But here's the last bit. This is the important bit. The campaigns between these two polarized groups, the religious right-wing groups from the US came over with the Evans stuff recently in our country, versus Gandhi's quote. So huge amounts of US healthcare particularly are spent on the last year of life. And he's arguing against that in his book, Being Mortal, Medicine, What Matters in the End. Death is the enemy. This is the feeling there. People are fighting death all the time. And that's a much worse way to look after people, particularly sick children, than if you accept where things might not be likely to work. If we just fight death, that's really bad. So just to finish off, doing things to versus for a child is illegal. Who's this happy man? Any Germans here? Can't. Thank you. I thought you'd know. Categorical imperative. Never treat a human being as only a means to an end. A very important rule. Even if that end is parental preference. Parents don't own their children. We have considerations of best interests and welfare. Rights, responsibilities of parents are exercised in the child's best interests. The state has interest in child welfare. Sanctity and quality of life are very, very important. We normally resolve most disputes, but sometimes children are better if they are allowed to die. Hard statement, but it is true. So Boris, back to Boris, how can he die? He's got brain failure. He's got respiratory failure, he can't breathe. He's now got renal failure, and it appears he can't die from that either. Intercardiac infection, well, he can't die from that. What do we do? Where's the burdens, benefits for this kid? And the last thing to finish off, just because I know you want me to go there, but I'm not brave enough to do it. What about the opportunity cost to other children? Who doesn't get the organ transplant? Who doesn't get the ICU bed? What about the children in Armenia, wherever it is, who are getting less healthcare than kids in this country? Do we even think about children in sub-Saharan Africa, or is that going too hard on you? Where do we limit the children we're considering? And the magic money tree for healthcare funding? Last I saw, there were some things people are having restricted to them that can clearly benefit them. There may be ladies who've got breast cancer and are not getting chemotherapy in this country because we can't afford it. That's uncomfortable, isn't it? So where do we stop? And I would argue that if we discriminate against Boris, who's got probably the worst learning impairments you can possibly have, aren't we just being discriminatory against children with learning difficulties? Ooh, that's a bit hard, isn't it? I'm done.
Thank you, Joe. Okay, so we've got a few minutes now for people to tell us what you think about some of those difficult decisions and difficult concepts. Who would like to kick off?
I think they all agree with me, it's fine.
Yeah.
Thank you for the very interesting talks. The difficulty is that you're never going to get big enough numbers to have a precedence or be able to have an absolute guide on what you're going to do, and they're going to be case-by-case basis. And I think the big thing, particularly in renal transplant, is the availability of a live donor. I think personally that is a game changer with regards to the discussion. But I know the example with Boris, but it's quite an extreme because it's a fictional case. I think, yeah, and I think. I've personally come across a couple of cases where we've had disputes in our own centre, but fundamentally they have to be looked at case by case and just having an extended MDT discussion.
Thanks very much. Very interesting talks. It's interesting to hear both of you talk about utilitarian principles, which I don't think of as being generally applied to the paediatric population. I think when you look at the adult community, particularly the renal transplantation, that can be quite illustrative. We're pretty liberal with adults with limited life expectancy that we put on the list. You know, people in the late 70s get onto the adult kidney transplant list, and we don't have problems with that. And I guess when you talk about the GMC duties of a doctor with making your patient your first concern, whether really utilitarian ethics in such a large country or global population really perhaps don't have any bearing on our paediatric ethical considerations.
I had to play up to being an intensivist. It's fun. The way we would resolve any dispute is to sit down with the child and the family. We have a meeting with the teams, not just an MDT, we have an ethics group who work with children and their families with previous parents. So I'm playing up a little bit. I have to say the utilitarian stuff, we've gone so far against it now that I think we're coming full round to go, well, actually, if we lose it entirely, we will be in trouble quite soon when the next pandemic hits, because we'll be left with no frame of dealing with true overwhelming need based on a population out there where death rates are massively high because of a sudden infection. But I would reserve ethical thinking almost for that type of area to use utilitarian principles, if that makes sense. Everything else is much more for us based on the child's best interests and welfare. When you stick in front of the courts, they don't say anything about utilitarian principles. It's all about that child in front of you. I think the utilitarian bit on the GMC is down number 6. Use resources wisely.
Oh, this is a great discussion. I think that first of all, I just want to address some of the things in the sense that we as physicians, we have to take responsibility of this. If you know that the encephalic case, I know it's extreme and everything, you know that it's not going to have an outcome, it's our responsibility to provide the clarity. This is why we're not going to do it. Parents do not want to have that responsibility. I can assure you that. They don't want to have to say, I'm going to take the life out of my child. It's our responsibility to create an organized plan for that child. Now, let's say it's so controversial. There's a few blessings in Northern California, even though we're in California, is that we have 3 transplant centers in which you have a problem, you can get a second opinion or counsel from other institutions that family can go and feel sure that what you're doing at least have some backup. And third is, in our center, we have very intense palliative care work in all these cases in which at least provides a platform for very open discussions about end of life.
Thanks, Valo. Just picking up on that last point, on the adult side, and a couple of you have mentioned palliative care or conservative pathways becoming an increasingly important aspect of treating renal disease. And we're either not putting people on dialysis or withdrawing them from dialysis. And it's still in its infancy, it seems to me, in the paediatric world. Let me ask the audience, how many of you, show of hands, how many of you think we overtreat children with renal failure, either with dialysis or transplantation, that we're doing too much, we shouldn't be treating quite as many children as we are?
Can I just clarify, you're asking a room full of renal transplant. Do you want a job? This might be Turkey's voting for Christmas moment.
Does anyone think we're dialysing too many children? No? Okay, I'll put my hand up. Francis, do you want to comment?
No, not really. I mean, each case is what are you trying to get out of the scenario that you're presented with. Survival isn't the only thing.
I think, to my mind, the issue is when you're 80, someone says, well, look, do you really want dialysis? Would you rather go home and die quietly in your own room with your family around you? When you're 1 day old, it's much, much harder to have those conversations with the parents.
I think there are excellent comments that have come up. In the International Paediatric Transplant Association, we discussed producing guidelines, and I think one of the first things is we have to look at the world resources. So you could turn around and say the 20% who don't have access to dialysis and transplant that actually have a normal life that could actually have, if you're going to say, a better quality life than somebody with severe learning difficulties, needs to be looked at. But also nationally, the British Association for Paediatric Nephrology, we've considered having an ethics committee, but my strong view is you need to see the child. So actually having a room full of people where somebody's got a loud voice, but they've actually never met the child, and in fact you could then question it and say, well, who are we to make the decision? Because we see, okay, maybe Leslie has seen this patient over the last 9 years every single week, but look at the cumulative amount of time that patient has been in the home, in the school, in the community. And actually, can we come up with a snapshot decision? And I agree that inevitably what we do is we try and resolve the issues with the parents in what we deem to be in the patient's best interest. But I was going to comment, Nizam, as well, you're talking about adults, that I was really blown away by the one big centre in the United Kingdom who showed adults with severe learning difficulties that were living in social care homes, where the people from the care homes went to the committee to say, we don't think these adults should be transplanted. And the centre, against the people who are looking after them, decided that they should actually proceed to transplantation. So we're talking about, do we look at what the parents think, and in adults who don't have that backup, so I think it's a really, it's opening a minefield to actually know what's the best thing to do. But I still think we need to think what's in the child's best interest and try and come to an agreement.
Yeah. I just want to reflect on what Joe said about death being the enemy. In the Netherlands, we have, since a couple of years, a very interesting debate, especially in intensive neonatal care, not looking at, let's say, the situation, should the child live, but is there a situation where you should let the child die? So reverse the debate and say, of course, life is the situation that we find normal, but under any circumstance, is there a possibility that you could say the best interest for this child is not to live? And I don't know if you're familiar with the development of it is called the Groningen Protocol. And there they reversed the debate and said, from a medical point of view, we cannot see any, let's say, benefit for this child. So going on with the treatment is not in his best interest. But we have to explain that to the parents who naturally have the opposite view. And it's very illuminating to see these debates, how in the end the parents will accept it, and not only accept it, but also understand why the medical team says it. I think it's very, it's an exercise that you should do, not say, why should he live, but is there a possibility where he shouldn't live?
Very good point.
I think, according to the Netherlands, we have even a more previous possibility in the treatment, is that according to overtreatment with dialysis, what was your question, all the pregnant women have the ultrasound at 20 weeks. So I think in the Netherlands there are many children who are aborted very early because you see that there is a very severe renal disease, for example, when there's oligoanadromyan, or so we don't see many neonates anymore because of a phase which is even earlier than the neonate who is alive.
Any other thoughts?
Mike, I just wanted to ask you about that case you presented about the 16-year-old who donated a lobe of her liver. Do you think the outcome would have been different if it had been a kidney and there was no, you couldn't claim the regeneration bit of the argument?
Yeah, oh, sorry. I think the debate would have been very much the same, because the fact that the liver more or less is a regenerative organ was not the decisive argument. The decisive argument was that the girl was deemed to be competent. I think in the UK you have the Gillick competency, which is the outcome of a court case, which says that in this case the person, the minor, is competent enough to oversee the situation and, let's say, accept all the consequences. So I think it would have been the same outcome for a kidney.
Because, I mean, in my view, I think nothing makes you grow up quicker, I imagine, than having a child. So if a child, a teenager has a child of their own, it's completely natural and normal for them to want to help their own child.
In the California law, when a teenager has a child, that becomes an issue of emancipation. So they can make decisions on their own health care. This person is already 16, she's a mother, she has a right to be emancipated to make decisions for her child and herself.
Yeah.
So it's not Gillick, just to clarify for the English people in Welsh, it's not Gillick for over 16s, so Family Law Reform Act, the same. So a 16-year-old has a presumed right to consent to medical treatment, but it's meant to be in their best interest, and that's the question. Is this her interest, the child's interest? I think we would make an argument it is, but it's a little bit more of a further thing than a right to consent.
The pregnancy makes a difference.
I understand. I'm saying we're a little bit short of that.
It's the pregnancy.
Yeah.
Okay, I think what I'm going to do is wrap this up now because we're a little bit behind. I did promise summing up from each of you, but unless you feel strongly that you want to do that, we'll
I agree with Mike.
Okay. We'll continue the discussion over lunch. In your packs, you've got feedback forms. Please complete them for each of the lectures. And we're going to reconvene after lunch at what time? Can't hear. No, 1:45. 1:45. Thank you.
few more. Okay, we'll make a start. So welcome back. Hope you have all enjoyed your morning. I thought it was a very illuminating morning. And that lunch is just sitting quite nicely now. So no one's allowed to fall asleep for the next half, because it gives me great pleasure to start the afternoon session with Waldo Concepcion, who I think we all consider a friend, colleague, and international collaborator now. So thank you for coming back. He's a professor of surgery at Stanford, and he's the chief of transplantation and pediatric transplantation there. So we have been sharing ideas and thoughts and research and clinical collaborations. And he's going to continue the discussions that we had whether we should transplant children. Now we're going to look at transplanting lots of other organs while we're there. So he's going to start off and say, should children with end-stage kidney disease be offered pancreatic transplant as well? So Waldo, thank you.
Well, good afternoon. I hope to keep you at least with the idea that we are here to contribute, to have a dialogue, and most important, to try to answer questions that we don't have clear answers. Okay? Should children be offer pancreas transplant? Sounds like a very simple thing. We know how to do it. We have the technique. We know the stitches. We know the bowel. We know the immunosuppression. But why children? We have a different question. Uh-oh. Am I okay? Okay. I always like to see where did we start it. Right. Did I do that?
I think they're drilling for oil.
This one of the most important pictures that I like is that diabetes turned a different course when we started able to synthesize insulin. And these are the landscape of what advances have been done in the therapy of diabetes, that we have to always look back and respect these pioneers that brought so much to us. Anna, where are you? You were there with the founders and the development technique for pancreas transplant in Minnesota. That's a huge contribution, that we know that this organ was able to be transplanted without any risk for the patient, most important, with success. Why are we talking about that? Because diabetes has a role in civilizations, here and wherever we go. United States, the #1 cause of renal failure is diabetes. The #1 epidemic in the United States by the year 2025 is morbid obesity. 60% of population is going to be considered obese. And every time that you talk about diabetes, is there. We have to deal with this. We have to learn what can we do about it. In the day and age right now, if you talk to endocrinologists, how do we manage diabetes besides medical? Most important to tell you, we have the best right now, actualized, computerized, glucagon, insulin-based sensors and delivery treatment. So therefore, I will not send you a patient for pediatric transplant, for kidney pancreas transplant. That's my center, and that's many centers I have visited. So why should we talk about it now? Let's see if we can find something. The insulin pump has changed from being a deliverer now to sensors that can even, in their literature, in the endocrinology literature, is considered artificial pancreas. So all of these therapies, as much as they do, they create some sort of euglycemia, but still we have challenges, am I right? The goals of pancreas transplantation, as we know it right now, is correct impaired glucose metabolism, prevent or stop progression of secondary diabetes, and improvement quality of life. We all agree on that, am I right? The issue is that most of our experience that we have on treating diabetes on adults. Most of our experience, we know that it takes 10 to 15 years to have renal failure in order to have in the diabetic population. So when we talk about children, that's probably not our common pathway that we're going to be doing with pancreas transplant. The best therapy that we have for diabetic nephropathy is simultaneous kidney pancreas transplant, type 1 diabetic. We know that. That's what happened. We are doing it. But how many of our patients that we see every day in children qualify here? Very few. So we're learning from the adults, but we still don't have all the answers. This surgical technique, we know it. You guys here, when you present your lectures, they're outstanding. The surgical skills to prepare this graft, to select them, to implant them, and all that, we have already all that knowledge. In my training time in the 80s, we didn't use this. We used the bladder. And we were experts on bladder, but we learned very quickly that bladder is not a good option in the long term for patients for many metabolic complications, erosion, cystitis, bladder cancer, metabolic, whatever it was not a good option, so we went to the bowel. And we learned that if you put it in the right place, The exocrine function of the pancreas can be absorbed with time. You don't have this massive diarrhea if you put it too distal. That's a very poor representation, but it is. And most important, offers an excellent treatment for patients with diabetic type 1 renal failure. So this is what we consider the standard of the surgical procedure for the type 1 diabetic patient with renal failure. I'm going to bring this slide to bring you to reality. The reality is a pancreas transplant. You have to deal with wound infections, peripancreatic abscess, thrombosis, pancreatitis, duodenal leak, rejection, and arterial aneurysm. This is the reality. What's the percentage may vary. Hopefully we're doing much better, but this is a reality, okay? And when you look at this, you're going to say, well, I'm going to do a procedure for a child, but the options of complications are this one. It makes you think twice. Well, have I exhausted all the technology and non-surgical treatment for these patients? Do we have the right complications? In the adult, we know. If you have unconscious hypoglycemia, you have starting to have the nephropathy, we know when to indicate it. But in child pro, you're not going to find that. How are we going to put the complications of the procedure, the success of the procedure, based on this? Let's go one step forward. If I ask the surgeons here, what's the number one cause that predispose patients to have these surgical complications? Quality of donor, we can say that's probably in the top of the list. So, do we have a system that if we want to do a pediatric, you're going to get the right donor for the right patient at the right time? Things to think about it. Now, let's go to see what pancreas transplant doing this day. This is the latest data from SRTR, and you see that the diagnosis of this, most of them are going to be type 1. You see most of them are done. But now we have a group of population that we are thinking that we can do type 2, and we're doing type 2s for patients that are developing the same characteristics of type 1. We can see age. This is a very important slide for me. It shows that patients less than 18 years old is a constant number, very low, less than 100 adult in the United States. What's the problem with that graphic? If you look at all the SRTR data, nobody describes what happened in this group. Who is doing it? For what indications? And what are the long-term outcomes? You can review all the literature in PubMed and all the literature in everything that you have, and we don't have a series larger than 7 patients that describe what happened in this population. So therefore, it's upon us to start looking at this and say, well, what do we really need to do? Looking at the type of graph, you will see that most of the patients that have been done is approximately 800, 700 of simultaneous kidney pancreas transplant. This is according to age. But look at the curves. If you look at the curves in the United States, what's happening? They're not going up. As a matter of fact, becoming less. Why is that? One of the questions, I'm sorry? There are a few things. One is that maybe that they're dying on the list. That's one, the disease progresses. Number 2 is that probably have better medical management. Number 3 is that we're probably still very stringent with our criteria to do kidney pancreas transplant. Whatever the reason, you will hope that with the donors, when I started transplant, when I started my career transplant in the United States, the donors were about 5,000 a year in the United States. You know how many donors we have in the United States right now? 18,000 per year. This should go up here. Things to think, why? And why we're going to talk about kids. Here we see the patients already. We're going to go forward with this. These are a different type of graph, simultaneous kidney pancreas, pancreas alone. All these are showing here the percentage of them. This is one of the things that I want you to start thinking. Incidence of PTLD. PTLD is a reality in children. And what is based? On immunosuppression, EBV status, and other aspects. EBV is a reality in adults. And when you're talking about kidney pancreas transplant, you gotta think about you have to upgrade your immunosuppression to be able to prevent rejection, but at the same time, you're starting to see the PTLD. Should children with ESRD be offered pancreas transplantation? Do we have answers? Well, let's look at what information is available in the literature. Don't believe me. Let's see what is in the literature. Minnesota published their first 1,000 cases, and out of the 1,000 cases that were done in the period of time mentioned here, just 7 were children. 4 children received pancreas alone, 2 children received simultaneous kidney pancreas for a typical HUS, and 1 children received liver pancreas transplant. This data probably is not accurate completely, because we're doing now pancreas transplant in multiviscerals. We're doing pancreas transplant for liver, pancreas, kidney, liver, pancreas, maybe even lung for the cystic fibrosis. So we are having more experience with it. But the only series that we have available that have seen these patients and determine what it is what we have here. Out of the patient, the outcome that were published, it is right here. 4 children received the pancreas transplant, only 1 graft survived 4 years. 2 children that received simultaneous kidney transplants, they are alive more than 5 years, and 1 child is alive that received the kidney pancreas, the liver pancreas. The data that we have, we can go to simultaneous single cases here and there, but for the case for today, this is as good as we have, and most important is that we had to learn that diabetic nephropathy occurs mostly in childhood and beyond childhood. Simultaneous kidney pancreas transplantation offers the best outcome. Graft quality produces the best outcome. And pediatric indication for simultaneous kidney pancreas transplants include different etiologies, including atypical HUS. Now, knowing this, going forward, what do we need to do to make this a reality for children? Let's look at what are the goals that the American Society of Diabetology and other places that look at what is the success, what are we looking in the treatment of diabetes. Most important is that the premise that we're doing this is because they say that if you have an intensive therapy and aim to lower glycemia, the result decreases rates of retinopathy, nephropathy, and neuropathy in the type 1 diabetic. That's a primordial thought that we have to think. Is this the best that we can do, that we have failed any type of technology to accomplish this? Is pancreas going to offer you that? Number 2, intensive therapy of type 1 diabetes decreases fatal, non-fatal cardiovascular events. Is this something that we are concerned in the early stages of children? Probably it's not the number 1 cause that we would do it, but definitely has effect on the long term. All these other aspects can tell you that the pumps, right now the incidence of diabetic compensation with a new set of pumps and sensor has decreased this amount of complications. So the goal for transplantation is to allow insulin dependence, improve quality of life, and reduce secondary complications. Remember that part there. Improve quality, insulin dependence, and reduce secondary complications. So, patients in end-stage renal disease to have a kidney transplant candidate for pancreas transplantation? Yes. Is that something that is for us in children? Question 2 that we need to solve. Are there patients without substantial renal disease candidate for pancreas transplantation alone in this point and where we are right now? Something to consider. One of the aspects that we have so much hope that we're still looking at it is islet transplantation. Is that for us, for children with kidney disease and islet transplantation, an option? The numbers of transplants I mentioned before, they are completely getting flat and a little lower. Survival is good. We're learning a rate for kidney pancreas. But what we're trying to do is what is the optimum? We have to give a good shout out for pancreas. What is pancreas does that a pump cannot do? Normal insulin response to oral intravenous glucose stimulation. Unfortunately, pumps cannot do that for us. The basal and stimulated peripheral insulin concentration is 2 to 3 times higher than normal. The pancreas does that very efficiently. The pumps still to see. We all have other effects here that we can do, but most important is what are we going to do today for adolescents? We are trying to see, we know the complications, we know how the pancreas transplant decrease it in adults, but also we have to realize that we still have to be in immunosuppression. I'm not trying to give answers today. I'm just trying to see all the points that we have to consider, to put together, to find a protocol, to find a reason why to do pancreas transplant on pediatric. All these patients are going to be in immunosuppression. All of them are going to need induction. And most important, if you do pancreas, you gotta be ready to be able to do early diagnosis of rejection. Islet cell transplant is coming up. And if you look at the UCSF data that published last year and this year, the results are coming better. Multiple transplants are able to be done and create good graft function, and even better than this. So, to conclude, what can we learn? What can we do with pancreas transplant for pediatric patients? We want to increase the insulin secretion. We want to provide a better quality of life. We want to prevent the complications. We want to be sure that if they have renal disease, this will be the patient that we want to approach. The evolving technology of islet transplantation is still not ready, but hopefully in the next future. And most important is upon us to create trials that answer this question. We can talk here the whole day, but we don't have the data to push any way to go. But more important things, we gotta create in this group studies that answer this question. Right now, we should not be doing one here, one there. We should have a protocol to really answer this question comprehensively and that we can disperse the information. I don't have much more because I think that it's a good discussion we should have here. Should we do it? What are the cases? How many have seen HUS that need both organs? What can we do different than what we're doing now? Thank you.
Thank you very much indeed, Waldo. That was a wonderful well-stop tour. So in the last decade, we've had a couple of cases at Great Ormond Street. One we had a debate about where, in fact, because they generally are adolescents, is whether they should be managed in an adult unit that are doing SPKs more commonly, and the other is just gone off to adult care anyway. Do you think, are you happy these patients being managed in the paediatric ward if they're not akin to problems, as you've said, of having leaks, duodenal leaks, fistula formation?
I think that your team goes to both sides. I think that to make a case for just doing it in adults because they have the most experience, still, it's probably a little less founded having the team going both sides. Number two, the pediatric diabetic teams in this institution, the institution probably excellent, that this is the type of support a patient needs. I think that for me, the priority would be, first of all, is to create a system that makes sense. Who are the patients we're going to do? Number two, we need to do national decisions. This patient has to get the best donor, the best outcome that we can offer to this, because there are not going to be that many. And the third is to standardize the indication for it.
Does MD have experience of SPKs in under 18-year-olds?
I was going to ask a question actually, but my experience in Manchester with SPKs in young children was not really very good, to be honest, where there was a mortality in a child that was because of post-graft pancreatitis. But the comments I was going to just say is that, you know, in the last decade or so, the biggest kind of changes, improvements have been in our number of live donor transplants and our probably marginal or DCD grafts. Both of them don't really apply to pancreas. And even though I think it's an issue that most centres have had, that the numbers haven't climbed, in fact falling, I think the conservative approach is the safe approach. And I don't know whether you think there is a future of being aggressive or being marginal graft pancreases for transplant.
Great question. I'm sorry, Nicos.
Yeah, I mean, Nizam did one in a 16-year-old in, I think it was 2006, early 2006, and she spent the next 4 to 6 months in hospital, real laparotomies. She had rejection, lost both grafts, and subsequently she did have a kidney transplant, but she's back trying to get another kidney now, and she's she didn't do very well, basically. So that's our experience.
My experience with young recipients is that the vasculature structure are completely diseased. It doesn't have to be obstructive. It has to be the disease between the different layers. They dissect very easily. I was telling Nicos that one of my first cases was a young lady, very young woman, that was done for indication that probably they were there. They're probably not even beyond 19 years old. And the most important thing is that these vessels are so frail that she ended up dissecting both legs and amputations and long stuff. So we have to be very careful what type of procedure are we trying to do on these patients and to try to offer this technology. I think that we need to be very conscientious about creating parameters, protocols, and organ allocation for this patient.
Okay, last question from Leeds again.
Hi. Just listening to what people are saying in the room, it sounds like nobody's really got any good stories about this, and it's actually just all catastrophe after catastrophe. And so I'll pose a slightly different, is this an inappropriate procedure for a child because the surgical morbidity is so high? It's a great idea to have protocols and everything like that, but in the US you've done hardly any, so here we're going to do even less than that. You can't really develop protocols for numbers of patients that are that small because you don't really have any data to go on. So you're sort of just, you can make something up, but you don't know if that's going to work or not. Given that most of the renal failure is going to happen when they become an adult, should we not be looking at islet transplantation or improving the technology to get them into adulthood, and then if they're still having problems, you can consider an SPK then? Is this not an inappropriate operation for a child?
Well, I think that one thing that I'm learning, since they gave me this subject to talk about it, I have not lived but looking for cases. I worked for 3 months looking for people doing this, and essentially you can't find them. But everybody has one here and there, one there. So I think that we need to continue to look in this. One of the patients that we're not talking about, that probably tomorrow we're going to talk about, MMA patients. When they have the severe crisis early in their life, they knock out the pancreas. And they're brittle. You want brittle diabetics? Look at the MMA. So can we consider this an indication in the future when we really think about this and have guidelines to add more diagnosis? Diabetes is probably not going to be our number one, but the other things, a typical HU is a severe that thromboses everything and knock out the pancreas, kidney, and have a stroke. That patient is going to recover, but it's going to end up with a diabetes and renal failure. How can we do this? Is the full organ transplant the best option, or islets, or what else? But we definitely need to set up a protocol, a consensus that, like a national level, to put these cases together. You guys are good friends to everybody here, not the United States. We are very divided, but you guys can do something very good is to put these cases together, learn from them, find commonalities, and most important, do the best for the kids.
Okay, well, thank you very much indeed, Waldo. We can have further discussions in the coffee break, over dinner, and even research breakfast tomorrow. Okay, so we're going to change tack a little bit from transplantation. So we're going to have a double act. We're going to start with Francis Calder, who's one of the wonderful members of the transplant surgical team here, the Evelina and Gosh. And he's going to explain why I say that both Francis and Lindsay, who's our advanced nurse practitioner, are magic. Why are you magic?
So many reasons, Steve. So thank you very much, Jelena and Nicos, and everyone who's organised this today. We're just going to, Lindsay and I are going to take a little trip through this topic with you. Why, which children with end-stage renal disease should have an arteriovenous fistula, and why? This is what end-stage looks like in the UK. If your kidneys fail, majority of people will start their life with PD. A certain percentage, 20-25%, will go straight to transplantation, but a significant number, 30-odd%, will experience hemodialysis before any other therapies. And this is what it looks like in the UK. Life on hemodialysis. You have your mother there, probably single parent by now. The male component has got fed up and disappeared. She's injecting all her time and effort in looking after you and any other children in her life. You have the dialysis nurse who's happily flushing the ports and managing the child's catheter. He's a bit fed up because he's not really allowed to go swimming with his friends, but he knows how life is at the moment. And this is not just representative of the UK, this is Europe, this is the US as well. This is what life is like for most children on hemo. So why get into this, ladies and gentlemen? As you can see, this young man doesn't look so pleased. Why have an arteriovenous fistula? Okay, he knows he's going to get a transplant. Most of our children are. But as we've seen, they're going through this revolving door of dialysis, transplant, dialysis, likely, again, before they emerge into adolescence and then into the adult world. And as someone who works in paediatrics and adult, we need to take a very long-term view of how we're managing these young people and then young adults, because this renal failure thing is a lifetime commitment for them and us. It ain't going away, folks. Some people sadly, are going to rotate through that door faster than others, aren't they? And if you're unlucky enough to have some of these recurrent disease problems, you can whip round in a few weeks or months. And this young lady reminds me of a case of a young woman with FSGS who then got recurrence, and now she's enjoying life with a catheter which keeps coming in and out. She keeps interrupting her plasma exchange therapy for her FSGS because the catheter doesn't work or the catheter gets infected, and all the while her creatinine is tripping up and up and up. And I kick myself for not giving her a delicious fistula earlier in her life because I pretty much know she's going to need it after the transplant. Yes, I understand it. It's the Big Mac meal available at every train station you happen to visit. It's quick, it's cheap, it's convenient. Everybody knows it. But all that sugar, all that fat, all those calories, is it good for you in the long term? The answer is no, ladies and gentlemen. You know it, and I know it. And particularly when you're a small person, you're in trouble in a very short period of time, and you end up with this miserable look in the outpatient environment with these dilated veins over your chest wall. And if you bother to do the angiographic investigations, you're left with this exceedingly depressing picture of central venous obstruction forevermore. Okay. And then you start to develop other problems. We've seen this recently, child who started coughing up their chylous fluid, which is accumulating in their chest and their mediastinum due to having numerous lines. So she has venous and lymphatic hypertension, and then when you develop this, you're in a very serious situation. Multiple chest drains in, draining the excess chyle in your chest, limitation of your diet, maybe parenteral nutrition, maybe asking the thoracic surgeons to try to ligate your lymphatic duct or do pleurodesis. You're in a miserable state, and it's avoidable. But this was a new diagnosis on me earlier this year. You can go from that chylous state to getting this, plastic bronchitis situation, again, where your lymphatic and venous hypertension is so significant that the proteinaceous material continually leaks into your alveoli, and you cough up these little proteinaceous squids, which are in fact the alveolus and terminal bronchi, and by this time you're stuck on the ventilator. And it's only, this is an example of the patient's angiographic results. This is just the azygous vein coming into the tip of the SVC there. And the child also had complications associated with pulmonary emboli due to the presence of the catheter. And it's only heroic, repeated interventional radiology that we managed to finally get the child off the ventilator. But by heroic, I mean dangerous techniques and consenting the child for death on the interventional radiology table. Don't go there. CRAT. This is something not slightly mentioned in the adult literature, and now coming into the paediatric literature, we've got a series which is catheter-related atrial thrombosis, where the catheter sits in the SVC or right atrial junction. It's not in a static position. Every time you breathe, your chest rises. Every time you move your arms, your chest rises. The catheter jumps up and down and sticks the endothelium of the SVC or the cardiac atrium. And you get thrombus associated with the catheter and the damaged wall. You can show it with CT angiography, or we've performed a surveillance scan with echo cardiography of children with catheters. And this is going on behind your back in our series, which we're yet to publish. 20% of children with these catheters will develop these CRATs. And some of them will end up on the post-mortem table. In our experience, about 10% once you've diagnosed it. So it's a very, very significant thing, and it's going on behind our backs at the minute. The other thing is hemodialysis is not equal. You can have it via a line or you can have it via a fistula. We know from the adult data that these are not the same, and now we know from the pediatric data that the same rules apply. If you have your dialysis with a catheter, you're going to spend more time in hospital, you're going to have more infections, the quality, the adequacy of the dialysis is poorer. So why don't children have these fistulae more frequently? We know this from our experience and worldwide. We surveyed the UK about this, but it's pretty much the same elsewhere. I understand the reasons. People are very conscious, just like you and I, about their body shape and form, and they don't want a damn fistula. Yes, I'm sympathetic, but they don't want the damn renal failure for the rest of their life either. And if you approach people properly and you offer them good psychological preparation, there are ways to get around this. They're all going to get a kidney transplant. Yes, they probably are. But if you don't have a live donor in the UK, the waiting time is about a year now. And we already know that there are a number of people who are going to need more than one transplant. They're harder to transplant the second time. And there's this recurrent disease problem, which is very significant in children. Nobody wants to be needled. Yes, I understand that. And Lindsay's going to talk about some of the approaches that you can use to actually get over this. The surgeons aren't interested. Yeah, well, the surgeons like surgery, and I would say that surgery is about 20% of actually keeping a dialysis program going based on fistulae, but the surgery is just surgical technique, and whether we live in Serbia or the UK, you can teach the damn surgeons these techniques, but it's really a team effort to keep a dialysis program going, and the assessment of the patient before the surgery, the surveillance after, are also key components. And finally, the dialysis nurse, he or she may not be comfortable. She understands how to manage the line and is happy with that, so they may need some competence and confidence in order to learn how to manage children with fistulae and their parents. We live in the real world, and this is our strategy approximately. We would say if you're before dialysis and there's no live donor option, come and see us in the vascular access clinic and we'll try and talk you into a fistula. If you have got a live donor option, avoid dialysis, go straight to transplantation. We see people with hemodialysis catheters, as you can tell. Again, if you've no live donor option, we'll give you a fistula. If you do have a live donor option, okay, keep the catheter and then just proceed to transplantation. Because it takes, in our experience, about 6 months to get through the assessment process, have the fistula matured, and then to become used to dialysing through that fistula. By that time, we should have turned around your live donation. This is absolutely key to working with fistulae in your dialysis program. You've got to think about preserving your veins. And James can't bear to look, I can't bear to look, because his venous potential is being killed by this well-meaning phlebotomist. And we can't allow it. And you and I have to be constantly vigilant about this and invest in programs such as wristbands, lanyards, DVDs, to hand over the responsibility to the child and their parents so that they can look after their veins for now and evermore. And just in case you were concerned about where to bleed them from, this is where you bleed them from. The back of the hands, either hands. And if you can't get in there, this is where you bleed them from, the feet. And for a smaller child, this is where you can bleed them from, the external jugular, and not in their arms, please. And then when you've had your lovely transplant, whether you're a body-conscious young lady or a little troublemaker like this man, you've then retained your venous option for the future, and you can train your staff to take the venous bloods after dialysis through the fistula and maintain their venous reserves for the future, because you and I know they're going to need it. I'll hand over to my friend.
Thank you. So I'm Lindsay. I'm the advanced nurse practitioner on Eagle Haemodialysis at Great Ormond Street. And I'm basically just going to talk to you about how do we actually practically get this to work in children. How do we get children to allow us to put needles in them 3 times a week? And I think one of the difficult things that we do see now on haemodialysis, we're seeing more of these children coming through the door, losing access, really anxious parents as well, and I can name 2 or 3 parents on the unit, on my unit at the moment, that are really anxious that they haven't really got much further access to go. So a little bit about our unit. We're a 10-bedded haemodialysis unit. Our numbers are slightly down at the moment. We're usually closed, but we're open at the moment. We've got 15, I've cursed myself now. We've got 15 in-centre haemodialysis patients. We've currently got 9 on home haemodialysis. At our most, this time last year, we had 16 on home haemodialysis. Currently, we have got 10 children with fistulas. We've got 2 that are on the waiting list. Again, this time we're slightly lower than what we were. This time last year, we were at 50% fistulae. And we really do encourage self-needling within the unit and trying to get children to actually needle their own fistulas. And currently, of those 10 patients, we've got 6 that self-needle, or parents are needling. And as a team, we are very much looking at fistula first. So one of our biggest problems with children, or perceived problems, is needle phobia and needle anxiety. So how do we actually get these children to needle? So one of the things that I asked the children on our unit was, what makes them scared of needles? What's their biggest concern with their fistulas? So starting at the top, what size needle are you going to use? And some thought can be put into this. There's different size needles, there's different size lengths as well. So look at your fistula and actually see, do they actually need the biggest needle? The biggest needle might give you really big blood flows, but do you actually need that huge needle to give them clearance? One of the things to look at is the length of the needle as well. And a lot of people are set on this 25mm length needle. That looks absolutely huge when you come towards a child with it. And a lot of the time you could get away with a 20mm, 15mm length needle. So it's really worth looking into what your options are for that child. Scab picking is a really difficult thing within the unit. So we do something called buttonhole technique needling. And for those of you who might not know what that is, it's where we go in the same hole every single time, and it kind of creates an earring hole. What you need to be able to do for that at the beginning of every session, you need to pick the scab off the hole, and that can be a really big thing for a child to actually pick that scab, and quite traumatic for them. So usually we recommend they use something like Emla cream, Amitop. They try and get them to pick it themselves. I probably shouldn't say this, but if I'm really struggling, even get them to use their nails to try and pick that scab off after they've washed their hands. You've got to look at different coping strategies for each child. So most of these children have been in healthcare all their lives, and they will have their own coping strategy for how they manage having needles just for general cannulation, and whether that be, I'll speak about that in a bit, but that might be music, it might be a sequence that they have to go through, and it's really important that we adhere to that for them. Most of them have got past experience with needles, so again, it's breaking through some of those problems, and I'd very much recommend that if you've got a good play specialist, they are the person that's going to make this possible for you. There's a lot of pressure on the dialysis nurse, and the first thing we get is, will you get it in first time? So there's a huge pressure on the patient, but there's a huge pressure on the dialysis nurse to get that needle in first time. And they aren't always very forgiving if you don't get that needle in first time. So I think when you're looking at training your staff, because we are small numbers in paediatrics, we've got to get staff trained on being able to do needling. I learned when I went to the adult services, I used to work up in Newcastle and I got sent to adults, and that was invaluable for me to actually learn on a community, a much bigger community, and that made me feel much more confident when I came back to actually have to needle children. So for anyone who has got good links with adult units, I'd really suggest that you touch base with one of your adult colleagues to see if you can form any relationships between. We've talked about needle technique briefly. There's 3 needle techniques that you can use to needle fistulae. You can use a ladder technique, which is basically where you move the entrance point each session. Most kids don't like that technique. They're very focused on where they want you to go every session. Then you've got something called buttonhole, which I've already talked about, like an earring hole. One of the things that we do tend to default to is something called area puncture, where we go in a small space all the time and we move the needle hole probably about 1 or 2 millimetres. That's not ideal, and you can have more problems with your fistula. But the problem again with paediatrics, we're very much led by our children as well, and we've got to kind of meet them halfway. So we are very guilty of probably sometimes doing area puncture in paediatrics. Trust is a really big thing. Now, when I say children aren't forgiving, if you've put that trust in you initially, then they can be forgiven. So we've worked with lots of children who are really needle phobic and usually manage to get the needle in, but if I can't get the needle in, they're usually quite forgiving of me and they will let me try again, but it's taken a lot of work initially with them to get to that point where they've gained that trust. And don't lie to them. If you tell them you're going to go in a place and go somewhere else, then you've lost their trust straight away. Children tend to like control as well. They've got so little control when they're on dialysis, but one of the things they do get control of is whereabouts you actually needle them in the first place. And this brings me back to where you end up going in a small space, because they will let you go in different areas, but it might be 1 millimetre, 2 millimetres away from where you've last gone, which isn't ideal. But again, to work with them to build trust, you've got to allow them some control. You need a lot of time when you're establishing a new fistula. So for some children, I know it's taken me up to 2 hours to get their first needle in, and you've got to be able to invest that time. And I know that's where my adult colleagues would say they find it really difficult to move it forward. But in paediatrics, it's really, really important we give children this time. Pain, simple things, use EMLA, Amitop. We've got a lot of children saying, oh, I don't want it. When they've got their fistula, I make them do it. I won't needle them for the first time if they haven't used EMLA or Amitop. They get very obsessed with who's doing their needles, and they tend to like the same people. Again, we're small units, so we don't like children just to focus on one person to do their needles, but I do think in the early days, if you can get your experienced needlers establishing access, then you can eventually start filtering through some of the less experienced staff. And of course, the fear of blows or infiltrations. It can be really painful when they're below their fistula, and it becomes quite scary. It can get quite bruised. So again, it's reassuring the children. So this probably should be my play specialist talk, because it's mainly the work that she does. But we do a lot of work around preparation and desensitisation. So we work with kidney books, role play, messy play. We write step-by-step plans. We have coping techniques and reward charts. And this is just an example of someone's kidney book. And it's a way of them documenting their journey, documenting their fears. They do a lot of work with them before they start cannulation. And the kids really report that this really helps in the preparation for cannulation. We do a lot, or our play specialists do a lot with role play, and actually letting them use the needles, get the needles out, look at them, needle their teddy bears. You can paint with the needles. Do something to actually help desensitise to that needle. And their messy play. It's amazing what you can do with all these needles. Obviously, they need supervised. And you can put glitter down them as well. Patient plans is something that we do for absolutely everyone that comes through hemo. So it's a very plan of what will happen the first time they get their needle, and the patient works on it with their play specialist, and they go through, we as staff have to adhere to it. We go through the steps every time, because routine helps a child who's anxious. I'm not big on reward charts, but we do use them. I think when you use a reward chart, you've got to be very clear how often you're giving a prize out or what reward you're actually giving a child. We probably say once you've done your first needle, you might get a small reward. 2 needles, you get a small reward. But at the month point, that stops. Because otherwise you could be going on for months and months with giving presents out for getting needles. Various children will have different coping strategies. This young girl in the first picture, she had a breathing technique, and actually that came through from when she was actually just having cannulas before she even got her fistula. And she would breathe, take some really deep breaths, and at the point where she held her breath, that's when you're allowed to put the needle in. And that worked really well for her. The girl next door, she had a sequence, and her sequence would be you'd count up to 10, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. You'd spray the cold spray 4 times. Then you'd count down from 10. Then you'd spray the cold spray again. And then you were able to go. And it sounds like a really long, drawn-out technique, but it really worked for her. And then we've done music as well. The same child, when we first started needling her, used to get needled to music, and Frozen was the song at the time. Definitely not me. I never thought about asking Francis, though. Option. So I've talked about self-needling. So why encourage self-needling? It gives them some control back in their life. So the youngest self-needler that we've had was 7 or 8 years old, and she did her needles really well. And again, that was her, she wanted some control back over her life. We did have a 3 or 4-year-old that had we given the needle, he probably would have done it, but didn't feel quite right to let a 3-year-old do their needles. It's less painful, they say, the children, when they needle themselves. They have a reduced fear and anxiety, because what they don't have is that coming in and looking on the board, who's doing my needles today? They've got control over it themselves. It's better for the fistulae, it's promoting independence, and hopefully eventually it could maybe lead over to a home haemodialysis programme. This is just a girl who did her, so this girl came on leaps and bounds. So the first time I needled her, it took 2 hours and she bit me. And she did her own needles this day. Now, she did do it closed eyes. She, with a little bit of help, she closed her eye and held her breath and stuck the needle in. But again, it worked for her. And you can see actually how proud she is. She's so proud of herself, and that just instills confidence. We've talked a lot, or Francis has talked a lot, about preserving vascular access. One of our registrars did this, which we hand out to patients in our vascular access clinic. It's a respectfully object and asked to reevaluate, and that's saying just have 2 attempts at getting my bloods, but don't use my arms. We're currently working with Gosh Arts to see if we can take this project a little bit further and actually get patient involvement to see if we can reduce the amount of cannulation in the arms. Just a few examples, so some difficult access that we had. So patient 1, he was 3-year-old, he had 11 lines, 2 periods of time on needle, on hemo. So the second period of time he came back, he was 8, 9 years old, and within 2 weeks he was self-needling on the unit. And that had a bit of a ricochet effect, so 3 others on that same unit started needling within that week. This young girl I've talked about, she was severely needle phobic and came with quite a past history of having some bad cannulations. And what she needed some control and she needed time. She initially started with this music sequence, which worked. Then she changed her sequence into this 1 to 10 cold spray. And eventually we got her home needling, and actually she now self-needles herself at home. This young lad was probably our most difficult child, and actually it took 18 months to establish needling on him. He's got behavioural issues, autistic. And one of the mistakes I made was I'd said to Mum had said to me, you've just got to hold him down and do it. And I thought, you can't do that in paediatrics, can you? We don't hold patients down. So we worked with him, and actually we made him worse. And what we did need to do was just get on and do it. And as soon as we did that, and we took the line out at the same time, we managed to establish needling. And this mum needled successfully at home for about 3-4 years. We're not always successful. We've had children where they've been so scared we haven't been able to manage to get them needling, and we've had fistula mutilation, at which point we've had to tie it off. But overall, in summary, we can use AVF successfully in children. It really is a team approach. It needs everyone on board, and it needs some positivity, particularly from the nursing team. Use desensitisation techniques, individualised plans, trust and control is important, and it's unit culture. We think fistula first. And I'm just going to leave you with a very brief film.
We know there are two ways to have dialysis, to have it with a line or to have it with a fistula. A fistula is a connection between an artery and a vein, and it's a small but delicate operation, either at the wrist or at the elbow. Our experience shows that with a fistula you get better quality dialysis, that is, the blood is cleaned better with the fistula. Also, that there's a much less chance of getting infection with a fistula compared to a line. And thirdly, that the fistula will actually last much longer than the line and have fewer problems once it's running nicely. One of the problems with being a dialysis patient is that lots of people want to take blood from you the whole time to look at your blood chemistry. And it's very, very important that the child and their parent understands that the veins in their arms, both at the wrist and at the elbow, must be protected from people taking blood from them. There's no specific age that you have to be to have a fistula. Our experience tells us that if you're 10 kilos or above, then you can be suitable to have a fistula depending on the quality of your veins.
Basically, what we have to do is clean it, wash it over there by the sink, and then we come here and we have these crackers that we crack, and we wipe it on our dots where the needles go in. And then if you have scabs, you pick it, and then you clean it again, and then you have this thing called a tourniquet, and then we put it around our arm to make our vein, the vein inside, well, vein and artery inside, come to the surface, and then we put it in. When the nurses usually do it, I feel it hurts more, but when I put the needle in myself, I can feel where it's going, so it don't hurt.
My play specialist Lindsay helps me and tells me what to do. Lindsay was showing me how to self-needle with the toys, getting all the equipment and doing it on the toy as if I was doing it on myself to get me ready and to help me understand how to do it properly. It's very helpful because if you start on something that you can learn on easily and it's not you're not doing it on yourself, then you're going to get more confident, so it brings up your confidence to help you start doing it on your own arm. I see all the little children doing it, and I just think that if they can do it, I can do it. I can be brave as them.
It takes time to build up that trust in a parent to suddenly become a nurse or, putting needles in her arm. But that happened very quickly, and that was one of the most valuable things that was given to us. That it's something that gets formed between, parent and child. There's a different level of trust.
When you first hear about fistulas, it is scary. Like as a parent, you think this is a big thing, but it's not as scary as what it seems to be. The more you do it, it just becomes so easy because you just know how to do it. Like it's so straightforward. You're not scared. You're not. When you first start, you're all jittery and you want to make sure everything's right. And now it just becomes like second nature. You just do it. You just know it like that. If it's something he needs to have and it's going to make his life better and it's going to make our life better, then it's just something we've got to do.
Fistula is better than the line because I can go swimming and I can do more activities at school.
With the line, she used to get an infection every other day. And with the fistula, it's safe, no infections. She loves to go to swimming. She loves to have a full bath. So because of that, she wants to have fistula.
My needles don't hurt me. I like my fistula because that I can go swim.
it's not something that every child goes through. But like a friend said to me once, you can always face your fears, which is, I think, was very important to me. And it took quite a lot of time for me to get used to it, but I think now I'm happy that I went through it, and I find that it's better. I just love it, yeah.
Okay, well, thank you very much indeed, Francis and Lindsay. That was excellent. I think beautifully portrayed. We decided we won't have time for questions because we showed that video, but I think it was really important. And to continue the analogy, this weekend it's just been announced that Uber Eats does McDonald's delivery. So we will deliver you our transplant surgeon to any of your units if you need any assistance. So thank you, Francis and Lindsay. We're now going to move on to Nicos, who's the lead paediatric transplant surgeon in London at Evelina and Gosh. And we've had an interesting case between the two centres, and he's going to be telling us and instructing us about doing parathyroid transplantation. So we've talked about hearts, we've talked about pancreas, we've talked about kidneys and other organs, and now we're going to the parathyroid. Nicos, thank you.
Thank you, Steve. So yeah, we've heard about a number of different organs, and you're going to say, well, parathyroid, what's he talking about? So let's talk a little bit about the why first. Well, autotransplantation has been happening for some time with respect to parathyroids. So in ENT surgery, head and neck surgery, where the thyroid gland is removed for cancer, for example, you can then preserve some of the parathyroid tissue and auto-transplant on the same patient, usually in the forum. And in renal failure, indeed I do all the parathyroidectomies here. You can do either a total parathyroidectomy or 3.5 gland parathyroidectomy, and that other half you can either leave it in the neck or cut in small pieces, put in the forum to try and preserve some parathyroid function. So some of these things have been going on for many years. What about allotransplantation? Well, when you look at the literature, there is some work, but usually very small numbers with respect to this topic. So in this particular paper from Turkey, they took 4 donors. There were patients with renal failure. They had hyperparathyroidism. They took, they did 3.5 gland parathyroidectomies, and then took some of this tissue to produce cells and cryopreserve them, and then transplant them in different recipients. And they used some steroids at the time for a short period, and 7 out of 10 recipients have showed successful function. And you can see here the PTH going up and staying up in these cases. But these were not associated with any kidney transplantation. And one of their arguments was that the parathyroid cells do not express class 2 antigens, and therefore rejection is not necessarily going to happen. Now, so the reason to do it is for patients with hypoparathyroidism. And I'm going to sort of take you through the argument. So there's a number of causes of hypoparathyroidism, as you can see. I'm not even going to attempt to go through all of it, but some autoimmune disorders, genetic disorders, resistant to PTH action, and drugs, just to summarize a little bit. So I'm going to talk a little bit more about autosomal dominant hypocalcemia, where essentially you have low calcium and inadequate parathyroid secretion. And ADH, there's ADH1 and ADH2, and there's different mutations for the two. But I'm going to concentrate more on the calcium sensing receptor gene mutation. And when you have ADH accompanying with hypocalcemia, kalemia, and metabolic acidosis, you can call that type 5 Bardet syndrome. And there are 5 such syndromes. You've got the more severe ones that are antenatal, and those are the 1, 2, and 4. And then the postnatal, the more classical ones, and a little bit less severe, but still debilitating, that can occur later on in life. So the issue with the particular Bartter syndrome, the 5, you've got an intrarenal defect here, the thick ascending limb of the loop of Henle. Normally, the calcium sensing receptor inhibits sodium transport, and the active mutation leads to salt wasting. And essentially, you have low PTH, high salt loss, and hypercalciuria. If you want to know the details of the in receptor pathway, you can read this. I don't know it. But essentially, you get low PTH and high urine calcium. Symptoms, well, in the most severe condition intra-pregnancy, during the pregnancy, you get polyhydramnios. You can get failure to thrive. You can get, as we said, loss of salt in the urine, and therefore polyuria, constipation, dehydration. As we said, the hypercalciuria and issues with nephrocalcinosis, and also the low calcium and its effects, as described here. So I want to tell you about a patient M, who started at Great Ormond Street and ended up in Evelina. So you can say joint care at different time points. So she was born in 2007. She was 37 weeks at the time, the gestation, and there was polyhydramnios. Did well to start with, but at 7 months presented with polydipsia, polyuria, convulsions, and hypokalemia. Also, the magnesium was low at the time. And she had genetic testing and diagnosed with Bartter's 5. And she had nephrocalcinosis. Initially, she was managed with alpha-hydroxycalciferol, but 1 year later required a subcutaneous PTH pump. And at times she had low calciums and needed extra calcium supplementation. At the age of 10, she had end-stage renal failure, and eventually she needed hemodialysis, which started, I think, a little bit later. Anyway, she had some metabolic bone disease as well, and she needed bilateral hip pinning. And I think it was Leslie originally who referred her to me saying, what about doing because at the time she didn't have a live donor, what about doing a deceased donor transplant as well as a parathyroid transplant from a deceased donor? So I was in the process of writing to our NHSBT body that regulates transplantation here and sends us kidneys, but never parathyroid glands, to ask for one. But then she was transferred to Evelina, and her dad wanted to donate a kidney. So we spoke to the dad, but before that we did some Medline search to see what's going on around the world. Well, there isn't much basically, but this was the best paper we found from Enrico Benedetti from Chicago, who some of you may know. He does a lot of robotic donor nephrectomies and transplants, again robotically. So he did take a parathyroid gland robotically and wrote it up. So this was from a live donor. But before that, he reviewed the literature as well and found a few cases where the parathyroid gland was transplanted in some way or another. But what we've highlighted here in red are the cases where there was a kidney as well. And most of those were sequential, kidney and some parathyroid tissue. There was one simultaneous deceased donor kidney and parathyroid gland. And the case that they described was one of simultaneous kidney transplant and parathyroid gland. And the recipient was a 23-year-old. The donor was 25. And you can see here following transplantation, the PTH level going up. So the synthetic PTH is not registered by the lab, so you can nicely document the function of the parathyroid gland when it does happen. And of course, it's a vascular tissue, so it doesn't start working straight away, and it can be up to a month later on when you start getting some function. So the father was 43, and he accepted to have one of his parathyroid glands removed. So did the nephrectomy first, standard hand-assisted technique, and then I decided, well, I had already planned that I would take the right upper parathyroid gland. The reason I chose an upper gland was that 80% of the time it's a constant location where it will be, whereas the lower one is only about 60% at the same place. So I thought it would keep things simple. Also did a frozen section afterwards to make sure it was parathyroid gland. Just in case it didn't work, I didn't want people to say, well, maybe you just implanted a lymph node or a bit of fat. So proved that it was parathyroid. And then we sent the kidney first across. Nizam started the transplant. Then I took the parathyroid gland out, put it in a similar big box, which is kind of funny because the gland was about that big. The box was that big. And transferred it across by ambulance. And the call time was 5 hours for the kidney and 7 hours for the parathyroid gland. And I'll show you how we did the parathyroid gland, essentially. We divided it into multiple small pieces. So that's the donor on the parathyroid gland there. Okay, that's the neck. That's the intraoperative location of the parathyroid. Took it out. It was about 11 millimeters, a bit of fat associated with it. And then at the recipient side, we cut it into multiple pieces. It was about 11, I think. And then open up the. So this was the same incision Nizam used for the implantation of the kidney. So right iliac fossa, but I've asked him to save the rectus muscle for me. So opening the rectus muscle and implanting a bit of parathyroid in the muscle, and then securing it with Prolin, but also putting some LICA clips in case we need to radiologically find where the parathyroid tissue is in the future. So you can see the kidney transplant here, and that's the parathyroid transplant essentially. And this was the first one done in the UK, as well as the first donor of a parathyroid tissue in the UK. So kidney function immediately, and then every day we kept checking the PTH to see when the parathyroid gland will start working. So eventually it did start. I think it was about day 8. We had the first hint of the PTH going up. And it was always since 2009, going back, she's always had just single figures of PTH. But for the first time, she started having 2 figures, as you can see, 20s, and so on. Obviously, she's been under the care of the endocrine team at Evelina as well. And they slowly reduced the PTH pump. Happy to say that she came off that in 2019. And she's been on that pump just like a diabetic for about 10 years before. And you can see here, that's her creatinine, and this is the PTH, so undetectable before and since the transplant. So, living donor, parathyroidectomy and parathyroid transplant is feasible. And of course, when you combine it with a kidney, you don't need any extra immunosuppression, so that solved that problem. Our results so far are satisfactory, and I must say, I needed about 1,000 emails before to get the process done. I needed approval from NHSBT, from the Human Tissue Authority, from the governance team here at GUYS for the donor, as well as for the recipient at Evelina. Thank you very much.
Thank you very much indeed, Nicos. That was excellent. Whilst people are thinking of questions, what do you think the longevity of the graft is? Does it get vascularized and then unlikely to have rejection is going to work for the next 10, 20? Do we know?
Well, we don't know, but we're Natalie's writing the case report, but maybe in a 5 or 10 years we can write the next case report and say what happened. Hopefully it will last forever. Okay, so well, I read the literature, and then essentially it said anything between 1 to 2 millimeters, and I cut about 1.5 millimeters. Good point. It's just that if one dies, then I have 11 options as opposed to, I don't know, 3 or 4, I guess. Just what I could find. There's not a lot of literature, as you can see. Yeah, Vlad.
Nicos, excellent piece of work. Congratulations. A couple of questions. First of all, would you consider parathyroid after kidney, for example, for somebody who lost parathyroids for whatever reason before?
From the same donor?
No, no. Just from UK transplant, delivered small piece in big box. And second question, God forbid there is a like hyperparathyroidism in those bits which you divided so spread so evenly. How are you going to chase them later in the muscle?
Okay. I'm sure I'll forget the first question, but to answer the second question first, you've seen a marked where the tissue is. So there's 11 pieces of proline there. That's not absorbable, and clips. So radiologically, I can even mark the patient before I have to go and remove the tissue, for example. And then inside, I will see the clip and the proline and remove it. So, I mean, there are reported cases where for autotransplantation, for example, where there was a need to go and remove it. So that's why I marked it before. And the first question, well, the issue is it depends on the case and the reason why would you want to go and do parathyroid transplant in your case that had a kidney transplant. So as most of our patients will have already parathyroid glands, unless they had congenital agenesis, which was the case from Chicago, for example. Most patients will have adequate parathyroid function, if anything, be more, of course. So that you need to define the case. In those cases, probably not many. Yeah. Yeah.
Okay, thank you very much indeed. You'll be pleased to know that we're now back on time schedule-wise, but for those of you that are looking at the programme, especially those that are doing the live streaming and in Armenia, we apologise that we're going to delay our coffee break because Nicos is going to continue to speak and he's going to do his later talk earlier now, so he's going to tell us how to increase living donation for paediatric transplant recipients.
Okay, so this time I'm going to talk about how to increase living donation for pediatric recipients, or at least my view. So first of all, I thought we'll review what goes on in the UK. Obviously, I'm biased from that point of view. And this figure shows the number of living donor kidney transplants that happen in UK. So from 2004 to 2018, and you can see the trend. Obviously, at the introduction of the laparoscopic life-donor nephrectomy program through minimal invasive techniques, the numbers went up and then they plateaued. When you look at the figures from the US, the same increase happened, but after that there's been a decline. So what can we do? Well, first of all, we need to see and analyze that graph a bit more. So what are the type of donors that we have? And this figure shows dark blue the related transplants, and the trends, the unrelated, the light blue. So that's gone up a bit, as you can see. Also, the antibody-incompatible transplants, HLA is the white, and ABOI incompatible, the slightly gray. So you can see the numbers had gone up, but those have been going down the last few years. But what has been going up and stayed up is the pair exchange and the altruistic donor numbers. So I could conclude my talk by saying that's what we should do, but I'll talk a little bit more. So what about, that was for all donors, and what about pediatric living donors? And you can see the numbers here. So we're definitely doing more living donor transplants now than in the 2000s. And again, you can see that a percentage of that has been through the altruistic pair exchange as well as incompatible. And the incompatible, again, you can see the same trend, slight increase in the numbers, but then decrease as we've been pushing more and more of these donors, the incompatible donors, through the pair exchange scheme. And here, this shows, according to the unit, the type of donors and transplants. So you can see that the majority are related donors. So we should definitely try and find more unrelated donors, I think, family members maybe. But you can see again the antibody incompatibles a tiny bit, and pair exchange, all altruistic. Since our well, for whatever reason, I sense that there's a bit more pair exchanges these days coming through. So I think that program will definitely develop more as time goes by. And these are the last year transplants, and you can see the numbers. Manchester 19, we've got Manchester representation here. Evelina and Guy's 9, and Gosh 13, and of course we've got the same surgeons for those two hospitals. But to put that into perspective, I thought I'll show you the deceased donor list and how many patients are waiting. We have got about 128 patients there, but of course about 36 are suspended. So that's the number of transplants done in the UK, more or less. So a little bit about ABI and HLAI. I know we touched a bit on the subject before. This graph is specifically for that. The light blue is the ABIs done per year, the last 10 years or so. HLAI are the dark blue, so obviously less than the ABI. And just one HLAI ABI in 2013, 2014. So not huge numbers, but still they contribute to the donor pool. And here is where these incompatible transplants have happened. You can see the majority have been at Gosh. I think Steve is writing that up, if I'm not wrong. Yeah. So we wrote our experience for ABI, Anna, who's somewhere in the crowd, and Jelena. So Jelena, the ABI, and Anna, the HLAI. So we'll talk a little bit about that. Essentially 11 ABI recipients that we're describing here, and our protocol is this. So essentially it depends on the titer of the recipient. So if it's less than 8, we don't do anything, we just proceed cautiously. If the titers are 8 or above, we give rituximab. And then if it's 16 to 32, we use double filtration plasma exchange to bring the titers down to equal or less than 1 in 8 before proceeding to transplantation. And if they're more than 64, we use the Glycorex columns from Sweden, which are very expensive, as you know. So these are the demographics of those 11 cases, and they were compared with 50 compatible transplants. And just to summarize, the graft survival was 98 versus 100% in the compatible versus the incompatible. Essentially similar results, and the rate of rejections, so 24 versus 9 again, respectively. And this is just to show you briefly the baseline titers where we started before any immunoabsorption or double filtration plasma exchange. And you can see the maximum was 128. And for those who do adults, you know that we do a lot higher dose titer levels for adults. And the results of rejection-free survival were similar, essentially, not significantly different. And this was the first 2 cases of HLA-incompatible transplants that were done at Great Ormond Street. Since then, in my recollection, we've done another 2. But anyway, to answer Andrew's question from the past, one was from abroad. Anyway, the results were, again, were very successful. The first case had ATG, the second case had Campath, but just that reflects our adult program that as we change with time. And you can see here the DSA level on one side, and the creatinine in the black line. So the creatinine came down nicely, but the antibody level came up, stayed up, but luckily with no rejection. or deterioration of graft function. So the way we do the HLIs is we do what's called a test plasma exchange. So we have one session of double filtration plasma exchange to see how successfully the decline in the antibody level will be before we can plan how many sessions they will need of reduction of antibody through the plasma exchange. And as I said, we give Campath these days. But pair exchange is what we push more, both for our adult and the pediatric program. So we talked a little bit about the kidney sharing scheme. Since we've got an international crown here, just to say that the law changed in 2006 to allow us to do this. The first run was 2007, and short chains and longer chains were introduced later on. So the standard two-way exchange, three-way, and nowadays short chains or long chains up to 3. And sometimes we don't do them all in one day. Very briefly, just to say that some patients, some pairs stay in the list for a long time, and these are the extra added cases every time there is a run, and there are 4 runs a year in the UK. And the majority were HLA incompatible for the ones that were registered, and 34 ABOI. And the last few years we've been adding compatible pairs as well. And from all those cases that went through the pair exchange scheme, 65% and the transplants proceeded. And you can see how the altruistic donors have contributed in the increase in the number of successful transplants as time went by. And again, this reflects the fact that there's an increase in pair exchange and altruistic donation as the years went by. Nizam is going to talk about transplanting the untransplantable, the ones with no IVC or aorta. And of course, they increase the pool by having a live donor. Of course, you still need to have a live donor. So here we present about 5 cases, Pankaj's paper, on these complex cases. So the child with no aorta, actually there's a bypass there, and here no IVC. You can just see the left gonadal vein going into the left renal vein, and essentially we use that gonadal vein and the aorta at that point to do the transplant. Nizam did the transplant, I did the donor. And again, Pankaj's paper that describes a novel classification system. So you've got aorta and IVC, A and V respectively. A1 and V1 are entirely normal vessels, and as you go down, they become occluded completely to A4 and V4. So this particular case, you can say, was essentially an A4 and V4. Again, I'm sure Nizam will talk a bit about this, but you see the 3D printed models there. So this is like an adjunct to allow us to do more complex cases as well. Now, we briefly touched on social media before. We did a survey through the European Society for Organ Transplantation, and we had some 190 responses, and these were mainly clinicians. And essentially, social media, as we heard before, is a way of increasing potential donor pool. And there's a number of benefits that I'm going to touch in a moment. But for example, this you may have heard, some of you, what's called organ mines. Essentially, they produce these nice-looking different organs where you can discuss and teach kids, with the hope that they will grow up eventually and they will know that it's the norm to do transplantation and donation. Because at the moment there's no curriculum in the schools to promote or teach about organ donation. So that's sort of looking at the longer term, essentially. So benefits, well, there were a number of benefits, but working prospectively and retrospectively to try and encourage donation through using different cases that happened in the past, different campaigns, using the Kidney Patient Association as well to help. And I want to show you this particular case that somebody mentioned earlier on. So this is Ethan. His parents put an advert on Facebook, and we had to stop at 20 because it was just getting a bit too much work for our coordinators. And you can see that's the donor. She's in her 20s, and they only met once before the actual donation. I did his transplant, and before I could go home, his picture was on Twitter, that evening. So a lot of the stuff we do now is in the media, but putting that aside, you can see how you can increase the donor pool. We heard that you can get up to 100 potential donors. So that is happening. I think with time we were a bit resistant or didn't really know what to do in the UK. But as we've been discussing with the Human Tissue Authority over the years, we've become a bit more relaxed with this. I mean, obviously there's a lot in the USA as well on this. And as long as there's no money exchange, essentially, we can proceed. Another way is using collaborations. And Nizam has been to Armenia in the past and done a few transplants there, hence the Armenia connection through the video link. But we've also been to Serbia more recently. And you can see in Belgrade, their live donor rate went down when they lost their surgeon. There, went to 0. So we went along and tried to teach Vlad over there to do both live donor nephrectomies as well as transplants. So we've done 3 so far. And you can see, you'll never see this in the UK, but there were 3 nephrologists in the theatre at the time. And Sanya is with us today as well. And we've managed to increase the rate there. So every little counts. So we talked a bit about incompatible transplantation, the sharing schemes, transplanted complex cases, and Nizam will talk a bit more about that in a moment, the use of social media and collaborations. Thank you.
Thank you very much indeed, Nicos. That was a wonderful overview. Any questions? Yes. A different surgical Vlad here, but from Glasgow.
Out of interest, would there be any scope in increasing matchability by joining the, not for runs UK-wide only, but maybe Scandinavians to join in, or Eurotransplant? Would that increase the matchability?
Yeah, of course. The bigger the pool, the more the chance to increase the matchability. I mean, we've seen different collaborations in Europe. For example, Czech Republic with Austria, they've done exchanges like that. And there's an initiative between Spain and Italy. So I'm sure with time this will improve. I mean, in the US, you've got such a huge country, and it happens, and it doesn't need to be all in one day. So it's possible.
Waldo, what's your experience in America?
Well, I think University of Pittsburgh just published their response to social media. I think they got this just in 1 month, more than 10,000 inquiries about donation, liver, mostly liver and kidneys. So I just want to just bring a question: why are we still stuck on the things that we cannot give some reward to donors? Why are we stuck on that? We're not buying the organ, but you know something? Some countries are already giving advantages.
Yeah. In Iran, they've limited disease donor list.
I don't even want to mention countries. There's already existing, and we're still stuck in that we cannot do. I'm not paying a cash money or anything like that, but we have to be innovative, because we take an organ, they take a hit, and we're not going to do anything. They have to leave work. It kind of insensitive to say that we cannot offer something in rewards beside the altruistic. Feel good about yourself.
Well, obviously, we pay for the expenses. We can fly in donors from abroad. But
why we don't give the tax break?
Well, Kidney Care, the Kidney Care UK and the associations can provide some money, so the living donor coordinators and the recipient and the donor side do speak to see whether they can help with loss of earnings, for example. But yeah, it's a very interesting question. Well, thank you very much indeed, Nicos.
Thank you.
We're actually back to time, but because we missed Nizam's talk earlier, we're going to have a shorter coffee break of 5 minutes. So it's a quick toilet stop with lovely brownies next door. So please bring your brownies and your coffees back in, and we'll restart up. Thank you.
In adults and guys, and also in pediatrics as well. He's just finished running the first robotic course and has done how many? 11 adult kidney transplantations. Yes, there will be a lecture on that tomorrow. So he can give a lot of different talks on different topics. He's an expert really in a lot of areas. But today, this afternoon, he's going to give us some surgical aspects of transplanting children with no main vessels.
Thanks very much. We've just had an email from Armenia, so thanks, Jelena. They're all watching over there, and they wanted to pass greetings on to all of you. They're really enjoying the course. As surgeons, we think we're kind of cool. This is Nicos and I doing a robotic transplant, and we like to think it's a complex, difficult kind of thing to do. But sometimes the nephrologists will come down to theatre to show us how it's done. This is Jelena making sure that we're doing a transplant properly. And if there's one thing that surgeons really don't like is when nephrologists call us plumbers and say, just plumb the kidney in, would you? But actually this talk is all about plumbing. It's all about how we fit transplants in when there's nowhere to plumb them into. You may think this is a surgical talk, and it will be hopefully of interest for the surgeons, but hopefully it'll be of interest to all of you, because you'll all be dealing with children like this. And just as we were talking this morning about how to decide whether or not we should be treating patients with certain conditions, I think it's quite important to be thinking about whether someone's suitable for consideration for a transplant. So in terms of complexity in transplantation, you've heard from Nicos about antibody incompatibility, metabolic abnormalities such as MMA, there are many others, cardiac or respiratory issues which often form part of the congenital syndromes that have caused the renal failure. You've heard this morning about congenital abnormalities of the urinary tract and kidneys, and I'm going to focus on vascular anomalies. So in this centre, we tend to put the kidney onto the aorta and the IVC for the small children, for children under 20 kilos. For children over 20 kilos, we tend to take a retroperitoneal approach and put them onto the iliac vessels. Other centres will have slightly different approaches, but clearly there's a problem if there's no aorta or IVC, since you've either got nothing to put the kidney onto, or you've got no drainage of the venous system or no arterial inflow. And here's an example, I'm going to show you more detail later on, of someone who's got no inferior vena cava, and all the blood supply from the lower limbs is draining up through that venous collateral. And here's someone with no aorta, where the aorta peters out. So why do children have vascular anomalies? Well, central lines are one of the commonest reasons, central lines which then take out the inferior vena cava. And one of the key messages of this talk for nephrologists, intensivists and so on is please try and save those veins. So you put in a femoral line to a small child, you're going to have a catheter in the IVC. If you leave it there for any length of time, the IVC will be gone, and that's going to make transplantation difficult or impossible. Previous surgery, which may be vascular surgery or other types of surgery, various syndromes which are characterized by hypercoagulability, and congenital disease, and the most common one that we come across is mid-aortic syndrome, where the aorta just peters out. It's characterized by hypertension, absent distant pulses, and an aortogram similar to that. So I'm going to give you a few examples of some of these situations and how people might approach them, and hopefully what we'll do at the end of this talk is have a bit of a discussion, if there's time, on different approaches, because there's no right or wrong approach. So a 15-year-old boy, again with no inferior vena cava, this is the aorta, this is another big collateral going up from the iliac system, and what we did here was made a left iliac fossa incision, went on to that iliac vein, and there were some difficulties in that there was a bit of thrombus there which responded to treatment with some heparin, but ultimately that child did okay. Here's another one, 7-year-old, both kidneys gone, previous transplant at the age of 3 onto the cava, which thrombosed, recurrent line thrombosis, SVC thrombosis, and no inferior vena cava. So clearly she's in a difficult situation if we try and continue with dialysis for any length of time. And what we did here was we made a midline incision. Obviously there were dense adhesions from the previous surgery, but as is often the case in our experience, you can find a small segment of suprarenal cava. You can find a small segment of suprarenal cava and use that as a landing site. And we used perioperative heparin, and I think if you are using venous collaterals or if there's any doubt about the venous outflow, then being a bit aggressive with the heparin certainly is worthwhile. So there are a variety of different options in summary if there's no IVC. We can consider the collateral veins, and sometimes people will measure the pressures in those collateral veins to determine whether or not there's enough outflow. We can look, as I've said, for a suprarenal IVC. We can mobilize the liver, and we can use the retrohepatic IVC or the right hepatic vein, or in this scenario, they've used a bit of deceased donor vein to make a conduit up to that cava. Or you can use the mesenteric veins. We've never done that, but it's certainly reported. Another thing that we have done, this isn't our paper, but you can use the portal vein. We've done that twice, and one of them didn't do too well, one of them did okay. The portal vein is going to be pretty small, and I'm not sure that in a small child it's going to be good enough for outflow, but some people have had success with this. And of course, you could just take the native kidney out and put the new kidney in, but that kind of begs the question, well, if there's venous outflow at this level, why not just put the new kidney onto the cava at this level with adequate exposure? So in summary, if there's no IVC, then it may be worth exploring to see what vein you can find. And in that scenario, you may think about starting the recipient prior to the donor, and that's something that we commonly do. And since we do the donors in this hospital, and we do the recipients in one of the 2 children's hospitals, has significant logistical implications. So if we're starting the recipient, what we tend to do is have the donor down in the anaesthetic room, and we've prepared in advance, both prepared the donor and the theatre team, that the donor's going to be waiting in that room for quite some time, maybe an hour. Someone has to stay with them. And then when we give the go-ahead, the donor surgeon and their team needs to move quite quickly. And that means having 2 experienced surgeons with the recipient, because we tend to do these complex cases with 2 consultants, but also an experienced surgeon with the donor. Because what you don't want is someone who's fairly early on in their consultant career being told, right, we've got a child on the table, we're waiting for the kidney, get it out quickly, because that just puts too much pressure on them. So that's the cava. What if there's no aorta? So here's a 9-year-old girl with mid-aortic syndrome who's actually had a graft, and you can see the top half of the graft here and the bottom half of the graft here. To get round that problem in the mid-aorta, father wants to donate, so we do a midline incision. We have a look at the vessels, and here we went on to the common iliac artery, which on the angiogram looks pretty thin and unappealing. But when we went in, it looked okay, and we transplanted there rather than onto the graft. Here's another one with quite a number of congenital abnormalities, and she's had an aortic arch graft twice. She's had a lot of surgery on her urinary tract, and her aorta peters out here, and her mother wanted to donate to her. So what we did was we got a piece of deceased donor iliac artery from the liver team. So the liver team will store these vessels. for use in liver transplantation, and we asked them for a piece of deceased donor artery as a conduit, and we went very, very high. So we split the diaphragm and went up above the celiac artery. So this is her native kidney, and this is her transplant kidney. So normally the transplant kidney is here. It's actually above the native kidney. And this is this conduit going high up onto the aorta. And what's interesting about this is that you now have two different tissue types. You've got the kidney and you've got the conduit that we've used. And what we found was that she actually seemed to develop some donor-specific antibody to the conduit and not to the kidney. And that was accompanied with both the rise in creatinine and a stenosis of the conduit. And our first thought was that the stenosis was just where we joined the vessels together, and the join was just too small. We stretched it up. The DSA had gone up. We increased the immunosuppression. The DSA went down. The creatinine came down. And since then, she's been absolutely fine. She's now just finishing her university degree. This is another case with no aorta and no IVC. And she'd had an aortic graft, a long aortic graft, an SVC obstruction, multiple abdominal trauma. Her donor was blood group incompatible, and she was highly sensitized, just to make matters even more complicated. And this is her angiogram, so it's the same aortic angiogram. This is the graft here. And this is the venogram, which you saw earlier on, so no IVC. So in this scenario, we had multiple multidisciplinary meetings. And as Joe was saying earlier on this morning, we used the hospital ethics team. We talked to the palliative care team and decided eventually as a group that it would be worth going ahead with this, and talked to the mother about palliative care, withdrawal of dialysis, because clearly access was increasingly problematic. But the decision was made to go ahead. We had 2 consultants at surgery, and we started the recipient first and managed to get it onto the distal aorta, just below the graft, and onto that gonadal vein. And the kidney survived, unfortunately. The child did not. She went back to her home country and died about 3 months after transplant from infection. So we've tried to characterize some of these anomalies in this paper, and you haven't got copies of these slide presentations yet, but we have printed out some, so they will be distributed. So this paper describes a means of characterizing the different levels of occlusion in the aorta or the IVC, which we hope would be useful for discussion. One of the other things we've started doing, which I'm sure many of you are aware of, is 3D printing. So we wanted to put his kidney, and he's a bit taller than me, into Lucy, who was pretty small at the time. And the question is, okay, is it all going to fit? And the answer is yes, it probably will fit. We've never had a case since I've been here where we've found we couldn't actually do the case on the day. But the question is, how easy is the case going to be? And will we need a mesh? Will we need other strategies? Where we've got complex vascular anatomy, how is it all going to work? So what we do is we 3D print, and we take the donor CT scan and print the kidney. And if you can just move your mouse to there, click the arrow, yeah. And this is the printer in action. So this just prints over the weekend. We switch it on on Friday and leave it for a couple of days. As you can see, nothing much happens, so it takes a long time to lay it down. And then we can also print the recipient anatomy. And we started off by printing the vessels. And this was the case I showed you with the aortic graft. And we looked at where we could try and get the artery onto. But we can also print the abdominal wall, and those of you who've looked have probably seen over in the corner, we've got a series of prints, from some of them from some of your centres, to try and help plan surgery. And we can print the liver, we can print the bones, and we can actually do the bones of different consistency to the liver. Could you just click on that one as well? And we've done it. This is me trying to fit the kidney in and thinking, yeah, that's not going to work, is it? Just prior to an operation. And then we can correlate this with what we actually see at surgery. And the correlation seems to be pretty good. Here's a case where Imran, who you heard from this morning, the urologist, was involved. So he took these kidneys out in a young child, 2-year-old. There were multiple aneurysms. And then we went in and did a living donor transplant. And here's one where, when we looked at this angiogram, the feeling of the MDM was that we shouldn't go ahead with transplantation at the moment because there was a high division of the aorta which seemed to have a funny configuration. When we printed it and passed it around, we decided it would be reasonable to go ahead, which we then did, and the outcome was good. So, in summary, I think it's important that there is a multidisciplinary discussion. Sometimes we have to involve our vascular colleagues, our urological colleagues, as well obviously as our nephrological colleagues, and sometimes even a liver surgeon, although we try and avoid those if we can. 2 consultant surgeons in theatre for any complex case, and very common for us to do simultaneous surgery or to start the recipient first, and that needs a lot of coordination and thinking about how you manage the donor side of things. We want to avoid deceased donation if possible, so these complex cases we don't want to be doing at 3 o'clock in the morning on a bank holiday weekend when no one's around and someone's struggling on. But if we have to list them for deceased donation, then we'll give consideration. They're going to be in theatre for a long time. They're going to need to go to intensive care afterwards, and we've got to prepare for that. And very often when you inspect the vessels, something that doesn't look doable angiographically is feasible. So it's always worth thinking about having a look-see if there's doubt. The use of a conduit is worth thinking about, but if you've got a conduit in, always remember that you may get rejection of that conduit, even though the creatinine is more or less okay and the kidney's not undergoing any rejection. And 3D printing can help you in some cases. Lastly, as I said earlier on, try and preserve not just the peripheral veins, but the IVC, because that's really critical when they come on to transplantation. That's it. Thank you.
Thank you, Nizam, for that overview. Any questions from the audience? Yes, all the surgeons. I'll just walk this way first, over, and then I'll come to you.
Hey, thanks, Nizam. That's a fantastic talk. Just regarding the conjugate, when you transplanted and used that, did you tissue type the conjugate to make sure it was compatible, or did you just blood group match it and hope for the best?
We didn't do any of those things. So we got hold of the type. So we knew what the type was for future reference because we were aware that this could actually happen, but we didn't try and select one that was appropriate. We just use it.
Well, actually, he's asked me the same question I was going to ask, so I'll have to think of something else. But you showed about where the aorta was absent, and you went on to prosthetic graft. Do you have a preference for which graft, or do you leave that to the discrimination of the vascular surgeons?
Yeah, so where they're doing a replacement graft of an aortic segment, that'll be the vascular surgeons who do that, and that's up to them. Nicos was involved in an auto transplant with the vascular surgeons last week. And what did they use then? They used Dacron. So you could use Dacron, you could use Gore-Tex.
Sorry, just one more question. You mentioned about the absent IVC or occluded IVC, about venous pressures. Is that part of your routine practice to measure?
No, we haven't made too much of that, really. I think it's quite difficult if you've got something like that collateral vein that I showed you, the gonadal vein. You can try and get the pressures, but it's going to be quite difficult to get decent pressures. And very often, when we've measured pressures, we've then been a bit puzzled with the results. You think, well, what does that mean? Is there really a, you know, it never seems to be very clear cut. So we've kind of gone off that.
Thank you.
One last question from, second to last question, then from Aldo first.
First of all, great work. In our practice, we use, for all this replacement, pediatric kidneys. And we have been able to use very marginal veins, the drainage, but also the pediatric kidney conditions to the lower flow, and the venous drainage improves with time. Number two, one of the other ones that we have used have been the splenic vein, and the next one that we have ready is the left hepatic veins for this, but great work.
Yeah, no, good point. Yeah, splenic veins certainly, yeah, and the hepatic veins, yeah. Yeah, I mean, these have been, they've all been adult kidneys because most of them have been living donors.
Thanks very much, great talk. I was interested in one of the cases where you talked about perioperative low molecular weight heparin because you'd noticed there was sort of low venous outflow. Do you have a sort of tips or strategies as to your perioperative anticoagulation regimes and what drives it?
So normally we're just using aspirin for our standard cases. If we thought there was some concern about venous outflow, so if I were transplanting into that gonadal vein, then I'd be as aggressive as I could be with heparin. We try not to give full IV, full dose heparin because we're going to be taking them back to theatre if we do that. So if we can avoid that, we will. But if it's really marginal, then we do that. But certainly prophylactic dose heparin in any situation where there's concern.
Hi, I'm Claire. I'm one of the renal coordinators from St James's in Leeds. In terms of the donor vessels, we've certainly had planned live donor cases where we knew that we would very likely need additional vessels. So what we've actually done is we've done a 2-week kind of scouting programme before the date of the planned donation. So what we've done now, we've done this at least 3 times in the Yorkshire region, and for the first week we will work locally, so certainly staying within the Yorkshire region, specifically looking for blood group and HLA matched vessels in advance. So each donor that is within the age set criteria, we will, our H&I lab, which will be typing their donor anyway, will match them against our child so that we will, in theory, have donor-matched vessels if we need them. If we're not successful at the end of the first week, that then goes out as a national appeal to all of the SNOD teams. And then it's a much wider approach, but what we will do is we will spend those 2 weeks actively trying to find matched vessels. And on 2 of those occasions, we certainly had well-matched vessels. On the 3rd occasion, what we needed to do was actually revert just back to the liver fridge and find something that was marginally matched and perhaps a little bit outside the age criteria. But we've also used Speak Tissue Bank as well. And it's literally been as simple as we've provided a sketch of what we've wanted in essentially a Y connector. And they've had a look through their vessels, and with a couple of weeks' notice, they will try and harvest a set of vessels for us that we will be able to use, and then HLI, ABO doesn't come into it because the vessels are just coming straight out of the tissue bank. So that's been really useful for us.
That's a really useful suggestion, yeah. And I think, I think good coordination with the local liver team, and if you're co-located with a liver team, then that's easier. But widening it out nationally, certainly, yeah, it's a good idea.
Thank you very much. I think we need to move on to the next speaker, again, Dr. Marks, my colleague, who is going to talk to us on increasing disease donation for pediatric recipients. So, Steve, thank you for giving the second talk today.
Thank you, Jelena. They've closed some of the blinds, but you can still see the London Eye if you squirt to the right. So I'm going to kind of lead on from Nicos about how we increase deceased donors for our paediatric recipients. So I think a lot of it, we have to think about what information, we've talked a little bit about the media and the social media today, and it's obviously becoming more into the fray. I'm going to touch a little bit upon neonatal and infantile donation, which is something which has been in the heart of transplantation, but also, again, in the media, but with especially looking at how we can increase and then talk a little bit about utilisation, because I think we have a lot about transplantation. I don't have enough time, but we've published some work on declined organs, and Nizam and I were at a meeting in Pan London last week. We were looking at the number of declined offers that happens, and then obviously thinking of outside the box of the ways that we can increase the donor pool. So I always love it when we have campaigns. It makes you think back to basics, and with Kidney Research UK, they're very much into thinking about transplantation, putting it more on the agenda, but especially, as you can see here, the number of people waiting transplantation, kidney transplantation, remains at the top. You've already seen the slide, but basically it shows you the number of adults on the waiting list is beginning to go down. So I guess when we look at what we were setting out with Lisa Burnap, who heads living donor transplantation, but also looking at campaigns for 2020, we wanted there to be less people waiting for a transplant, but also less people dying waiting a transplantation as well. And what can we say about children? Well, you could be positive or negative. Is your glass half full or half empty? Because what you could say is actually, well, we're doing really well and it's decreased over the last decade. But in addition, what you can also say is that it seems to have gone up a little bit recently in the last 12 months. And although we've changed the kidney offering scheme in the United Kingdom this year, one thing that happened is actually the waiting list time for transplantation for children went up for the first time this year prior to the change in the kidney offering scheme. So I keep on telling NHS Blood and Transplant, when they tell us how much better it is now with the new kidney offering scheme, it's got to be in context that this year it went up. But what we can see is there's a lot of variation, and that's one of the areas that we're interested in researching. Why do things happen differently in different centres? And it may be not only the infrastructure and the number of members, for example, of the nursing team working in transplantation, but it may be a difference in the mindset of the multi-professionals within the team. I haven't given you the actual names of the units here, but I just wanted to show you that if you looked at the median waiting time in the United Kingdom for children, it varies from 114 to 498 days. So that means that in some units, the average time is about 3 months, but in other units, it is heading up for 1.5 years. So there is a complete variation what is happening up and down the country. Sometimes I'm told that that's because of ethnicity, but I think everybody would agree in London we have a multi-ethnic population. There is obviously changes in gender variation as well. It's sometimes depending on your baseline, the number of children that you have with posterior urethral valves at any given time if you've got few numbers of children in your units. So what can we actually do? And I think one of the important things is we can't do anything alone. We need to work together as a multi-professional team. So one of the first things to discuss is the Max and Kira's law. So this is looking at the opt-in and opt-out system. So the idea about starting the opt-out happened in Wales as a test. As you can see here, the 1st of December 2015, and it is likely NHS Blood and Transplant, together with the Department of Health, it's looking like the beginning of April 2020 will have the opt-out system in England. That is where it is deemed that you are presumed to be wanting to donate your organs after you die. So at the moment you need to be registered, which of course you can have whenever you have a new driving license, for example, in the United Kingdom. If you go to Boots and you get your Advantage card, you have to tell them whether you want to be a deceased donor. So there are various ways of actually doing this. I'm going to touch a little bit about Scotland. My Scottish colleagues at the back, Scotland are always ahead of the game, because in Scotland you can decide at age 12 that you want to be a deceased donor without the consent of your parents. You can make that decision yourself. Whether it happens, of course, is the whole big debate about opting out, taking in England. So obviously we need to think about the parental rights and the rights of minors. We obviously want to do what is right for children, and we touched a little bit upon that in the ethics. So with a living donor, there is a discussion, should children ever be living donors? And this has been debated. This was 13 years ago, this editorial that I wrote, when I actually looked around the world, and every country had minors under the age of 18 who had donated their organs as living donors, and the UK was included as well. But what can we think about for deceased donation, donation after brain death and donation after circulatory death? Well, I think a lot of it goes back to education and about speaking to the public. And one of the things which has come on is actually the Scottish educational system. So in Scotland, it is part of the natural curriculum that teachers have to educate the children about transplantation and about deceased donation, and also they talk about live donation. And that education program has actually resulted in children going home and having the conversation with their parents and making parents think about what their views might be on transplantation and organ donation. So it's not allowed nowadays, I think, in 2019 to say you're unaware, because the information is out there and we've got to make sure that we talk about donation. So we touched a little bit, of which nearly 1,000 were parents who had children under 18. And what they wanted to do was to get their attitudes to organ donation. So talking about, you know, would you consider being a deceased donor? Would you consider this as a child? And would you consider discussing organ donation? You might be able to see where you live, but London was down at 24%. Everybody thinks we're forward-thinking in London. That's only because Nizam and I are the Scots living here trying to show you what to do. So what are the attitudes to organ donation from parents? Well, what some people think is that children are too young and too vulnerable to be talking about dying and death and also about transplantation. It's quite a difficult concept. And of course, we're not talking about saying it to 4- and 5-year-olds. We're talking about secondary school education. And some people feel they don't want to upset their children, or they would not avoid talking about it at all. And that was 43%, so that quite surprised the number of people. What if mummy and daddy died? What would you want to happen? It's also a difficult subject. As a growing child, you don't want to consider your parents, the fact that they are not immortal. And discussing organ donation with family members, as you can see here, 2 out of 5 felt it was inappropriate to discuss it with an immediate family member. So if we don't talk about organ donation and who holds a deceased donor card and thinking about what we're going to do with the opt-out system, then we really need to rethink and revisit. And obviously we can talk about what happens in your various centres, but also your countries as well. But you can see here that about 2 in 5 felt that they were able to talk about it with their spouse or partner, but only, as you can see here, about 1 in 6 with their children. So one of the other aspects I wanted to look at was the consent and authorisation rates for deceased donation. So this was over the 4 years. And as you can see, that the consent authorisation rates is obviously less for DCD compared to DBD, but is actually pretty similar in the DBD between adults and paediatrics. If you want to look at the mean number of organs transplanted per donor age group, that you can see that for a healthy paediatric DBDs, you can see that the number of organs transplanted is 4.5. So actually, it is up to the intensive cares and it's up to the SNOD teams to really think about donation in these groups of children as well. And what we have seen is there has been an increase in the number reported by NHS Blood and Transplant over the last 5 to 10 years. What has come up more recently is talking about neonatal and infantile donation. Again, it seems so wrong to think about children dying. We talked about the ethics of our own patients, but also to think about giving life back after your child has died. And that is something which is increasing, as you can see, in infantile donors under 6 months, which has increased over the last 6 years. So what about the actual utilisation? And I put the question here, is there an issue with identification of potential paediatric donors, and what are the consent rates? What actually happens in the situation? And this was looking at some work which was done by Richard Hodge for NHS Blood and Transplant, with a number of extra paediatric donors that could result each year if they used the same criteria that were used for adults. And what you can see here is that the total number of DBD and DCD increased by nearly doubling of the numbers that they had previously. And the number of extra transplants that could result each year if they use the same thing with adults, again, the total number increased was nearly 90 to 100 every single year. So we're talking about substantial number of organs being available if we applied the same criteria to children. If we want to look specifically at the younger paediatric donors, so the under 2s, and there's a whole big debate, we use the cutoff of 2 because, for example, in renal transplantation, you're likely to take them en bloc, and then there's a consideration whether they go into adult, so kind of young adults, or whether you would consider them in some of your adolescents. And I think it depends on the patient, if they're sensitized, if they're on dialysis, how long they've been waiting for a kidney. And you can see here that the number of organs donated has increased exponentially year on year. And you can see that with the groups above the age of 2, there has been an increase, but not to the same amount. And you can see the number of kidney transplants in 6 to 18 years is normally around about 100. What about if you look at the outcomes from these transplants? Well, the donors aged 0 to 2 generally do a little bit less favourably, although sometimes actually you can have improved EGFR by having en bloc kidneys put in, obviously, and that's one thing which is looked at, but there's an increased thrombotic rate, and these patients do need anticoagulation, which is usually more than your standard. And if you look at the renal transplants from the paediatric deceased donors, if you have a look, there wasn't any difference in the groups that when it was published in Transplantation back in 2015. So what's the way forward? Well, I think we need to recognise there's a potential that we can increase the number of paediatric deceased donation that happens. There's a big working group, the NODT, through the National Health Service Blood and Transplant is looking at this with guidance with neonatologists and intensivists together with the SNOD teams and nephrology and transplant surgery as well as the multi-organ. There has been some innovation in the Leeds group, Niaz Ahmed, who started there, did some of the initial transplants and the very small and the neonates and infants that went in the press, and it's now been deemed that we would also do them in London with the Guy's transplant surgeons and obviously working in the teams with Evelina and Gosh. So I think one of the things that came up was that we need to have specialist small paediatric donor kidney transplant units, and not everybody should be putting small kidneys into even adults around the country, and it should be done by a specialised group. I'm just going to end very briefly with thinking outside the box. You've heard about ABO-incompatible living related. What about doing ABO-incompatible deceased donor transplantation? And part of the issue is that the antibody titers vary hugely from lab to lab. And Nick Barnett, who's now here at Guy's, when he was doing his research, he looked at some of the data. And what we did is we looked at all of our patients who were on hemodialysis, who were waiting on call, and we looked at the titers. And what we found is that a third of our patients who were on call for deceased donor transplantation had antibody titers of 1 in 8 or lower. So that means that 1 in 3 patients, if you remember from Nicos' slide, wouldn't require any additional immunosuppression if they were called for a blood group incompatible deceased donor renal transplantation. 1 in 6 of them had a titer of 1 in 16 and below, so that means a total of nearly a half of them would be very easy to do pre-transplantation. And with NHSBT, we did some modelling, and we found that this would increase the transplant activity by about 2%, and the median time would be reduced by about 20 days. So to conclude, I think there's increasing recognition that there are some missed opportunities in paediatric organ donation. I think we need to think about increasing the organ utilisation and maybe for adult recipients as well in the under 5s. But we have good outcomes after using these kidneys, and there's ongoing challenges for the PICU and transplant communities, and we have a duty to provide end-of-life options to parents and families. Obviously, I'd like to thank Live Life, Give Life, who gave some of the data that I presented, also NHSBT, but also our teams, Niaz and the surgeons and members of the CAG. Thank you very much.
Thank you, Steve, again for another excellent lecture. Any questions for Steve on this topic or any other topic? I'm sure he can answer a question.
Does anybody want to give some of their experience, Antonia? Your experience of using young deceased donors? What's the policy in your unit and with Eurotransplant?
Our donor issue is just changed in the Netherlands. So we have the opt-out system. So we have to look if that will come into more transplantations. And but I think we didn't change in children as donor. So I think that the numbers remain stable during the years. But once in a while we have a child as a. That's what I often hear from parents later on. So, for example, last year we had a child who died from asthma when she was skiing, and the parents decided to not go for donation. But later, they really felt sorry, but you were not. They told us that you were not well enough informed. So I think we have to improve the information to the parents when this moment comes, and then we can improve donation in children. That's what I think would be important.
Yeah. Just a comment on your showing the programs for education in schools. In the Netherlands, since 5 or 6 years, we have quite a comprehensive program for donor education in secondary schools. It is not compulsory, but it is now taken up by the majority of secondary schools. The idea is not to promote donation or to say you have to donate, but to give all the basic information about what is happening, what is donation, what is transplantation, and to teach the pupils to make up their own minds. And this has resulted, and there's now research done, in a considerable rise in the number of young adults who sign up as donors in the register as positive as donors. And we have, it's really, let's say, an increase compared to, let's say, 5, 6 years ago. So having these programs really makes sense. And as you say, they take it back to home, to the kitchen table, discuss it with the parents. We'll have to see if that works, but for the young ones, it certainly works. And we have now also a pilot program to discuss organ donation and transplantation, even in primary schools. And you'll be surprised at, let's say, how 6, 7, 8-year-olds grasp the idea of donation. And very naturally they say, well, there is a solidarity element. If you want something, you also have to give something. So that idea becomes very central in let's say, informing your own opinion about it. So it is really, I think, a very important issue, education, to make people, let's say, accept donation, let's say, from the age of 18 in the Netherlands. You're officially allowed to register as a donor. It can be even from 12 years old, so as in Scotland. Yeah.
But what's difficult is that when you want to be a donor, that the system is now that the family can decide to refuse. So also in a jail, but also an adult. So I mean, when I die and I want to be a donor, but my family thinks, oh no, we are not going to do it.
Well, this was the whole big debate. The whole big debate here in England as well is that it's never deemed anything in law, and if somebody's relatives turn around and say they don't want it. And one of the issues has been that Wales, there wasn't an increase in the uptake, and it's only just been shown now that there is an increase in the total numbers by having the opt-out system.
I think this is probably the most important thing we can do for transplantation is increase donors. No question about it. But one of the important things is that we need to validate the first-person consent. In the United States right now, first-person consent trumps everything. If the family is not agreeable, we give a cooling down time, and we go ahead and say this is like a living will, and it's honored. Because if not, it's no sense to have it. Second thing is that in our area, we have a special registry for small pediatric donors for pediatric patients first. And if you see the UNO's declarations, on the front page, children, donor for children recipients, and that's not happening. So we are appealing to that to make it happen. I tell you, if we can increase that, a lot of this that we use in our live donor could be solved with better with pediatric donors.
I mean, it has been debated in NHSBT, but it's not paediatric donors for paediatric recipients in the UK, where it is in Eurotransplant.
I think in the UK, there's very good reasons as to why
Yeah.
we have consent from families. If the families say no, then actually we don't take the organs, because I think the public relations element of taking someone's organs without your family's consent actually would probably do quite a lot of harm in the media, etc. But I guess I had a question about the practicalities of educating young children about organ donation. I have a number of young children, and despite being a transplant surgeon, I feel very uncomfortable at the thought of my children being donors. And my children, when I've talked to them about it, initiated by them, Daddy, what do you do? Is it true that you take organs from someone and give it to someone else that needs it? They don't understand what I'm talking about. I can see a total blankness in their face, and I just don't know how informed paediatric consent to donate can really be.
Well, it's an interesting question. I mean, a lot of it is doing things in an age-appropriate manner. Transplant TV Live and NHSBT have got some wonderful interviews that they've put online, some of which include children, but also looking at parents. And some of them, you know, parents, as Antonio was saying, somebody who's relatively healthy with asthma then dying suddenly, or a child having a road traffic accident. But what it gives back to families when they hear that it saved, you know, 5 other people's lives, it does mean a lot. And the connection that they then have, that their child is living on, is also, I think, a powerful medium as well.
I don't know about here, but every state in the United States has what I call the public health goals. We were able to put last year organ donation transplantation as the next goal, that the public health nurses and educators, and they have several names for them, that is part of we create a content that we put it there, so they have to educate whoever community center has, they have to educate about that.
Thank you very much. I think we need to close this talk, and our next speaker is Professor Guido Laube from the Children's Hospital in Zurich. Guido is a colleague and a friend of this symposium, and is going to talk to us about the transition to adult services, how it is done around the world and how we should be doing it. So Guido, thank you very much for coming to give a talk.
Thank you, Jelena, for this introduction, and thank you, the organizers, for having me here. It's a privilege. Well, we have heard about quite a lot of transplantation of any organs this morning and this afternoon. We have heard about needles, we have heard about all the techniques, but never forget these children, our children, they get adults. And we have to take care about these children in terms of getting this in a serious way. So I would like to start with some definitions. What is transition? Transition is a process. What is transfer? Transfer is something, it's a moment. And compliance, or you can name it adherence, is the extent in which the patient does follow what we ask him to do, in a way what matches on our agreed recommendations in terms of medication. So the question, the first one I would like to ask, why are patients non-adherent? So there are 3 possibilities. They have no idea, it's the first one. They know it better, or they just don't want. So these 3 possibilities are for non-adherence. So if you have a look at the literature and look what has been often studied in terms of adherence or non-adherence, you see that there are many diseases, disorders, from asthma to cystic fibrosis, HIV, and so on. It's not that many published, and the incidence of adherence is about 30 to 50%, and the consequences in general are that the course and the outcome is of course touched quite seriously. They can end up in a impaired quality of life, and of course it does raise the costs of all the health systems. So non-adherence after renal transplantation is quite a serious thing, is quite having a lot of consequences. The first one could be that the children are running in acute rejection, ending up in persistent tissue damage, reduced graft survival, and they had to be put on dialysis again, and they have to retransplant it again. So this is the way these children will go. And when you look at a paper that has been published 9 years ago, then you see that in these children, it's about hardly half of those, they are non-adherent. About a quarter of them do have acute rejections, and about, well, 15 to 30% will have their transplant lost. And that's amazing. I mean, we can talk about new medications, we can talk about new techniques, but this is an amazing number that you see here. So the consequences you see on the left side is that we know that the green line you see is for allograft survival in patients being transplanted in the teens, in teenager age. And you see also the rejection-free survival rate on the bottom on the left side, which indicates that non-adherence does result in a lower rate. And non-adherence is something, if you look at the age, that is not with 12 or 14, it starts with 15 to 20, even 21, 22. So they do have kind of a postponed puberty they do have during their life. So what is puberty? It's a rough journey. It's all about discrepancy between dream, so what can a teenager do, what does he want to do, and what is his ability. So they do think everything is possible. No one can stop me. And this is ending in an impairment of self-reflection, reality of the awareness. So reasons, if you go a bit more in detail, as at the beginning, of non-adherence, is first that the teenagers, they have another risk behavior than we adults do have. Sexuality is an issue. They want to be peers as others. They want to just go out in the evening and have some beer or whatever. Schooling, and of course the drugs. All these issues can lead to non-adherence. And in a chronic adolescent patient, I mean, this slide here is just for every teenager, but in a chronic adolescent patient, there is even more. They are very often to the hospital, they do depend on parents, they do depend on doctors, they do depend on nurses, and they have to cope with their chronic disorder. They are depending on the hospital the whole life. And the possible consequences, of course, are physical and mental development delay and an impairment of their family life and their social contacts. So we could ask, so what? Should we react? What should we do? I think we should react. We would like to have our small patients to become strong adults, you know, that they survive in the adult world. So what is in the literature? You all know, I'm sure, Alan Watson, he has published quite a lot on the consensus, what is necessary for a good transition, leading to a good transfer, leading to a good solution for these children. It has been published a few years ago. And the summary conclusion is that transition is a complex process leading to transfer. It goes about the information, what is it is including. Should start very early, 12 to 14. And it should involve the parents, it should involve all the teams, and it should also involve the peers, the schooling, and everyone. And the adolescents does need the individual schedule to be known. He does, or she does, to get to know what's going on. There are also skills and competencies described what a patient, when getting adult, should be know about. So you can read it on the right. It's just the understanding of risk behavior, the understanding of the disorder, the understanding of easy things, how to to make up an appointment, how to contact, at Saturday morning when I'm not feeling good. So what is or has to be involved is the patient, with the family, with the peer support, it's the pediatric unit, it's the adult unit, and in between there is some coordinator, some nurse, some psychologist, or you just name it, transition coordinator. So having a look at this concept, what is resulting in Europe, there has been published a survey last year, an online survey, including hardly 40 centers from 24 European countries. And they've tried to give a score to this kind of recommendation. What is the result in 3 centers? It's also a solution. I don't think it's good that pediatrics just stay in the pediatric setting, even if they, getting adults. In 5 centers there was no transition, and in the remaining centers they only get a median score for adherence. The maximum here was 15, and they reached in median a score of 10, which is, I think, not that good. What about the United States? They also did a survey questioning what is the handling with these patients. They get about a response rate of 40%, and what they saw that there is an inconsistent use of validated tools that are known, insufficient communication, the lack of use of dedicated tools. So they worked out the development of rise to transition. I'm sure you know this. These issues, and there are described 4 competency areas, as you can see here: recognition, insight, self-reliance, and establishment of healthy habits. And they end up, you can't read it, I'm sorry for that, but they end up in a just a schedule how to go through this time with the patients. So transition around the world is the issue I've been asked. I mean, it's not much published. The question is why? Because it's not consequently implemented. Because you don't get famous, you get more famous publishing some new genes. That's just a matter of fact. You can't change that. It's expensive, or maybe not needed. As a few of you possibly know, I'm also working in Cambodia. This is the emergency room in Cambodia. It's just 500 children being there. The rest is waiting outside, waiting on the streets during nights. Some of those, they will die. So they're just happy to have an X-ray, and this may introduce peritoneal dialysis. So there is no need of a transition program in these countries. Okay. So what have we done in Zurich? We do have a adherence and a transition program. It starts at 7 years, the adherence program. There is individual training, supportive tools, and we have a transition program which then starts at 14, including also a individual support. In detail, it's the adherence is getting taught by a nurse and the leading doctor. We have handouts, we have folders, we discuss these things. We have supportive tools. We had in earlier times a watch, giving 2 alarms every 24 hours. And nowadays, of course, we have the mobiles. We have developed an app with information, with alarms when you don't take the medication 10 minutes after. We have these boxes. We have candy boxes, because if the teenagers, they are at Saturday evening, they are not at home. They are with the peers. They don't want to be recognized as a drug dealer because they just have the medication. They just take it out of a candy box. Just simple things. We have events, workshops for patients, parent, teachers. We have a dialysis camp. See the Swiss Mountains and the transplant groups. We have adherence training. And we try to find out when a patient is non-compliant or non-adherent. So we assume if he's lacking, his outpatient clinic is having unstable drug levels, missing appointments, and all these things, that there are kind of consequences then. So we do intensified the adherence program. We make weekly appointments and try to optimize. The schedule is with 14. We ask the parents to be out of the room, which is not always that easy. We switch from, sorry, this is German, from du zum sie. We Swiss and German, we are a bit stupid. You is not you. There is a polite form of you, and this is the sie. I hope you get that point. But this is making you adult, okay? So we start to plan the transfer individually. Some are with 18, some with 19 or with 20, they are ready. And then 1 year before transfer, we just make a detailed schedule. We just repeat all the things. We just talk about all these issues that you can read here. And I've already also mentioned, we do include other experts, social workers, and other specialists, dietitians, psychologists. And then there is 1 day per year we do a transfer. We discuss, we meet in the group, and then we physically walk to the adult center. And in the adult center, they just get informed, they get to know who's my new doctor and stuff like this, okay? And the question of course, is it worth it? It's quite a lot of work. It costs as well, and as I mentioned, you don't get famous. So we did a retrospective cohort study. We just historically looked what happened before, what happened with this transition and compliance or adherence program, and published this 3-4 years ago. And the results are, we had 2 groups. The one in pink is transition group without, and on the right one, the orange one, is with. And you see it's not a huge number. Zurich is not a huge center. You see these groups are comparable. There are the 2 things you see now, the living organ donation and the age was significant, not to compare, but I think this not changed the result. And what we saw and what the primary outcomes were is that after the transition 1, 2, or 3 years, you see that there is a better GFR in the group with transition program, and we had less rejection rates. Of course, the number is low, I know. And you see here again the group without transition program ending up in a more severe or higher percentage rejection rate as the one with transition program. So the conclusion, it improves GFR, it reduces the incidence of acute rejection, and I think it's worth it investigating in these children. So to summarize, I think it's transition that is some individual process ending up in transfer. We can't do it better than adults, and adults can't do it better than pediatricians. That's important to realize. And it demands collaboration, and it reflects, by the end of the day, the pediatric quality of work. So let me finish with this slide. I mean, these children and adults, if you ask them, they have one wish. They just want to be normal. They just want to be normal. They want to go play football. They want to go away in the evening with the peers. They want to go in school. Just want to be normal. And I think we should help them to reach this tool and to reach this aim of just normality. Thank you.
Thank you, Guido, for a fantastic talk and a really good overview of transition and how it's done in other countries. Any questions?
First of all, great subject. But one thing, pediatrics do better than adults, I'm sorry.
Pediatrics do better than adults?
We're doing adults better.
I mean, if you say
No. I think that the patients, pediatric patients, when they go to adult, the main thing they tell us is that the intensity of the follow-up by the APPs and the transplant is much more intense. And much. If they don't show up to lab, they're calling them. Why not? Adults, if you don't do it, you don't do it.
Yes.
Number 2 is education. we have an extremely intense education program because they need to have a job. After 18, if they don't have a job, they don't have insurance. And that's one of the most important aspects we lose grasp, is financial. And third is the aspect of cognitive development. As you know, a lot of metabolic diseases impact the brain, and it's mostly a frontal lobe. God forbid I start smoking pot. So we probably should be careful with how we transition. We have lost a patient just recently because parents said, you're 18 years old, you're on your own, you have to take your medication. But the cognitive function due to the MMA was not there. And essentially he ended up losing everything in his life. So thank you, good representation.
Yeah, I mean, this is a special group you mentioned, the group with the mental delay. This is one thing I really could only underline. And the other thing, of course, it is also quite important to have these patients, these adults, to be socially integrated by having a profession. By this is one of the skills they should have. I mean, if you study, you can't wait till then to be to have transition. But you need to have a profession. You have to be settled down in what you're doing, even if it's still being on education. But we also have a group, trying to organize, to help, to make the network that they find a good solution in terms of schooling and profession.
That's important, that even if they don't go to college, they have a skill.
Yeah.
Just before we close, just like a comment from Gronya, who's an advanced nurse practitioner in transplantation at Evelina. I know that he has enormous experience in successfully transitioning children, so I think it would be good to just hear from her and her view on how to successfully transition those children.
I wish we had the magic answer. Thank you very much for that presentation and for raising such an important topic. But I think it's so important to see the collaboration, and certainly the JOS team and us at Evelina London have seen that by collaborating with our adult colleagues, it's definitely the way to, or the direction to move, so that our young adults can see trust between the teams, the adults and the paediatrics working together. And there isn't a quick fix, but it's about continuing and handling the failures as well as the successes on the way. So thank you.
Thank you. I mean, yes, we could learn from each other, as I have learned from the adults, I think they learned from us. And in earlier days, it was always the message, well, you can't care about these patients because you don't know about cystinosis or you don't know about primary hyperoxaluria. But of course they don't, maybe really they don't know because we don't teach each other. And that's, I think, also a very good point, that we collaborate, that we take part of each other's professional life.
That was excellent, Guido. I was just going to ask very quickly, do you have a youth worker? Because I think we've got experience in working with some of the adult teams where I think the youth worker really adds a different dimension, because the young adults actually will tell the youth workers things they might not tell the nursing and medical staff as well.
Yes.
Thank you very much. And with that, we move to the last session of the day, which is a panel discussion on the novel treatments for the recurrence of FSGS. So when we were planning this session, there were 3 people in the country who I wanted to invite to give a talk, and because I couldn't decide, I just decided to invite all 3 of them. So Aoife Waters is going to start the session. She's a consultant colleague from Great Ormond Street Hospital. She's a lead for our nephrotic service and definitely somebody who promotes innovation in our center. Following her, it will be Dean Wallace, who's a colleague of mine, working now in the Children's Hospital in Manchester, sharing his experience. And then we will finish off with our lovely Anya Koziel, who's an expert in FSGS, who's a senior clinical lecturer at the KCL and a consultant nephrologist at the Evelina London.
Thank you, Jelena, and I'd like to say thank you to the organisers for inviting us, and also for creating space for this very important kidney disease. It's probably the most devastating disease I've ever dealt with. So I'm going to just start by highlighting 4 cases that we've dealt with at GOS. And then Dean will take over from me, talking about his experience with preemptive strategies alongside LDL pheresis, and Anya will give her personal perspectives on LDL pheresis at Evelina. So we all know that FSGS is one of the most leading causes of childhood renal failure. It tends to recur in about 50% of paediatric renal allografts. And when it does recur, it's one of the major causes of graft loss in children. And as you can see, this graph here, it highlights that the recurrent group in particular have a very poor 5-year renal survival. And therefore, every strategy available must be at least attempted to try and get on top of this disease when it does recur. So what are the risk factors for recurrence? Well, less than 6 years at presentation, those presenting with a rapid progression towards end-stage renal disease. Some reports have suggested that diffuse mesangial proliferation in the native kidney is a risk factor. We all know that recurrence in the first allograft is associated with 80 to 100% recurrence in the second allograft. And more recently, the lack of identification of a mutation in at least 70 known genes associated with steroid-resistant nephrotic syndrome, it puts patients in the higher risk category. And Anya, you were involved in a very important paper in JASON in 2014, which highlighted the problem with patients who develop secondary steroid resistance. So that's about 10% of cases, as being a major risk factor for recurrence of disease. So the first case is that of a congenital nephrotic syndrome patient who had a mutation in the C-terminus of nephrin, which lies just at the base of the podocyte foot processes. And most of these patients undergo bilateral nephrectomies in our centre. They then embark on peritoneal dialysis. And this case received a living donor transplant, which had a pretty good match. And as you can see, serology was, the donor was CMV negative, EBV pos, and the recipient CMV neg and EBV neg. So very unusually, we saw recurrence in this patient at day 7. And interestingly, we were able to get on top of this recurrence fairly promptly by initiating plasmapheresis, which in our centre we treat with 10 successive sessions of plasmapheresis and then wean that down to thrice the subsequent week and weekly for the last week. And this patient received 8 weeks of oral cyclophosphamide and rituximab, and the disease never recurred again. So I think this case highlights basically that even though we say a negative genetic screen, we all know that the congenital nephrotic patients have been reported to have an anti-nephrin antibody, which can, in a subgroup, cause recurrence. But as you can see here, this was easily managed, and Anya will present a similar case that again was easily managed. But this case does provide evidence that there are certainly circulating factors which seem to be associated with podocyte dysfunction and hence early onset of proteinuria after kidney transplant. And of course, the other lines of evidence have come from the fact that proteinuria in infants of mothers with FSGS due to antibodies against neuroendopeptidase, which lies at the bottom of the foot processes. And you can give rodents proteinuria when you treat them with plasma from patients who've had a relapse. And of course, the remission after plasmapheresis or immune absorption supports the hypothesis whereby removal of the circulating factor seems to help those podocytes recover. And of course, you can have recovery in a retransplanted kidney to another recipient, again suggesting that circulating factors play a major role in the pathogenesis of this disease. So what are the protocols that are available? Well, you can give pulsed methylprednisolone, just 1 pulse over 3 days. Whether you do that successively over subsequent weeks will be discussed in our subsequent talks. High-dose calcineurin inhibitors, whether we do that with oral tacrolimus, oral cyclosporin, or IV cyclosporin. And I've got another case to show you where we did achieve remission with that strategy. As I mentioned, oral cyclophosphamide, plasmapheresis, rituximab, and another B-cell depleting agent like ofatumumab has been described to have effect, immune absorption, and LDL pheresis. So this was a case from a living donor recipient who presented on day 2 post-transplant, having progressed to end-stage renal disease with 8 months of treatment, whereby she recurred by evening of day 1. And as you can see here, in the yellow shows a very fast fall in her albumin. And by day 3, she was in full-blown relapse, so we initiated prompt plasmapheresis. And we did that over, as I mentioned, 10 successive days. And this was associated with a high urine albumin creatinine ratio. We then gave her rituximab, 750 milligrams per meter squared at the end of the 10th successive day. And we left her on oral prednisolone over the first month at 1 milligram per kilo per day, alongside MMF at 1200 milligrams per meter squared per day, divided in 2 divided doses. And we gave her IV cyclosporin the day before she went into theatre. She had a 12-hour trough CSA level of 200 nanograms per mil. And I'd like to just point out that did not prevent the recurrence. We left her run on IV cyclosporin for the first week with levels at least 200 to 350. And then we switched her over to oral cyclosporin for the following 3 weeks. And she was in remission by the 14th day post-transplant. So her baseline creatinine by month 3 was 56, at which point she was on oral tacrolimus. Now, the next 2 cases will reflect what's reported in the literature. So we know that we can prevent or we can treat remission in about 50% of cases, but there are obviously the other 50% who we don't always get into remission. And how can we do better with this group? So case 3 is that of a boy who presented at the age of 8 years. He presented with a colitis and within 6 months was diagnosed with nephrotic syndrome. In October 2014, he had a kidney biopsy which showed collapsing FSGS, and you can see this feature here on the right. He had comorbidities which were treated. These included hypothyroidism, and he was treated with statins for hyperlipidemia, and this was in another centre. He was maintained on combination tacrolimus and MMF. He was given 4 doses of rituximab, 375 milligrams per meter squared per dose over 4 weeks. He then went on a trial of plasmapheresis when he did GFR greater than 60. However, he progressed towards end-stage disease and ended up needing bilateral nephrectomies and was started on nocturnal hemodialysis. So he received a kidney from his father, and by day 2 again had recurrence. The UAUC at time of recurrence was 3,600 milligrams per millimole, and he had basically oliguric, allograft, acute kidney injury within the first 3 days. His creatinine remained high throughout the first 4 weeks of his recurrence, and his albumin was in the low 20s. So his CNI levels, he was on oral tacrolimus going into the living donor kidney transplant because he had IBD. And as you can see here, by day 9 and 10, his tacrolimus levels were between 8 to 10. And he received 3 pulses of methylpred and prednisolone of 1 milligram per kilo per day. And the prednisolone was weaned because he was not tolerating high-dose oral steroids because he was having nightmares and night terrors. So his prednisolone was weaned down. We also treated him with plasmapheresis, and in fact, by day 5 of his recurrence, we gave rituximab with 24 hours of plasmapheresis. The dose of rituximab we gave was 375 milligrams per meter squared. We had B-cell depletion within 22 hours of plasmapheresis. And then we continued his plasmapheresis protocol for a further 5 days and weaned that plasmapheresis to alternate days over the ensuing weeks. But as you can see here, by day 30, the urine albumin creatinine ratio, whilst better, was still in the region of 1,000 milligrams per millimole, and his albumin remained just below the lower limit of the normal range. By day 42, which was week 6, he had a kidney biopsy, at which point his creatinine was 246 and the albumin was 30. And there was no morphological evidence of FSGS, and that's concordant with what we hear in the literature. But on electron microscopy, there was diffuse foot process effacement. So we continued with plasmapheresis, and by the end of the 3rd month, we started to run into problems with fluid overload, at which point he was requiring hemofiltration. And alongside that, we noticed that he was developing progressive head and neck edema. And he had a CT venogram, which we were sorry to learn that he had basically evidence of SVC obstruction. So at that point, on liaison with our transplant surgeons, we felt that it was causing more harm than good to continue the plasmapheresis. And we had a team discussion about what options we could propose, and we considered the use of LDL pheresis. But this patient did not have any good vascular access apart from a left femoral vein, which we did not want to compromise further, and his parents were not keen on the concept of high-dose steroids with the use of LDL pheresis. So the current situation was by month 9, we did a second biopsy. This time it showed morphological evidence of FSGS. We tried a second rituximab at 750 milligrams per meter squared on the basis of lack of chronicity on the biopsy. However, that did not work, and by month 11, post-living donor transplant, we started peritoneal dialysis. And then this is just the last case leading into Dean's talk, just to highlight the situation with a 4th case whereby, again, following progression from the recurrence of a disease in the first transplant, a 4th patient received a kidney transplant, and this also was associated with the immediate recurrence of the disease, which did not respond to plasmapheresis, cyclophosphamide, or rituximab. So I'm going to leave you with this case so that we can now learn from Dean about some preemptive strategies that are worth considering.
Thank you, Anya. Thank you for having me today. It's a pleasure. I realise we're short on time, so I'm just going to blast on through, and I'm going to keep this very heavily clinical. Then I'm going to leave Anya to do the clever stuff. So I work in Manchester, and I became interested in this therapy when I was facing a very difficult case. And I remembered a previous case who's been discussed before that I mentioned, and I've worked with Anya before, and she'd mentioned this potential treatment, and I remembered it when we ran into difficulty with this case, and I followed it and chased it down. So it's no over-exaggeration to say it's a nightmare, recurrent FSGS in a transplant. It's not untransplantable. What do? We go and transplant, of course, but it is horrible for the parents, not only the physiological demands upon the patient, but also the emotional ones as well, and it's minutes to months, all the way from proteinuria to severe nephrosis, ATN, AKI. So what are our options? So you've heard from Anya some of the standard therapies, plasmapheresis, different immunosuppressions. Can we mitigate it by preconditioning, by giving them treatment prior to the transplant to do this? So we looked at our patients over a 2-year period. And we had 4 patients with SNRS, FSGS and biopsy, non-genetic variants having been screened by the Bristol panel, age range 6 to 17 years, and 2 had already previously lost a transplant as a result of their condition. And we preconditioned with the rituximab early, 2 to 4 weeks prior to transplant. We gave 4 exchanges of plasma exchange in the week leading up to this, and all of these children had early disease recurrence at 2 to 26-day range. 3 out of 4 of them went into remission with plasma exchange, complete or partial, quite quickly, and 1 continued on and lost their graft at 5 months after this, after a total of 56 plasma exchange sessions, you know. Got to realise something's not working here. And at 30 to 60 months of follow-up, 1 was in complete remission, 2 still are only in partial remission, with an EGFR range of 45 to 104. We just submitted this to Paediatric this month, so our feeling very much from our centre experience is preemptive preconditioning does not work in these children in preventing graft recurrence. So what is the evidence of dyslipidemia in treatment in nephrotic syndrome? Well, there's lots of experimental data in animal models and human models that actually addressing dyslipidemias reduces podocyte injury. It's known to be directly nephrotoxic in experimental data and clinically as well. And that's all the way from albuminuria reductions to reduction of actually podocyte numbers in the urine as well. So taking this on further, I became aware of the actual subbit of LDL apheresis, and I looked into it. And it's not a new technology. It's been around since the 1970s, but refined over the years. And I think we've all heard of it in the context of familial hypercholesterolemia and the treatments for that. But this is specific, low-density lipoprotein apheresis, a very specific removal, which doesn't affect serum HDL cholesterol levels. It selectively removes LDL cholesterol, VLDL cholesterol, and circulating triglycerides. And I became aware through conversations with the American trial team of a protocol that was being used in an American trial, which has been standardized to put people into remission post-transplant FSGS recurrence. And as you can see here, it's an LDL therapy, which I'll show you in just a second, and it's 2 sessions a week for the first 3 weeks, followed by 1 session per week for the next 6 weeks, a total of 9 weeks and 12 sessions. And at week 3, we begin some concomitant immunosuppression with pulsed intravenous methylprednisolone and oral deriaprednisolone between that for the duration of the therapy with a weaning schedule. And this is what it looks like. It looks a bit more complicated than your standard dialysis machine. That's my day job. I'm mostly a CKD dialysis consultant. And it's a little bit of a difficult thing to put together, but our nurses learnt it with aplomb. We have a standard plasma fractionator, like a hemodialysis filter, and then the plasma, the separated fluid is passed through these dextran sulfate columns, which are negatively charged and selectively attract low-density lipoprotein cholesterol to them and do not remove anything else and return the normal plasma back to the patient. So you can already see the difference between this and plasma exchange, where everything is removed. It's a sledgehammer to break an egg. And we do about 60 mils per kilo, 2/3 circulating plasma volume, takes about 3 hours per session, and is associated with minimal side effects compared to plasma exchange. And as I said to you, has no effect on the circulating HDL cholesterol levels. And that's just a brief graphic showing you the actual attraction of VLDL cholesterol and ApoB lipoproteins. So, on to the cases quickly. So, case 1, post-transplant recurrence rescue. So we had a 5-year, 8-month-old male child who presented at age 2 with steroid-resistant nephrotic syndrome, and he had bilateral sensorineural hearing loss. His biopsy in April 2015 showed minimal change disease. Had we biopsied him again later, before end stage, it would undoubtedly shown FSGS. And he went to end stage renal failure within 1 year of presentation, having demonstrated steroid resistance and second-line agent resistance as well. He went on to PD initially and was changed to hemodialysis with bilateral nephrectomies, and his kidneys at nephrectomy just showed end-stage sclerotic changes. This case was complicated by concomitant child protection concerns, and we'd screened him genetically as well for all the known mutations, which were 70 at that time on the Bristol steroid resistance screen. Finally, father came forward as a living-related donor transplant. And so we preconditioned him at that time, as we did in our centre, with the rituximab and plasma exchange. And his course was complicated by severe hypersensitivity reactions with raised mast cell tryptase and IgE. We thought he was having dialyzer membrane reactions, and we switched dialyzers over, and it still continued to happen. We felt it was possibly plasma exchange related. His first and second dates were cancelled because of infective complications, in part related to the preconditioning immunosuppression. But we finally went forward on the 21st of June 2018. It was a well-matched living-related donor from father, 1-1-1 mismatch, EBV and CMV positive to negative, single artery in vein, and uncomplicated transplant, immediate passage of urine on the table. And we use a standard twist immunosuppression protocol in Manchester, which is basiliximab, TAC, MMF, and a 5-day steroid withdrawal. The aftermath. Day 2, he developed acute oligoanuria and severe. And the ultrasound had shown that he might have a perinephric hematoma, so concerned about an anastomotic breakdown. He was taken to theatre and re-explored, and there was no hematoma around the kidney. But an open biopsy at the time showed that he had a severe ATN and a urine protein creatinine ratio of 800 at the time. And he went on to require isolated daily ultrafiltration in intermittent HD over the next few weeks. And we commenced immediate post-operative plasma exchange in the intensive way that Anya outlined before, and pulsed intravenous methylprednisolone. We'd already B-cell depleted him, and he'd already had plasma exchange before that as well, to bear that in mind. And what this graph shows here is just the plasma exchange schedule alongside his serum creatinine. So you can see that his initial acute kidney injury resolved after a couple of weeks of the plasma exchange therapy. But what I can tell you as well is that when you compare that against his urinary protein levels, we could not switch off his nephrotic syndrome with a plasma exchange. The nephrosis continued. We'd mitigated and modified a circulating factor toxicity, but not really done anything to his nephrotic syndrome. So he's miserable, volume overloaded, ultrafiltration dependent on multiple human albumin solutions, and intensely immunosuppressed. So this just summarises what I've just told you there. I remembered the cases we discussed previously when I worked in London with Anya, and I went about procuring this machine from the Kanika company at their centre in Germany. It took several weeks, and while I was waiting for that, I tried our standard lipid apheresis machine, which removes all lipids from the bloodstream, while I was using that in the meantime, because we have one of those for familial hypercholesterolemia. And we started the liposomal therapy in August of 2018. And just to show you the same graph again where we were, this is the standard intensive plasma exchange, alternate daily, 3 times a week. It's not working. This is the intermittent lipid apheresis we use while waiting for the Kanika. And when we started the Kanika therapy here, and subsequently the high-dose methylprednisolone and oral prednisolone weaning schedule, by the end of the LDL apheresis therapy, although he was still in a nephrotic syndrome, we'd had improvements in his urinary albumin, but we were able to come off all of supportive therapies. He didn't require the ultrafiltration anymore, and he didn't require the human albumin solution. And then we saw, within 6 to 8 weeks of finishing the therapy, this late phase massive reduction in urinary protein levels, and he went on to improve clinically after this and went into a full clinical remission. At the clinic at the moment, he is on tacrolimus, MMF, and 5 milligrams of alternate daily prednisolone. He's relapsed subsequently on a few occasions with febrile illnesses, but each time he is steroid sensitive in this time. So we've taken someone who was completely steroid and CNI resistant and apparently seemed to have induced immunosuppression sensitivity. This case was reported this year as part of a series of 7 cases in paediatric nephrology, along with some of Anya's cases. And our American collaborators have seen the same kind of effects as well. So perhaps the only real original thing I've got to show you today is case number 2 then, because moving on from that, we start to wonder, can we do something different in stopping somebody getting to the point of end-stage renal failure and transplantation? And the major hurdle to doing this is the idea for a paediatric nephrologist to be putting central line access into a patient who hasn't got CKD, who's in a thrombophilic state. And I think that's the hurdle that we've had to mentally get over. However, in this case, it was easier because we had to. So we have here an 18-month-old female who presented in middle of last year with her first episode of severe nephrotic syndrome. She was transferred, volume depleted, severe electrolyte disturbance and acute kidney injury with severe edema. She demonstrated primary steroid sensitivity. She flirted with remission towards the end of the IV methylprednisolone, and as soon as the dose was dropped on oral, she relapsed again. Her biopsy, again, showed minimal change disease and nothing else of interest in the biopsy, and she commenced on cyclosporine as a second-line agent. She couldn't tolerate second-line immunosuppressive therapy agents. She had recurrent febrile illnesses, worsening albuminuria, and worsening edema. And we stopped all suppression in September of that year after a severe CMV viremia, transaminitis, and developing severe EBV viremia, which fortunately the CMV cleared with valganciclovir. But in December of that year, she was admitted with acute pulmonary edema secondary to a rhinoviral lower respiratory infection and ended up with central access because she was requiring so much albumin support and eventually machine ultrafiltration. So these two are quite unusual in that sense. On this slide, I just wanted to show you just the number of acute kidney injuries she suffered during that first period, just because she had such intense volume shifts. You know, her clinical volume status at 9 a.m. was different to volume status at 5 p.m. on a daily basis. It was one of the most severe nephrotic syndromes I've ever seen. And what we did with her, again, we had the central line access already. That wasn't our decision to put that in to start that. It was already there because of her ultrafiltration, immunosuppression, and HAS requirements. So actually, it was a relatively easy thing to think about doing. We'd had a good experience with no adverse effects, and so we felt we could try it on this patient. So you can see what happened there again. Within months of finishing the LDL apheresis therapy, she had monumental reductions in albuminuria to put her in a clinical remission and eventually into a full defined remission with the UPCR, which is in the normal range now. What she did do, again, like the other patient, every febrile illness she got a fever, she relapsed immediately. But fever, short course of oral methylprednisolone, responded. Fever, relapsed, responded this time. Fever, relapsed, responded. And just in recognition of the multiple episodes of steroid therapy, we reintroduced tacrolimus to reduce the steroid burden. And on this occasion, it seemed to keep her in more prolonged remission, and she had a further febrile illness, relapsed, and has come back down now. So at the last clinic review, this child has got a urine protein creatinine ratio of 23. She's got a plasma creatinine of 20 and a serum albumin of around 30. She's been up to 35 with a minimum tacrolimus level of 3.1 micrograms. So by using this adjunctive therapy, we seem to have demonstrated in a post-transplant rescue, in a pre-transplant episode, that we've been able to induce immunosuppression sensitivity to these patients. And certainly we seem to have stopped somebody going into end-stage renal failure, certainly now at least anyway, and all the socioeconomic and physical factors that go along with that. So they're my two cases for the moment. I'm just going to pass you over to Anya now, who's going to have a look at FSGS itself and some of the evidence for these therapies.
Thanks, Dean. I think both Eva and Dean have very much illustrated how difficult these patients are. And really, the ideal situation is that they never get there in the first place. So very much the practice in our centre is to try and do everything prior in the clinic when we first get the nephrotic syndrome. We first get these patients and try and prevent them from going there in the first place. I think actually also these cases and the four I'm about to present very much illustrate this is an umbrella diagnosis, and I think as clinicians we need to be very conscious that we don't force a protocol onto the patient, we adapt the protocol to the patient, we don't do it the other way around, because they're all slightly different. And I think unfortunately, just like pre-transplant, post-transplant, there's probably a number of different etiologies involved. So the patients I'm going to present had all gone through all the things that Dean and Eva have described already. They'd gone through all the conventional treatment strategies and everything had failed, such that when they came to us, they were probably about between 4 and 6 months on plasma exchange, plus or minus rituximab, plus or minus cyclophosphamide, and PCRs were still in the thousands. Nothing was really working. And they were very much resistant to all treatments. Our first patient actually was probably the most successful one. She was, by the time she came over to us, she was about 6 months post-live related. She'd had plasma exchange, she had a plasma exchange resistant FSGS recurrence. She'd had cyclophosphamide and rituximab, both ineffective. She was kind of potentially a candidate for circulating factor disease. There was some vague report of a partial response to prednisolone, possibly putting her into a secondary steroid-resistant category, but it was really difficult to tell. But certainly, from early on, she was then multi-drug resistant. And in common with some of the other cases, she had no detectable podocyte gene mutation. I think that's always a bit of a warning. If you have a patient, even if you have a patient who's multi-drug resistant, including steroid resistance, you cannot pick up a gene. Always worry about the fact that there is a risk, increased risk of post-transplant recurrence. As she'd been through everything else and everything else had failed, the family requested liposorber. And so I got in contact with JJ Zaretsky, who I know quite well from previous life, and got in touch with Kaneko and brought it over. And we actually followed the rescue protocol that Dean described, so very much twice a day LDL apheresis, so switched directly from plasma exchange to twice a week LDL apheresis, followed by a 6 weeks initial course. We didn't actually give quite as much steroid as the protocol because I was a little bit worried about it, and she was also marginally hypertensive, and actually the only downside of the LDL apheresis, you cannot use ACEs, although you can use ARBs. So that's where the adult physicians struggle a little bit with it. However, you can use losartan, you can use that group of drugs. So we followed the rescue protocol, but we used 1 milligram per kilogram of prednisolone. But we did do the sort of 20 milligrams per kilo of solumedrol for the first 6 weeks. And this is really her chart. Again, because we've gone through these cases a bit so far, you can see quite clearly that her protein creatinine ratio started to decline at about 5 weeks. And that's one thing you do see. You've got to sit it out for 3 to 4 weeks before you see a response. I don't know why, but it may be that you've got a pool and need to reduce it below a critical level. Arm-waving hypothesis, I'm not sure, but and then the peaks that you see there in the protein creatinine ratio are all infections. So in common with Dean's patients, infections do set it off again. However, we persevered, and in fact, I really set a very arbitrary baseline of I want a protein creatinine ratio down to below 300. So that's how we got to, and actually weaned the steroid quite rapidly thereafter. And in fact, again, protein creatinine ratio continued to decline, and now almost 2 years down the line, her protein creatinine ratio is about 15, kidney function, transplant function is completely normal, albumin's normal, and she's going out leading the life of a completely normal little girl. Our second patient was again a patient that came to us, I think it was probably about 8 months post-transplant. Again, plasma exchange been marginally, she had responded to plasma exchange in the sense that it did improve her albumin, did improve her protein creatinine ratio, but the moment it was stopped, it shot straight back up again. So this was palliating, but not curative. There's an additional problem of bone marrow kind of malfunction, normal bone marrow biopsy, but just some sort of issue that nobody really got to the bottom of. So she was GCSF dependent. This meant that she could not really have cyclophosphamide or rituximab safely, and in fact had rituximab prior to going into renal failure and had been completely ineffective, and she reacted to it very badly. Again, she was not an obvious candidate for circulating factor disease. In fact, she'd been completely steroid and multi-drug resistant, and she had a primary FSGS, which was, from the initial biopsy at 18 months, looked very much like it might be a sort of developmental disorder. In fact, we chased the genetics very, very hard, didn't really come up with anything, because there was various features such as embryonal glomeruli, tubular changes that really did look much more like a finished type or something. So we were I think there was a big surprise when she did relapse post-transplant. And again, at that stage, there really wasn't anything else on offer, so what do? We try liposorber. The first time we tried it, she got infection after infection after infection. We abandoned after a couple of months. It was just hopeless. It probably started to work, but then she was in such a state that we just had to give up. So the family went back to their home country, went onto a course of plasma exchange, got the PCR back down to about 1,000 and returned. This time round, we had more challenges. We had liposorber started, but then the poor girl got BK, we reduced her immunosuppression, she got acute rejection, and then repeated infections. So in the end, we were propping her up with a cocktail of azithromycin and immunoglobulins weekly, as well as modulating immunosuppression to prednisolone and MMF. And because of that, really, I was a bit reticent to give her any more additional prednisolone. So we restarted liposorber without the additional steroid. And again, more infections. So again, because we had nothing really, and we do learn from our patients, you know, when you're up against the wall, and what do you do next? So what we decided, the only way we could do this was possibly to either increase the frequency of liposorber, which we did, and that had some sort of impact. And then I thought, well, let's try a bit of plasma exchange in between, really for no good scientific rational reason, and that did the trick. I think the only thing that I can think of is that LDL is a shuttle molecule within the lipid pathway, so we're possibly taking out one thing that's water soluble, one thing that's lipid soluble, but equally it did work. The combination worked a lot better, and then she had that for 4 months. They had to go back home, and in fact she's continued to improve. She's now down to once times a week plasma exchange, and very well, and the next step will be to stop plasma exchange altogether. And again, there seems to be a delayed response. You know, we stopped the LDL apheresis some months down the line, things were sustained. This is again her PCR. I don't have the data from now, but certainly the first arrow was when she started liposorber, then we had to stop, and then we started again, and then the red arrow is where we started liposorber plus plasma exchange, and she just continued to improve. Creatinine is now very good, and the plasma albumin also improved. Our third patient, again, was a bit of a surprise when she relapsed post-transplant, completely multi-drug resistant, and her initial biopsy showed diffuse mesangial sclerosis, which traditionally is a congenital nephrotic syndrome. No gene mutations, no family history. Again, I've whole genome screened her, I've whole exome screened her. I've got mum and dad, I've got a trio. I can't find anything. It's possible it's in the non-coding region, I don't know. But anyway, she had a deceased donor transplant, and again, relapsed shortly afterwards, and then was at 8 months plasma exchange resistant on 3 to 4 plasma exchanges a day, which really is not a life. She had an initial response to liposorber, but unfortunately, I think over time, it's a complex social situation with the family, and we were reduced down to 1 times a week liposorber, which certainly for the initial period was as good as 4 times a week plasma exchange. She got her life back. The additional compounding comorbidity is this little girl became morbidly obese, and certainly on repeat biopsy she has FSGS, and I think probably one of the secondary causes of post-transplant recurrence is actually a metabolic syndrome, and I suspect that's probably the bigger component here. So at one point we were using liposorber to keep her cholesterol down. She's now come off liposorber, she's sort of lingering along, but I think she's certainly one patient that we would consider preconditioning were we to transplant again, because she recurred once, she'll do it again. One thing we were very keen on trying to do is give cyclophosphamide on the premise this must be some sort of gene mutation. Is this an antibody-driven thing? But the family refused, so until it was really too late, so we couldn't go there. Our fourth patient is very much like Aoife's, MPHS1 mutation. First graft, not a problem. Second graft, she relapsed. Again, we presume this is an anti-nephrin antibody. It's very difficult to measure them. And I also presume that because she had a life related with the first transplant, so likely what's called a haploinsufficient graft. So one of the nephrin proteins would have been normal, one would have been abnormal because her father would have been a heterozygote for the NPHS1 mutations that she has. And again, we tried plasma exchange, didn't really work. Rituximab didn't work, but cyclophosphamide was very effective. And at the time, we consulted the Finnish team that pretty much described this. And their attitude is very much, do what you can, and something might work. So again, I think it just illustrates how hopeless these patients can be. And you just got to try what you can, because you have no other option. If you don't treat, it's not going to end well. So really, very much the concept of post-transplant recurrence at the moment is that you've got your genetic, which are likely low risk, and you've got your circulating factor, to which I suppose the secondary steroid-resistant patients would fall into. But increasingly, it's not really that simple. So I think now very much the thinking is becoming that you've got the genetic patients, you've got the circulating factor, but there is an intercept of multi-drug resistant, yet relapse post-transplant. So presumably there's some predisposition to nephrotic syndrome, but on top of that, these patients, for whatever reason, are multi-drug resistant. There are a number of potential therapeutic targets, pre and post. I won't go too much into the science because we're probably running out of time a little bit, and I think it's a forum for discussion, really. But when we look at all the sort of things we throw at these patients, there's a lot of different parts of the potential pathogenic pathway they may work. And they're probably hitting the pathway in a number of different areas could be successful, but I think also because we've got a heterogeneous population, what works for one patient may not work for another, and you've just got to go through it in sequence and see what you can do. Comparisons with abatacept. This is a patient that abatacept is very commonly used in the US. Unfortunately, it doesn't seem to be too successful, and this is a patient who had abatacept but then went on to LDA apheresis, and that was successful. Again, this is from a paper. Very few people, bar the original people who published the abatacept paper, have been able to recapitulate the data. The other molecule of the moment at the moment is SUPAR. I mean, for me, this very, very first slide is a problem because actually, as we know, minimal change and FSGS are probably on a spectrum of disease. So you'd expect the SUPAR to be raised in minimal change as well as FSGS. So quite how the data was done, nobody really knows. However, what is reliable is that nobody can recapitulate the data. And in fact, there's some people do use protein column A immunoabsorption, and they have induced remission, and SUPAR is not removed. And in fact, SUPAR expression may be just non-specifically increased in the setting of a low GFR. And that's really, I thought at this point we should open it to discussion.
Thank you really to all three of you, Aoife, Dean, and Anya. I know there's probably a lot of questions, but also a lot of colleagues who might want to share their experience. So it's now open for discussions. Yes, Ian.
Well, I've just been live streaming with Ben Reynolds in the bus. So we've had 5 cases just recently. Unfortunately, the first one, immediate graft loss, almost like the case you described. We've treated 3 of them with ofatumumab, 2 of which were very successful. They've now got good PCRs, normal albumins. The most recent one, he relapsed almost immediately. We plasma exchanged them, we gave him ofatumumab, and interestingly, he has become steroid responsive with regard to his function, but not with regard to his albuminuria. And the question that I had was, do you think that this child, after being steroid unresponsive, now being steroid responsive, would benefit from the liposorber? And if so, how much does it cost?
It's cheaper than ofatumumab. I don't know, can you get it? Because I've actually got 2 patients and I'm having to do named patient basis because Novartis has pulled it out of the UK. So you're a very lucky man.
We've got a stock. I think we've got five vials left.
It's
Our
brilliant. It's far better
pharmacist
than
has stored it.
rituximab. But I think that's, if you're stuck there, I'll give it a go. With the caveats that Dean presented about the problems with you've got a patient who's potentially a bit hypercoagulable, you've got to put a line in. But I think, because I'm a bit old and I've been looking after these patients for 20 plus years, in the days before MMF, before tacrolimus, before rituximab, ofatumumab, all the things that we have in our arsenal pre-transplant. And I have recently had a patient who actually has done very well on ofatumumab, but developed anti-rituximab antibodies. And he was behaving just like in the old days, where you absolutely could not stop this disease. I think, unfortunately, if you can't stop it, there's only one outcome, really, and they become secondarily steroid resistant, they just stop responding, and they end up with a transplant recurrence. So I suppose the choice is, do you do it just before transplant, or do you try now? And I think it's a very well-tolerated procedure. It's cheaper than plasma exchange. I think off the top of my head, I think plasma exchange was something, we costed it all up. It was something like £800 a session. This is more like sort of 400 or 500. Depends who you look at, because and how many you do. But Canica is always, they're very approachable, they're very easy. Pre-Brexit at least, they'll come over with their little machine from Germany, and they lend you the machine. You don't have to buy it, and then it's just the tubing, the cost of tubing that you have to pay for.
Who did the training?
The Canica come along and do it. Yeah. Yeah. The guy comes with a machine and teaches. He's great, little man with hands.
And your protocol for doing it, so it's 3 times initially, twice a day, and then what do you do thereafter, once a week?
Once a week, 3 to week. Now, that's the standard US protocol. And again, that protocol's been made up out of the earth pretty much based on some floating around protocols from previous trials. The biggest data pool comes from the Polaris trial in adults, which was done in Japan, and it was 44 steroid-resistant frozen episodes treated with a very, very similar protocol. A very similar protocol, and they reported kind of 40 to 60% partial and complete remission responses. And so that's why that protocol was adapted and abbreviated from that with some steroid as well. To your question, I have no experience of ofatumumab in this situation, but I'm hearing good things about it. We actually did a 3rd liposorber in the northwest at Alder Hey Children's Hospital. We transplanted the patient who recurred literally on the table. They took him back after a while and wanted to do it themselves, even we just started doing the session. And they did it alongside plasma exchange, like with ofatumumab, and he went into full remission after a little while. But again, I suspect Canica are going to do individual costings because it's not procured by the NHS at the moment. But we had a similar experience whereby it came out no more expensive than the session of plasma exchange the patient was already committed to.
And the other thing I was going to say was, is there any place for us pulling the genetics for the patients that we've all seen with recurrence and actually looking at whether we do whole genome sequencing and linkage studies in them?
Probably, that's for me. That's actually what I've done.
Yes.
Yeah. That's what. So I have actually whole genome sequenced these patients, but I've only got 5. And so the more the merrier, because actually, as with anything in life, this is a rare disease with rare complication of rare disease. So, and actually the most important is to also look at patients who don't recur post-transplant, which are generally the pure genetic types. And also to have the trios, have the parents and the child, because there's usually some difference, some subtle difference. But these are all these are all, so we've screened clinically for the sort of 70 genes on the SRNS panel from Bristol. But I've then gone on to do whole genome sequencing. What I've restricted at the moment is looking just at the exome. So I've been looking for protein coding variants, but there's nothing to say that it won't be outside that. Because certainly in the protein coding bits, we haven't really found anything robustly.
And then alongside DNA, we're also interested in RNA, plasma, and any tissue that you've biopsied. And in particular, the JAK-STAT pathway at the level of the tissue we're very interested in pursuing.
Well, if you send me that stuff.
Yeah, yeah. And I just had a quick question back to you about the rationale for ofatumumab over rituximab.
So that, I think that was fortuitous. It actually came from a discussion with Kate Tyerman and Ken at one of the, I think it was at the CSAC meeting. And it just escalated from there.
Okay.
And you give it once to a patient and it works, and you then think this is the epiphany.
Yeah. Because there's, were you at IPNA this year? I mean, there's, I guess, a lack of consensus amongst us all that it is a superior B-cell depleting agent for recurrent FSGS. Again, there's been a trial that's had to be terminated early in Italy, showing a lack of efficacy with, between 13 patients. The argument, however, is that it was a lower dose, 1,150 milligrams per meter squared. So a second question I had for you is what dose you used, if you can remember?
I don't know, I'll find out.
Yeah.
The other thing is, though, as you said, it's a heterogeneous disease.
Yes, yes. Okay.
B-cell depletion before the transplant. B-cell depletion is not the only answer. Yes. So I don't actually just plasma exchange that didn't work for the patient side.
So I had a question to the three of you about exactly that. So on rituximab, there's efficacy in some patients. There is lack of efficacy in others. I think the Mayo did a study many years ago looking at rituximab pre-transplant in terms of recurrence, showing no significant effect. It'll deplete your B cells very quickly, but we know that it has minimal effects on your antibody levels. So it may have some benefit in terms of T cell activation. Not quite sure what the relevance of that is here. And it's being used in the context of a number of other therapies at the same time. And if you look at the antibody incompatible transplant protocols, many of them included rituximab early on, and it's come out because people thought, well, actually, are we sure that it's doing anything? And the answer was probably not. So do you think we can justify using B-cell depletion, and if so, why?
I must admit, it's never worked in our hands, so I'm not sure. I mean, ofatumumab has a higher binding affinity because it's a humanized monoclonal, so it's actually got better binding affinity to the receptor. It binds deeper, it binds longer, it's got a different epitope. So I can see why it works in the steroid sensitive. I think the only justification for rituximab is if you've got the occasional patient that's secondarily steroid resistant that you've just missed because the history is incomplete, it's a late diagnosis. So these guys are probably a B-cell driven disease that attacks the podocyte. And if it all goes horribly wrong, you end up with a post-transplant recurrence. But I think that's the only justification because we did, I think the last time we had apart from this multi-drug resistant, the last secondarily steroid resistant patient we had that went wrong was about 2004. And she did respond to rituximab before. I think Chris did some heroic protocol with plasma exchange, and you may know the patient. And she has never relapsed again, having relapsed on the table with the first graft in 2005. But that's the only instance I can think where it worked. But I don't know the details because it was before my time.
Well, I guess the one thing we do know about it's incredibly effective in the pre-transplantation setting for steroid-dependent nephrotic syndrome. So it's one of the best drugs we have to prevent recurrences and recurrent relapses. And then just the only other thing to say, I guess there's two papers, you were part of one of those with Andre, where we know that tissue-resident B cells can be a source of interleukin-4, which stimulates JAK-STAT, and whether we're using enough of a dose. So, for example, in lupus, Steve, you might want to comment on this, where you use 2 doses 2 weeks apart to get good tissue penetration. So maybe we're not using it enough. And then just a third point, Nizam, I completely agree with you about the ABO-incompatible transplant setting, because what was really interesting for me to learn as a medical colleague was in the context of an anti-B mediated post-transplant rejection. Even though the patient had been preconditioned with rituximab, clearly those memory B cells were still able to come out of nowhere and generate an anti-B. And I suspect that's what's happening in recurrence as well. So a multi-pronged approach is what's advocated by Virginia Savin, which we do. We remove the circulating factor, we target the source. Whether we're targeting the tissue-resident B cells enough, we don't know.
I was just going to say to myself, I'm a bit conflicted. I think we've got a bit of cognitive dissonance because I don't think the literature is there in steroid resistance for rituximab worldwide, but there are clearly some people it may do something for. So why would we think it would be effective in the most difficult cases going towards transplant? I don't know, but it feels biologically plausible, and we don't know if this is just B-cell mediated circulating factors.
So Jelena knows I always misbehave, so I'm going to be the devil's advocate here. That protocol that's put up with Zaritsky had 20 milligrams pulsed intravenous methylprednisolone weekly. That's equivalent to 25 milligrams orally, or about 3.5 milligrams per day, in addition to your 2 milligrams per kilogram oral. We do not use, and that's for 6 weeks, we do not use those steroid doses for lupus nephritis, vasculitis, crescentic nephritis, and here you are using them for 6 weeks. And I hear you said that you didn't want to and you reduced them. But how do we not know that it's just the steroids and we're not using enough steroids for higher dose?
Case 2 didn't have steroids. They didn't have additional steroids. It was case 1 where I reduced it. Case 2 didn't have any additional steroids.
So I think the protocol has to change. It's too steroid
The reason that
toxic.
was developed is that the original FDA protocol actually was, so this is the rescue protocol. So the original protocol was developed without steroids. So JJ got all the patients that had failed the first protocol and then did a rescue protocol where he added in steroids as well. And that's what happened. So when you're faced with a very high-risk patient and you think, do I have 9 weeks? That's why, I suppose, with the first patient, we ended up doing steroids. But the second patient, we couldn't really give steroids, so we didn't, and it still worked. Whether that's a good enough answer, I don't know. Again, 4 patients, or we presented, 6 patients. Rodney's got some in Southampton, there's 1 down in Plymouth. You know, there's 10 patients in the whole country. Small N number.
I shared Steve's concerns about the steroids. The patients
Tolerated it rather well, should I say. There was some hypertension that was relatively easy treated. But most of these patients have been through 5 doses of 15 to 30 milligrams per kilogram of pulse methylprednisolone as part of the original protocol, and then weaning down steroids after that. This wasn't massively dissimilar to the original onslaught of immunosuppression. And if we felt we'd done enough to sensitize them, we felt that we just had to flood them to get them back. It didn't feel, on risk-benefit, it felt like the right thing to do. And also, the problem with the literature in this entire field is it's so muddy, and the amount of protocols and immunosuppression regimes is so different, and there's such clinical heterogeneity in the patients, you almost can't compare one study to the next. The adult studies include IgA, HSP, C3, nephrotic syndromes, and it seems to have some general effect by treating the dyslipidemia. And so we thought, if we just compare ourselves with the American trial data and harmonise our protocol as much as we can with them, we'd have something meaningful and comparable, even if it was only small numbers, which all of this will be.
So did you give the 5.5 milligram per kilogram per day? Did you do that over 6 weeks?
We gave 20 milligrams per kilo pulse methylpred from week 3, once a week, so 6 doses of that, and we gave 2 mg per kg, near enough random. Yeah,
So
yeah.
5.5 milligrams per
Yeah, yeah, we did do that. Yeah.
Can we have just the last question from Antonia?
I have one comment and one question about the rituximab. We had the best result in the child who didn't get rituximab. He came into remission. He came into remission with plasmapheresis, immunoabsorption, no steroids, MMF, tacrolimus, and ACE and ARB. And the others 3, they all had rituximab, and we didn't achieve remission. But my question is, when did you start with ACE and ARB in all your patients, or because early after transplantation?
I started after the therapy had discontinued. I felt it was too much of a risk of bradykinin release syndrome at the time. But you can have, I think, an ACE dose within you have to stop it 24 hours before the apheresis session, and you can go back to it. I didn't see the point, and we just started it afterwards. But you can use ARBs apparently. Yeah.
We haven't used them.
So also not before the LDL? You didn't give the ACE and O?
I think one of the patients had been on a maximal dose ACE prior to trying this. It was, it was like shoveling snow in a storm. It did nothing to the proteinuria.
Is there any difference between your experience as a live donor and deceased donor? Because Transplant would never do a living donor on this type of patients. Just by experience, we would never touch a live donor, much less.
I'm gonna draw it to a close. I know, Anne-Marie, you're desperate to get in. I suggest we keep the discussion going on the way to the restaurant for those of you who are coming. But if we don't leave soon, we're going to miss our table. There's 2 or 3 things to say to you. Reminder of your feedback forms. Please fill those in. Tomorrow morning at 8 o'clock, for those of you who are interested in research, we have a research breakfast. So we have breakfast plus research. So you can discuss various ideas, projects. The idea is that we've got a number of experts from around the world, and we thought we'd use the time to have a chat about that for about an hour before we start. And for those of you who are coming to the meal, Dr. Marks, for those of you who are coming to the meal, we will be leaving here shortly, and Hannah's going to guide us over there. So I think it's been a fantastic first day. I hope you've enjoyed it as much as I have. And I'd like to give a big thank you to all the speakers today. So thank you very much, everybody. Thank you.